Sorry for the delayed start. I'm Nicola and this is Endesh, and we will be your hosts for this conference. As you will have noticed, we're a little bit behind schedule, so we will be about 20 minutes behind for the morning, so adjust your schedules accordingly. We'll run through a few logistics before we do the official welcome. So first, if you haven't already, please download the app. You will need, even if you're a face-to-face participant, for some of the activities. The code, if you don't have it, is MSF PD24, and you'll find the Wi-Fi code on the wall here. If you need any help during the conference, look for someone with a beaded lanyard. They will be able to help you. And not just because we're running late, but we are on a tight schedule anyway, so please be punctual coming back from breaks. And speakers, please try and stick to time. And I'll hand over to Endesh for some more logistics.
Yeah, so good morning again. Yeah, as you probably see on the news, the rain has been a bit too much in Nairobi, around Nairobi, and traffic might be affected. Just for you to note in your logistics planning and everything. The emergency exits for this hall. There's one on the left and another one on our right side, and you'll find them. The bathrooms, as you leave this hall, they are on the left side. And we have posters on your right side, and then as you go along.
Hopefully, for those of you that have already downloaded the app, you've had a chance to have a look. But there's a lot of information on there that will be really useful during these 2 days. All the online posters are on the app. That's maximum volume. All the posters are on the online platform, and there are physical posters here, but there's more that aren't printed that are online, so make sure you do check out all those online posters. We have our speaker bios. You'll find all the participants for the conference face-to-face and online. You can message other participants if you would like through the app, and during the sessions there will be active participation, so quizzes and other things, so please have your app open during the session. And really importantly, you can ask questions to the speakers. So whether you're online or in the room, you will have that opportunity. If you're online, there's a Q&A tab. If you put your question in there, we have someone in the room that will monitor that and ask the question on your behalf. So please do participate. There's also a resource library to have a look at. So yeah, the app will be very useful during the sessions. All right. So yes, it's MSF PD24, all in lowercase. Yeah. All right. So now we will hand over to our. Oh,
sorry. Just one more thing. We have the. In case of emergency, we don't expect so much, but we have an ambulance outside. Lucia, are you there for help? Yeah, she's there. Sorry.
All right. And one last thing. Some of you will have received paediatric guidelines as you came in. Unfortunately, there aren't enough for everyone to have a copy, and the intention had been for people coming from the field and returning to the field that you take a copy of the guidelines with you. So if you were given a copy of the guidelines and you're not going directly to the field, we kindly ask that you return them to registration. So people that we really prioritize those going to the field to get them. I wish everyone could have a copy. In time, that will be possible, but for now, please, if you're not going to the field, if you can kindly return them. All right. So now I would like to hand over to Roland Kaya to officially welcome you to this Paediatric Days conference. Roland has more than 20 years experience in MSF and now is the General Director of East Africa MSF. So we welcome Roland to the stage.
Good morning, everyone. I hope you are well. And for those who have come from far, I hope you had a nice travel, smooth, and your first night in Nairobi was okay. My name is Roland Kaya. I'm the General Director for MSF Eastern Africa, based in Nairobi. On behalf of MSF Eastern Africa, I would like to welcome all participants, in person and online, in your different titles, positions, roles, and responsibilities. We would like to welcome more specifically MSF Spain and MSF Sweden, who are the main sponsors of this event. And also a specific welcome to a pediatric working group, which has been working endlessly to improve the quality of services we are offering in the area of pediatric. As we speak now, millions of populations are affected by the extreme weather conditions in Kenya and also in the region, opening the gate for devastating short and long-term emergencies. For the last few weeks, the situation has worsened, and it's not getting any better, according to meteorological predictions issued by Kenyan authorities. This has led to major or preempting major humanitarian emergencies. As we know, children under 5 are always the default victims, and they are the most affected age group by any emergency situation. MSF stands together with everybody who are directly affected and will continue to support by continuing with assessment of the need and organizing the response accordingly. For today's event, we are all in this room in person or online, attending to contribute to the achievement of the main objectives of the event. Some of us are certainly familiar to this. However, many of us are attending for the very first time. Since 2016, this event has brought together world-renowned pediatricians, academia, and clinical experts, MSF staff, both international and locally hired, and also representatives from different organizations, to present, debate, and discuss the specific challenges faced in the humanitarian, pediatric, and identified problems, and to try to identify potential solutions. We have gone through the readings related to this event. However, it's important to remind all of us that children are at the core of MSF activity around the world. Often being vulnerable, and also the age group which is always next to women, the most affected. In MSF health structures, in 2022, almost 6 million children under 5 years old were seen as outpatients. 600,000 more have been seen as inpatients and received treatment. In the same year, we are talking about 500,000 children who have been treated for malnutrition. With the inclusion of children up to 15 years old, pediatric patients represent more than 50% of MSF activity globally. The under 5 mortality is always one of the most important public health indicators. And it's important to mention that substantial global progress has been made for the last 30 years in reducing children-related mortality. And this has dropped by more than 60% since 1990. Despite the significant number of children continue to die daily, half of whom are neonates. In 2021, 5 million children under 5 years old lost their lives, meaning every day more than 13,000 children are dying. This is an indication that we are not yet where we should be. It means that we are still lacking high-quality care in many countries around the world, mainly in developing countries. Scientific researches are taking place, mainly in high-income countries, in this area of pediatric care. However, the recommendation related to these researches are not always applicable in many settings. To bridge this gap, the best practices must be continuously adapted to different contexts to deliver aimed high-quality care to our children. And this is one of the core points of reflections taken by the MSF Paediatric Days. The 2024 event will focus on some specific topics, mainly the vaccination and vaccines preventable diseases, pediatric HIV, and nutrition. It's important to highlight that the MSF Paediatric Days are open to everyone interested in improving neonatal and pediatric care in humanitarian settings. So it's not only specific to nurses and doctors who are specialized in this area. All of us should continue reflecting, contributing, participating in all events related to pediatrics, to give it a multidisciplinary tone. This way, we hope to find more innovative ways to manage the challenges we face in the neonatal and pediatric care in MSF. Thank you for being part of this initiative. Your contribution during different sessions will be essential for the success of the event and also for the quality of the outcome. We wish you a successful discussion, pleasant and safe stay in Kenya despite the extremely heavy rainfall. Again, we thank you all and welcome.
Thank you, Roland. I now have the pleasure of inviting our inaugural speaker for the conference, Professor Ruth Ndwati, to the stage. She is a very impressive woman. She's a professor of pediatrics and child health at the University of Nairobi, as well as being a consultant pediatrician at Kenyatta Hospital. She's done extensive research in HIV, health policy, guidelines, medical education, and was also named as a pioneer or trailblazer woman of Kenya. So thank you, Ruth.
Thank you very, very much. Thank you for inviting me to this forum. This is a Pan-African forum. In fact, it's an international meeting right here in our backyard in Nairobi. Thank you very much. Now, please, the slides. I've titled my presentation, Nurturing Care for Children Living in Humanitarian Settings. And some of this, what I'll say, you probably know better than I do. But since it's a point of reflection, it is good that we do that. And as I start, I want to draw your attention to this document. Nurturing Care for Children Living in Humanitarian Settings is a UN document, relatively new. This concept of integrating nurturing care into everything we do for kids is, there's been a big push from around 2018, and it's just percolating down to the ground now. So I hope as you reflect on all the things that you would do, that you'll bring this on board. Now, please, I move the slide, sorry. I start off first by my set of slides. Please do the slides for me. Just keep going. Just keep pushing the slides for me, please. I start off by picking some slides out of a UNICEF presentation that is on response in humanitarian crisis, just to set the pace that we understand what we're talking about. We're talking about situations where there's danger. This may be a natural phenomena, or it can be a human-made crisis. And then we talk about risk, defined as exposure to danger, and giving you the probability of having harm. And then we talk about vulnerability, which I think is the main thing that we deal with. Populations that have diminished capacity to deal with the problems that they are facing, and the impact on them. And these problems may be man-made disasters, or it can be like now in Kenya, we're having rains like we haven't seen for more than 30 years. Next slide, yeah. Now, a disaster is a situation which overwhelms the local capacity and needs an international response, for external assistance. There are usually challenges. Nations, governments have challenges in deciding whether we call it a disaster, because when a disaster when we call a situation a disaster, it means that we are asking for resources externally, but also with the external resources comes external supervision of what is going to be done. And in that process of that discussion and waiting, the people who are on the ground who are vulnerable continue to suffer. And then, of course, we have definitions of what is a humanitarian emergency. There's a critical threat to health, safety, security, and well-being. We've just come out of the COVID times, and remember the challenge that there was, even at the level of WHO, making that decision. Are we having an emergency? Are we not? What do we do? And we all saw what happened when that evolved, that crisis evolved. I think the most important thing is always being prepared for emergencies. Anticipate that something will happen. And some of that emergency preparedness is the risk and vulnerability mapping, early warning systems, contingency plannings, where you have governments that function normally, they have regular service, their standard service that are able to give you early warning. And your regular demographic health service can tell you where there are problems. So when there's a crisis, you know where things will be worst. So having that understanding of where you're working. The need for standby capacities. This, I think, is a very difficult thing. And I was in Nairobi. I was a physician practicing at Kenyatta National Hospital when we had that horrible terrorist attack on the US Embassy, and more than 5,000 people hurt. People were being rushed into the hospital. But very fortunately, we had a leadership that was prepared. Our hospital had supplies for emergency response that carried us for about 6 hours before we now started getting support from UNICEF and other agencies. There was a locked cupboard in our emergency room with the supplies we needed, syringes, blood-giving sets, you name it, all the things that you need in sutures, etc. And we also had a team, so we immediately moved to do what was needed to be done. And then, so this is the list of the things that you need to have. And in planning, and maybe you're aware of this, I wasn't aware of this until I was working with my colleagues from the UN, is that the preparedness, the planning, there's the planning of something that might happen in the future. There's planning when there's imminent danger. The meteorological department has said we're going to have a rain, there's a cyclone heading towards you. And then there's the operational planning on the ground as things are happening. And we need to develop these skills. These skills are not routine skills. They're not routinely taught well in medical school settings. So these are skills that you need to develop as you go along in your career, because you might find yourself, you're the medical officer in a little health facility. Suddenly, you're the team leader to respond to a major crisis, a major emergency. Now, this picture is from 2017. There's the global burden of disease studies, and they periodically post these things. And you can see that sub-Saharan Africa has the highest burden of disease globally. So when we have and this is based on disability-adjusted life years per 100,000 population. And what you can see is that even when we don't have a humanitarian crisis, we are in a state of crisis, chronic crisis. We have the 70% of people living with HIV are living in this East and Southern African region of Africa. We have a crisis. We have issues around pneumonia, TB. Right now, multi-drug resistant TB is evolving in our region. And we have mental health issues. We have cardiovascular disease. When you have a humanitarian crisis, these problems don't go away. They're just part of the response. They are part of what we need to respond to as well. Children, and I'm glad your head, the East African head of MSF, has highlighted the issue of the children. I was reading the literature, and they talk about 29 million children born in conflict-torn regions of the world. That was in 2018. And since then, there's been more conflict regions. You have the stuff going on in the Ukraine, you have the stuff that's going on in Middle East, and we have all the ongoing problems in the Sudan, and so there are very many children who are being born in that situation. And so when you have a conflict, people move. The constant threat of displacement destabilizes individuals. Families are separated. There are issues of limited access to health services. Even when our friends in the developed world offer opportunity for migration, say like you have large groups that migrated, for example, the Ethiopians went to the US, the Somali people also went there, into Canada. When you're there, there's also a sense of isolation, the issues of language, the lack of the networks that you normally have when you're at home, so that even if you have a really fancy hospital there that can offer the state-of-the-art medical care, this person who's displaced do not necessarily access those services, and the children are most affected. The estimates are that in this humanitarian crisis and this migrant crisis, mortality is 20-fold higher than where that person came from. They came from a bad place, then they're displaced, but there's this increased mortality. But what is also more important is the diminished opportunity for early childhood development. Our potential, our human capital potential is developed in the first 3 years of our lives. So when we don't pay attention to that, even though we provide for food, for shelter, whatever else, that individual or those groups of people may fail to actually transition completely into a place where they have optimizing their human capital. They're fascinating and also very sad studies out of Europe. When they had the war more than many years ago in the last century, the country of Netherlands was under siege. And because it had good data, medical data, they were able to follow people who their mother was pregnant or they were born just after or just before and compared their health status. And one of the things that has come out now 40, 50 years later is the problem of mental health. And not just depressed, serious issues like schizophrenia, etc. And you can read that in the literature. So this is something, as we work as humanitarian workers, that it's not just the now we need to think about, the tomorrow. Next slide. I think I'm talking too much. Please go on. Show me the next slide. Now, the next 3 slides I'll just fly through. Just keep pressing until the whole slide is through. Let's see the whole slide. There's the HIV/AIDS crisis. There's a vulnerability to HIV infection. And there's the risk of being infected, right? There's the very well documented increased gender-based violence when people are displaced, so that putting people at risk of infection. Then there's the disruption of the health services. Remember, a disease like HIV or chronic illness, you need your medicine every day. It's like you're buying your life every day with your ARVs. So when there's that disruption, you lose what you've gained. You know, if you don't take ARVs, your viral load goes up, your disease is deteriorating. If you're a victim of this gender-based violence or your mental health makes you a perpetrator, you increase in transmission in that setting. Next slide. The babies that are born in that situation are also at increase of infection. Next slide. Let's see the next slide, Kabisa. Then what about women? We all know about the vulnerability that women experience. There are the problems of, sexual violation, but then even the issue of hygiene products, you know, your sanitary products in that environment, a toilet facility, you know, the loss of dignity that comes with being displaced away from the home in those camps. And then, of course, the disruption of family life. Our approach to humanitarian crisis is to pay attention to the women and the children. And in the process, we separate the men from their families. So the families are losing what is normally, in many societies, the structure of protection. I'm not 100% familiar with the literature on this, but that may be part of what the increased vulnerability of that family. I don't know. It's something we need to think about. Next slide. Prevention of mother-child transmission of HIV. Next, again, I have highlighted that becomes a complete issue when you have these disruptions. And the disruptions are not, it's not always a big crisis. Sometimes it's even, we have had a presidential election. In Africa, crises are many. There are many of us Africans here, so I can talk about it. We have a new president. We have a new government. Everything the previous government was doing we need to show we can do better. In the process, the structures that have been put in place to support programs like this are disrupted. And that in itself creates a crisis and creates the next wave of infections. Next slide. So as I go to wrap up, I want to emphasize, there's a quote from the UN document that early years in a child's life are critical in building a foundation for optimal development through stable and nurturing environment. And really the children face a major challenge for survival and even to thrive. This is the nurturing care framework. And if you look at the SDGs, if you look at the literature around SDGs, we started off with the SDGs, then we called action for women and children, and women and girls, women and children. But now, as we have been working on this, this is where we are. That these 5 things are critical for the survival of these young children. Let me go to the next slide. I've outlined them. The first one is good health. And it's the well-being of the child and the care provider. When the mother is healthy, physical and mental health, then she's able to provide for her child, and even her offspring is much healthier. There's the issue of adequate nutrition. Mother's nutritional status in pregnancy, we know, affects the baby's outcome, but even after her nutritional status after delivery, it directly impacts the well-being of that child. Even the food security, and then safety and security. And here we're not just talking about physical dangers. We're talking about emotional stress. We're talking about, is she exposed to intimate partner violence? In fact, that is the worst type of violence. It destroys the mother and destroys the baby. Yeah? We're talking about the environmental risks. So like now we have flooding, is a real crisis. And then access to food and clean water. Then there are these other two things that are less known and which we often don't program for. Opportunities for early learning. And the problem can be that when the opportunities are there are good results. If the environment is negative, it is harmful. If it's absent, it's even worse. The best example is babies in a children's home. If you feed the child and you don't stimulate them, their brain doesn't grow. If your method of disciplining children is cruel, you also harm the child. Then responsive caregiving. This now is understood to be the foundation of who we are. The relation contributes to the bonding and the attachment of the child to the parent. And it is about recognizing a baby's cues, responding to them appropriately, consistently, and it is critical to our well-being, not just for when you're a baby, but when you're also an adult. Next slide. So the actions that we can engage in are, first of all, to try and support the community and home-based services, and I will show you the list. It's not a strange list. We need to prevent separation of families. We need to promote hygiene and healthy training. And we need to establish, of course, the baby-friendly spaces. And what are these child-friendly spaces? It's a place where you can sing to your child, you can play with them, read. Let me see if by a show of hands, in your work environment, you work in humanitarian areas, where you're seeing children, how many of you have, there's an opportunity for play, singing? How many of you? I can see one hand there. Encouraging, talking, early learning, and psychosocial support. I work on the 3rd floor of Kenyatta National Hospital, and every week there's a team that comes in to play with the children, sometimes to sing, and then they walk around singing and dancing and reaching the other children who are not able to come and sit and do the artwork. We have a beautiful little library there with a wonderful collection of books for the children. So it's doable. And then, of course, we need to be contextually appropriate. We need to be culturally appropriate in our work. Next slide. Next slide, please. Go back one. Let's do that. This is the list of the things we must do. And I've put there the picture of the mother-baby booklet, which we use in Kenya for maternal child health services. This is the basic. We do it for people who are not displaced. It's the same thing that is basic, that is required for even in those humanitarian crises. And the things that are kind of newish here is promoting kangaroo mother care. Of course, early initiation of breastfeeding, support for responsive caregiving and learning activities, and then taking into account the psychosocial and trauma informed support for the young child and the mother and the parent, but being able to also screen for the children who are, who are at risk for suboptimal development. This is sort of like the basic. Next slide. Now, once you have the basics going, these are the other things you need to add. I think we can skip that. Sorry, 1 minute. In this slide, we emphasize that you need multi-sectoral planning. And this multi-sectoral planning is not just at headquarters, it needs to go all the way to the ground, even where you're implementing, all right? It's more easily said than done. Next slide. Now, once we've established those basic things, these are the add-ons that we actually need to ensure that we have optimal early childhood development in the environment of humanitarian crisis. You need to have, of course, the preventive and promotive care. We need to address mental health. we need to have trauma-informed psychosocial support. And I'm glad, MSF, you have published work on your response to women exposed to sexual violence in the Congo. We need to support parenting practices, and we need to care for children with additional needs. Next slide. Now, I just want to highlight this issue of trauma, mental trauma. And the individuals in this crisis have got what we call complex trauma. And these are the long-term consequences of this complex trauma. PTSD, depressive disorders, behavioral and conduct disorders, chronic disease, and even self-harm. This is a slide based on a meta-analysis done by some child psychologists, and it shows you the prevalence of these conditions 1 year after the event. You can see like the sexual violence has the highest level of PTSD at 37% after a year. And then the orange is child sexual abuse, and then the yellowish is child neglect. The gray is war experience. Now, when they look at lifetime, the prevalence of PTSD actually increases. So we move from 37% to 50%. The war situation from 25% to 39%. So it's moving your way does not take away that experience that you had. Now, next slide. Now, we have some wonderful news. There's been a series of studies done by child psychologists. They have used randomized clinical trial design. They worked with children who actually, the main form of abuse was chronic sexual abuse in families. And they have been able to show that this trauma-focused cognitive behavioral therapy treats the PTSD and improves the well-being of that child. And they have followed those children more than, they have data from the immediate and also data 2 years down the line, all right? I won't go into the details of the study, just to highlight. However, the challenge is, this is what involves the trauma-informed cognitive behavioral therapy. You can see it's up to 12 sessions. It requires, sorry, next slide. You haven't moved to the next slide, please, next slide. We have, this is what it involves. It requires 8 to 12 sessions. You have sessions of the child alone, and then sessions of the care provider, and then together. It requires some level of skill, but they say you can teach others to do it. The research is at the stage where they are looking at, say, for example, working with teachers in schools, etc. But this, to me, is one of the important things to move forward so that people actually recover from their problems. Next slide. Here is just showing the sequencing that one can sequence.
Ça, nous pouvons regarder. Le dernier dispositif, c'est... Vous êtes ici pour faire ça. Et...
Highlight what are seen as the attributes of a well-trained health professional. You need both knowledge, you need skills, and you need to have the right affect, and I think you all do, right? But as health professionals, you also need to be able to be a good communicator, good collaborators, manager, health advocate, scholar, professional. Does this sound like what you do? Right? Yes, but all these things, you need to keep developing them. You need, when there's opportunities for further learning, you need to actually engage in it, because the core medical school curriculum does not teach you all these skills, whether it's nursing or medicine or pharmacy or whatever. And the learning is, this Miller's pyramid we use for informing examinations in medical school. But you can also use it to inform yourself. Ask yourself, are you performing optimally? Are you just doing stuff here at the level of gathering data and passing it on along? Or are you able to look at the information you have and solve problems? In the space you work, you don't have much support, you often are alone. So you need to be performing at that higher level of work. In 2010, there was a publication of the Lancet Commission. This was 100 years after the previous commission on medical education. And this was the statement, and I think you're in the space, you're doing just that. That health is about people, that the core driving purpose of professional education must be to enhance the performance of the health system for meeting the needs of patients and populations in an equitable manner. And your contribution as MSF, working in humanitarian, in the humanitarian space, is phenomenal. And I wish you well for the rest of your conference and success as you do your work. Thank you.
Thank you, Professor, for that very sobering yet motivating talk and really highlighting the importance of nurturing care framework, especially in the first 1,000 days. A very nice way to set the scene for today. Now we're going to go to our first oral presentations. So I invite our people that are going to be in this oral presentation to come up to the stage, as well as introducing Miriam Alia, who is the Vaccine and Outbreak Response Advisor for OCPA, who will be moderating this session.
Hello? Okay. Thank you all. My job today is to keep you awake for the first table. The first thing, I think we missed one of the speakers. So for the people, no. You are not. No, you are in the second. You are, no. And to organize people also. Okay, so we are going to have a table with 3 young versus senior people. And we are going to go through different topics in this table, very complete table. So let me introduce our first speaker, Dr. Hasmin Omar. Okay. He has worked with MSF since 2017, mainly as PMR in regular, but a lot of emergencies. In epidemic, displacement, and nutrition project. And he's going to share with us his experience in one of the main outbreaks we have been responding in 2023 and 2024, the diphtheria outbreak in Kano, Nigeria, with a special focus in the strategy that they have used, the centralized model and home-based care. So welcome, the floor is yours.
Thank you. Good morning, everybody. And let me as well welcoming our partner, Minister of Health from Kano State, particularly Dr. Selma. She's a pediatrician and as well our case manager in the diphtheria outbreak response. So
you can be a little bit more near the mic.
It is okay now?
Yeah.
Yes. So just to introduce Dr. Selma, she's a pediatrician and as well the case management leader for diphtheria outbreak in Kano. So I'm going to present decentralization model of care, DMC, in response to diphtheria outbreak in Kano, Nigeria. This is strategy implementation. So Kano is one town, is most populated town in Nigeria, is the north part, where we experience high-scale diphtheria outbreak in the last year, and still it is ongoing. Yeah. So background and objective. Diphtheria is vaccine preventable diseases and mostly affected children. In Kano, we observe most children age affected from up to 15 or 14 years old. In Nigeria, there is high-scale outbreak. Kano State has been the epicenter of outbreak since declaration of the outbreak in December 2022. So there is outbreak of diphtheria all over the country in Nigeria, but Kano State is considered the epicenter. It accounts for 77% of all confirmed cases reported in Nigeria, with 12,581 between week 2 up to week 48 of 2023. Low vaccination coverage is the main leading cause, with other factors. Since Kano State is most populated, this is one other factor you can add it, and as well vaccine hesitancy and other risk factors. DMC implemented in Kano in week 43. Why? Because in since week 26, we observed there is increased number of cases of diphtheria. For example, from 136 cases per week up to 750 cases per week. And it is not possible to admit all these patients in the diphtheria treatment center. That is why we discuss among our team, we need to think about a strategy how to cope with a high number of cases. So DMC designed to be close to the affected community with curative and preventive health care that is fast and accessible, contribute to reduction of the mortality by reducing late presentation and complicated cases. Whenever we have the case of diphtheria arrive earlier to diphtheria treatment centers, we'll have definitely less complication, and the possibility to be recovered is very high. DMC was implemented to pragmatically ease the burden on the health care facilities. Rationalization and rationalization of the next slide. I can do by myself. Okay. Rationalization, patient-centered and community-based approach, improve access to the health care related to diphtheria case management, and early detection and treatment of diphtheria cases, and close contact to reduce morbidity and mortality. These three rationale, all of them contribute to reduce the mortality. Component of the diphtheria decentralization model of care, we have two components. Component number one, outpatient. Outpatient mainly for triaging and management of mild cases, and then for moderate and severe cases or complicated cases to be referred to diphtheria treatment centers. And then the second component is contact clinic. In the contact clinic, we have two types of the contact clinic, one mobile contact clinic and one fixed mobile contact clinic. Fixed contact clinic, it will be in the most affected area. We have some affected area, we have fixed contact clinic. For mobile contact clinic, our epidemiological team, they provide in weekly basis epidemiological map, GIS, so we are using to move our team from place to another place according to the number of the cases. So contact clinic mainly to improve access to the preventable care for close contact. Here we have main package of DMC. The main package of DMC include health promotion and infection prevention and control. And then we have chemoprophylaxis and vaccination for close contact. And then we have identification and management of simple cases. And the fourth component is referral of the complicated cases to diphtheria treatment centers. And the last, it is training of the health workers. Is not only Minister of Health workers, as well MSF health workers, not only from Nigeria mission, but other missions as well in the West Africa. So this one of our GIS map we are using to guide our team, for the mobile contact clinic. For example, in weekly basis, we receive this map from epidemiological team. Whenever we have high number of cases in a specific area, our mobile contact clinic team, they will move to the area. So DMC is implemented within existing public health facilities for outpatient service. and in the community for the contact clinic. For contact clinic, for example, we can use primary health care center, we can use a hospital, or sometimes even the community structure with proper IBC measurement. Selection of the facility is guided by epidemiological data, as I said, data analysis and mapping. Check square testing was used for statistical analysis on the mortality before and after DMC implementation. So as a result of the DMC, a total of 12,662 suspected cases from week 2 up to week 48 of 2023. DMC before was after implementation. Before implementation, we have 1,987 cases. We have 136 mortality deaths. Case fatality rate accounted 6.8%. And after the implementation of the DMC, we report 10,675 cases with 611 deaths. Case fatality rate 5.7. We can observe here there is a little bit decrease in the case fatality rate. Mortality square testing shows statistically significant difference in the mortality before and after implementation of DMC. So conclusion, decentralization model of care used for diphtheria response in Kano may have contributed to reduction of mortality, easing the burden on the healthcare facilities. It may be recommended for implementation in big outbreak upon in-depth analysis of its impact. Additionally, this study highlights the need for further studies on the impact of DMC in the access to the healthcare and reducing the burden in the health facility in massive outbreak. Acknowledgement, special thanks to MSF West and Central Africa for supporting implementation of the activity and conduction of the study, to the member of the Ministry of Health in Kano and the Nigeria Center for Disease Control and Surveillance for partnership in the control of the outbreak and the study done. Lastly, to the collaboration partner in the shared common goals of controlling the outbreak and furthering the understanding of the diphtheria. There, that is all. Thank you. Thank you.
You can.
I have my colleague. He will join me, Dr. Philip, to support in the discussion as well.
Yeah. Okay, so can you say it, and then the discussion will be after your colleagues present. Thank you. So we go with the second speaker, Duke. So while you get prepared, let me introduce Duke. He is a person of action, former member of the emergency pool with OCG, and a person of science. He has been involved in research mainly for infectious diseases control, and he's going to present a mist method operational research in Kismayo for measles outbreak. So the floor is yours.
Good morning, everybody. My name is Doug Lau, and today I'm going to take you through some findings from a study that we recently conducted in Somalia. Some delay on this clicker. All right, so the study took place in Kismayo, a major port city in the southern part of the country. Despite the availability of EPI services and mass vaccination campaigns, Kismayo has been facing resurgent measles outbreaks for many years. At the request of the Jubaland State Ministry of Health, we started a mixed method study to look at measles burden and measles vaccine coverage in Kismayo during a 2020 to 2021 outbreak. We also tried to identify key barriers and facilitators to measles vaccination and care. On the bottom left-hand side of the slide, you'll see an epi-curve of measles cases reported from Somalia to the WHO. Though this is national level data, it can give you an idea of just how common outbreaks have been over the past decade. In terms of the Kismayo health system, primary care for measles is available at maternal and child health clinics across the city. Secondary care is also available at the Kismayo General Hospital. In terms of vaccination, EPI services are available at all MOH facilities on a once or twice a week schedule, or through reactive campaigns with door-to-door visits. Despite the fact that several reactive campaigns were verbally reported to have taken place during our recall period, we were unable to locate any reports documenting the achievements of these campaigns. Our study used a sequential mixed method approach where earlier quantitative findings informed later qualitative investigations. For the quantitative methods, we conducted a household survey with a minimum sample size of 1,093 households. We used a satellite image of Kismayo with rooftop extractions along with a GIS-enabled simple random sampling method. The recall period ran for 2 years, from the 1st of February 2020 to the 31st of January 2022. After gaining some insights from a preliminary analysis of the survey data, we moved on to qualitative investigations, which included both focus group discussions and key informant interviews. In total, we received informed consent from 1,050 households, representing more than 6,600 individuals. Approximately 27% of the households identified as IDP, internally displaced. We conducted 13 key informant interviews with respondents from UN agencies, NGOs, and the Ministry of Health. We also conducted 8 focus group discussions with 8 participants each. From the household survey, we found an attack rate of 5% overall and 12% for children under 5. Though not shown on the slide, children under 5 from IDP households had an even higher attack rate of 17%. Case fatality ratios were found to be around 3% overall and around 6% for children under 5. Again, children from IDP households who were under 5 had a CFR of nearly 12%. Based on the rates we estimated, we project that there were more than 20,000 cases and 500 deaths from measles that happened in Kismayo during our 2-year recall period. In terms of vaccination coverage, about 50% of the children aged 6 to 59 months had at least 1 dose at the start of the recall period. This rose to 69% at the end of the recall period, an increase of about 20%. MCV2, or the second dose of vaccine, was found to be a great deal lower than the coverage for MCV1, with only about 8% of the sample population having received a second dose by the end of the recall period. Though not shown, the population up to 15 years of age showed very similar rates of coverage to the 6 to 59 month cohort that you see on the screen. As we attempted to make sense of these quantitative findings, we found that almost all study respondents had a very good basic understanding of measles, with nearly 90% of households able to identify 1 or more measles symptoms. However, there were still clear gaps in knowledge that became apparent, as one community member notes.
Sorry, Duke. Yep. 1 minute. You need to hurry up.
Okay. I'm going to race through this. I was not previously aware of measles, but I have learned through personal experience. One of my sons died and lost his sight to the disease. I did not take him to the hospital when he became sick because I did not recognize the symptoms. Another thing that also stood out was the clear support for measles control among local leaders. One respondent explains, as leaders of the community, it is our responsibility to address the challenges faced by people and raise awareness about any diseases that exist. Therefore, it is imperative that we encourage them to get vaccinated. I'm just going to skip through here. So another key challenge we identified involved the fact that medical care for measles was only sought by about 1/3 or 1/2 of self-identified measles cases, depending on IDP status. If you look at the chart on the right, we can see that the top reasons for not seeking care included the belief that measles was a mild disease, that medical care is not effective against measles, and that the distance to the nearest health facility is too far. Surprisingly, reasons related to cost, security, and social stigma were only seldomly reported. Regarding vaccination, the two most commonly reported reasons for not getting vaccinated, including no vaccine being offered and the distance to access vaccines being too far. As one respondent explains, people come to Kismayo for health services, which has become the central location of Jubaland State. One of the key factors leading to prolonged measles outbreaks is the number of unimmunized children in other areas, particularly areas controlled by Al-Shabaab. Of the 292 children receiving at least one dose during the 2-year recall period in our sample, we found that only 7% of these were received through door-to-door campaigns, with 92% instead getting their immunizations through EPI. As one community member explains, I would say that the mistake originates from the NGOs responsible for administering the vaccinations. They tend to delegate the entire process to the workers without proper oversight and control. A second respondent stresses that vaccinators are called only 1 day prior to the campaign, and it is unclear if they are properly trained. In summary, we have identified 5 key barriers to measles control in Kismayo. These include 1, the steady inflow of unvaccinated IDPs from insecure areas. 2, a tendency for households to delay or forego measles care, often based on the idea that measles is not a serious disease, healthcare being ineffective for measles treatment, or prohibitive distance associated with accessing care. 3, limited access to EPI vaccinations, especially in terms of the once-a-week vaccination offerings and long wait times. 4, limited coverage achieved by reactive vaccination campaigns, especially in terms of challenges in human resources for health, and limited efforts at community engagement.
Hello, you need to finish.
Okay.
We are eating the time for questions.
Okay.
You can.
And here's the last slide that I will let you read on your own. Thank you very much.
Yes. Maintenant, je vais parler en français avec les mêmes.
I'm going to speak in French. I'll have a Spanish accent. I'm going to represent Barry, who is an epidemiologist. He's a doctor in medicine. He is also in charge of the Guinea Institute. He's been involved in research on malaria, tropical diseases, and his presentation is on MOVs. Thanks a lot, ladies and gentlemen, dear colleagues. We have the honor today to present to you the missed opportunities. I have been working under 5 years in the Matoto Health District in Guinea. To do this, the following plan will guide our presentation. After a brief introduction specifying the objectives of this work, we will discuss the methodology, then the results, and end with a conclusion with some recommendations. According to the World Health Organization's MOVs in children include any visit to a child who is eligible for vaccination, unvaccinated in a health vaccination that does not result in the injection of all doses of vaccine for which they fulfill the conditions. In Guinea, the expanded program of immunization targets children between 0 to 23 months. The vaccines are 1 dose of BCG, 3 doses of Penta, 4 doses of polio oral vaccine, 1 dose of inactivated polio vaccine, 2 doses of measles vaccine, 1 dose of yellow fever, and 1 dose against meningococcal meningitis. Well before the COVID-19 pandemic, the demographic and health surveys revealed that less than 24% of children aged 0 to 23 months had received all basic vaccines. These situations exposes an increased risk of vaccine-preventable diseases. Between 2021 and 2022, the country experienced a measles epidemic during which MSF treated 81% of cases in Conakry. In order to optimize progress in combating vaccine-preventable diseases, it was imperative for us to assist missed opportunities for vaccination in children under 5 years of age, with the objective of estimating the prevalence of MOVs in children, to describe their distribution by age group and antigen, to describe the reasons for visiting, the reasons for missing the MOVs, and also to identify the reasons invoked by the accompanying persons. To achieve these objectives, we use the following methodology in agreement with the extended immunization program of Matoto and the Municipal Directorate of Health of Matoto. We selected health establishments. We had Tombolia Health Center, Daponda Health Center, and 2 private ones, Banabi Botoba and St. Gabriel Dispensary. In these 4 selected health centers, we conducted a cross-sectional study from 11th to 19th April 2023. Children of 0 to 59 visiting these 4 establishments. We included the study where all children for whom the accompanying person gave free and informed written consent. A default convenience sample was used for each health facility. We selected a minimum of 0, a minimum of 40 age 0 to 23 months, and 50, 24 to 59 months. The choice of 24 to 59 was to show the added value of vaccination catch-up. We note that in our study, we considered as a MOV any children who had not received the indicated vaccines, even if they had passed the recommended age to receive them according to the country's policy. The data we collected using a standardized individual paper questionnaire. They were then entered into a standard Excel database developed by MSF with automatic calculation of the indicators. Our main results were as follows. During the assessment, 357 children were eligible for vaccination. Amongst them, 300, that is 84%, presented an MOV at the end of their visit. Children aged 24 to 59 months were the most affected with 53% of cases. The distribution of MOVs by age group and antigen showed the oral polio and measles vaccine were the most missed, with 91%, with 50% of the cases. Children of 0 to 29 missed the oral vaccine at 91%. And 97% for ARVs for 24 to 15-month-old children. The reasons for visit of these children was for curative consultations and vaccination. The children for So 87% were those between 0 to 23 months that presented themselves for vaccination. The lack of information was one of the reasons that they gave. For those that were aged 24 to 59, the loss of information was cited at 47%. Our study has a few limitations. As far as the limitations are concerned, first of all, we've got a potential memory bias, as some data were collected on the basis of the memories of the accompanying persons. Also, the sample was not representative. This means that the results were not generalizable and beyond the health center. Because these children lived the places with children aged between 24 and 59 months were the majority, but we noted a significant proportion of children between 0 to 23 months were targets of EPI. The main reason was for curative consultation and vaccinations. That's the reason why they went to the health centers. This situation shows the need to have practical and specific interventions to face MOVs, and for this we came up with several recommendations. One of them is to organize the patient circuit so that vaccination is mandatory, integrating MOVs, evaluating them into the system as a routine process, identification and training in each health district of an evaluation officer, a constant and adequate supply of vaccines and immunization equipment, and finally, the systematic organization of catch-up vaccine. I thank you for your attentiveness.
So now I come back to English. We have gone in a very different way, because we have started with the end, with the strategies, and I would like to come back to the beginning. So we have started with the children missing their opportunity to get protected due to lack of information or lack of vaccines. We have gone to the impact of this lack of protection with a measles outbreak, a classic measles outbreak with this qualitative study, and then to the strategies with in a not new, but the emergent disease as diphtheria, in a massive outbreak in Nigeria, in a very complicated place due to security and with the centralized model of care and home-based care. Thank you very much to the three speakers. I don't know if there is question in the audience. There is a question. So if you can say to whom is the question?
Oh, it's actually to MSF in general.
Okay. Hola, Maria.
My name is Diani. I just came back from my visit to Ethiopia Kule project, and I just wanted to understand how we as MSF are going to react to the situation which we have in the Kule project. We have one confirmed case of polio. We are still waiting for the secondary confirmation, which was sent to South Africa, which will take another 2 weeks, and we have 3 more suspected cases. Out of these 4 cases, 3 are returnees from South Sudan. South Sudan has detected 1 positive polio case in December 2023, but that boy was lost to follow-up. So we have this issue of almost eradicated disease newly emerging in an area where polio was not so frequent. I know Ethiopia had some cases, and knowing that we have a gap in vaccination for polio even in Western Africa, I would like to know how are we going to move forward in tackling this issue.
Okay, this is, thank you for the question, very interesting, but it's not a question for the speaker. If you allow me, we can put this aside for a moment, and there is any question for the speaker, because if there is not, I have some questions or clarification.
Thank you. My question to the colleague from Nigeria and from Kano. Several years ago, there was a big initiative on polio eradication. And Gates Foundation, through Gavi, put a lot of money into the Nigerian government. And they even started using GIS systems to map out where unimmunized children are. Now, my question is, what happened? I met them. There's a body called the Polio Elimination Monitoring Board. I used to meet them. We met them there, and they told us of these wonderful things they were doing. That knowledge of polio elimination looks like it's not translated into prevention of diphtheria and other childhood illnesses. The point I'm making is that if you go back and read how disease has been eliminated, especially disease in childhood. For example, the government of India has wonderful documents of how they found all the children. And if you think of India with a large population, migrant populations, internally displaced, people who are traveling, the whole works. And I'm asking, why are we not learning from that, and why are we not doing what needs to be done? And this is a problem even here in Kenya. Our immunization coverage is less than 50%, is about 50%. So that's a general question. Then to the colleague who is from Somalia, just from Somalia, we have the same population, as you're having, and we have the same outbreaks, polio, measles, etc. Our problem is the messages from their relatives in America. They're the ones who are, say, driving the vaccine.
I think we have a volunteer to respond to your question. Dagi? Dagi, can you introduce yourself? And
I'm the Emergency Medical Program Manager for WACA. Dr. Salma, who has been working in Kano for ages, is here with us. But practically, the rhetoric and the practical realities are completely different. So the planning, the documentation, the EOC with its fancy places with all the gadgets are there, but the practical realities of delivering vaccines to children in Kano State does not work. As MSF, we have not been in Kano for a long period of time. We arrived in Kano in 2021, so we don't have a long history of what has been happening in Kano. But practically, yes, people want to get vaccinated. That's what we learned in our intervention during the diphtheria outbreak in Kano. But lack of availability of vaccines, poorly resourced facilities, and poorly informed community members are the reasons why we have a very low vaccination coverage. And Dr. Salma may add a few answers.
Thank you, Dagi. Any other question?
Hello, good morning. I just want to, I'm Dr. Salma Al-Suwaid, consultant pediatrician with Ministry of Health, Kano State, and the case manager for diphtheria in the state. I think there was a fallout. The local government that where those cases of diphtheria were reported was known to have very low vaccine, high vaccine hesitancy. Anti-vaxxers were plenty there, and then it is a community that has an influx of people from Chad. In terms of when we have IDPs, they were all going to that particular local government, and that's where the outbreak started. It became the epicenter within the state, and we all know with outbreak, if it stayed a long time, the herd immunity of even those that are immunized get to be affected, and we went into a roller coaster with diphtheria. Thank you.
A question to the speakers? Okay, thank you. Go.
And my name is Ali Sheikh. I'm an epidemiologist in PERA project. I have a comment from the methodology that he has done, the author. And I'm commenting the methodology. And actually, you did a good study, which is talking about more about impact of DMC in the community. So in your methodology, you use that chi-square test to see the impact of the outcome of the variables of your study, which is more on the mortality. And how was feasible, to conduct like RCT or quasi-experimental study, where you look at those who conduct the DMC and compare to other area which has no DMC to see the real impact of the study instead of using chi-square test?
Yeah, go ahead.
Thank you for your question. Still, we are collecting some data. Our team in the fields are collecting some data to have conclusion and as well to have proper analysis for the study. Our team leader, Dr. Dagi, as well, they can explore more. Yeah.
I think few clarifications. This abstract was not conducted as a study. We just wanted to see the impact of home-based decentralized model of care in reducing mortality. We have not come to a conclusion saying that it has definitely contributed to reduction in mortality. Currently, we are developing a protocol to see the impact of DMC to be submitted to the MSF Ethics Review Board and to the Nigerian authorities. In partnership with Epicenter. We know the presentation has its own limitations, but we thought also it's quite interesting to present to our colleagues managing a massive outbreak, being forced to do home-based care and centralized model of care for very complicated disease was something that we had to implement because practically it was impossible for us to manage all the patients in the diphtheria treatment center. Thank you.
Thank you. Any other question? There is a question there. Yes.
Hello, good morning. So my question is to the presenter that did the data from Somalia on the measles vaccination. I found it interesting in your presentation that you mentioned that the reason for the high, the high outbreak, one of them was because the vaccination was not offered. And the second thing that I found interesting is that you mentioned that the people, I'm not sure if that was from your data or was a feeling from the community, that the people that were providing the vaccination or providing the service, it was felt that they were not trained. I found that very interesting. So, and there was also a high level of NGO activity within that IDP community. So what I'd like to ask is if there is a high level of NGO within that community, one, why is the vaccination not offered? Because measles vaccination is available. And two, if we have volunteers, why aren't they being properly trained to be able to provide that vaccination? Did you mitigate, or that's just a finding that you've picked up to be able to be mitigated later? Thank you.
Great. Thank you very much for the question. And yes, indeed. So what we actually saw from the quantitative side of things was that mainly the people that did not get vaccinated were reporting that it's because they had no vaccine offered to them. And then the second bit about the people not being trained, that's coming from the qualitative side, from interviewing with actual stakeholders that were familiar with the process. Now, if you're asking me why it is the case, that answer isn't really contained in our data, and it's actually a good opportunity for further study. Ultimately, there is something that's happening. There's some sort of breakdown from the idea that we want to increase the coverage enough to build the herd immunity versus the actual implementation of the activity. And so, yeah, it's also a deeper question that needs more study.
Something else? Any other question? I see two hands. I don't know if we have time. Yes? No? You tell me? No? we don't have time. So keep your question for the coffee break. The speakers will be available and more relaxed. And thank you all. You were very awake. And keep this spirit, because we are having a very interesting panel in vaccination in 30 minutes. So thank you very much. And this is the formal opening. Thank you.
Thank you, guys. So now we have our first PED talk for the conference. So I'll invite Tony up to the stage, wherever you are. All right, so Tony Labunda Ngemba is working in our project in Morsala in Chad. He's been with MSF for the past few years in many projects, but he's going to talk to us today about pediatrics without pain and the experience they've had. And just a reminder to those of you that need translation, if you don't have spare headphones on your table, have a look around and steal from another table. There were 6 put on each table, but people might not need them, so.
Yes. Bonjour à tous.
Good morning, everyone. I shall speak in French. My name is Tony Lubudangamba. I am a medical doctor from the Democratic Republic of Congo. For the moment, I am in Chad as a BMR for other sections. I am there with I am here to share this activity that is a project within a project called Pediatrics Without Pain, Morsala in south of Chad, in border with the Central African Republic. It's an old project of MSF since the year 2010, and the objectives were revised in the year 2018, and we now have a support of the Ministry of Health, and of course in consideration of malaria, we are serving with a ministry hospital in Sala, 2 health centers in the peripheries, Dembo and Beboro. As you all know, I think you will agree with me that considering pain in pediatric services is a serious problem in the area of public health, and after so many analyses and studies and research in a more collegial and systemic manner, the people decided to put in place this project, a very interesting one that is considering ending pain in pediatry. This has started since the year 2021, early 2022. Due to many hindrances, it wasn't able to move forth as we planned for, but we relaunched towards the end of 2022, and up to date we see there are very positive changes, and we are moving forth, though there are challenges. I want to thank all the pediatrics service providers in the room. Thank you very much for the great work you're doing, especially in managing pain in children. And I love this sentence that you always say, the child is not a young adult or a small adult. And so we shall continue. After this systematic approach, we did put in place some things for this program to be disseminated, i.e. sensitizations of those accompanying us, because part of the problems we had in the past is that project did not move forth. There was need to see how the community looks at the project, even the staffs, and so there was need for sensitization in the field that focus resources on this for it to move forth, and now we have a good understanding of the project. Secondly, we were able to have training, chronograms of personnel training, well respected, though there are hiccups here and there. However, we are doing our best to follow. We are also following up with the files. There are audits that take place monthly, and I can give some examples, like the case of January. After the audit, we realized that the evaluation of pain amongst children was done at about 70% in February. It was 78.3 in March. We went back to 72%. So you see, this is a serious challenge on which we need to work on. Apart from this, we also created a hall, a room that deals with treatment. Maybe something that I did not say. MSF supporting pediatry and maternity and cases of blogs for maternity. And here you understand that this project has come on another non-surgical project. So we need to think of how it should move forth. And so we needed to put so many things together, so many work for this to be accepted. Yes, we had started not long ago with the two centers that we are supporting, Dembo and Deboro. There are still challenges, however, we are somehow doing our best so that this can work better. Now, on the side here, please don't look at the bad image as it is, but I want to show the map, evaluation for children in pain. This is the scale that is used for children up to the age of 7. After 7, we're using verbal scale. Now, in this chart, what we are showing here, this is a mean of communication for sensitization in every pediatric services. We try to do this to remind people that the nurses, the medical doctors, and everybody else in this will continue doing the evaluation, that we should not forget to take into consideration the pain of the children. I will not say a lot looking at the time that we have. It is just to share with us this systematic approach, how we started, what are the axes in which we worked to put together this activity or this project on pain management amongst children. There were many analyses together with prediction so that we can put together this project. And now, as always, a project will always have success and challenges. However, I will begin with the success. Now there is collective awareness, which is a positive thing. There are people who now accept the project, they try to adhere to this and are doing assessment as they ought to and taking care of the children as they ought to. Secondly, there is improvement that we have seen for us. Is something to be proud of. I've shared a few examples on audits. This is a positive thing for us. Now on decentralization, I must mention what I said a bit earlier. It is a project of thin collaborations. About 90% of people from the ministry, things don't happen as always. This is not the case of MSF 100% sponsored projects, so there are many things to put together, working together to see how things will work. But I must also mention that this collaboration for us is a wealth, because there are not many projects like this one, and so from the start to here, this is a positive thing we are proud of. Amongst challenges that we have experienced, there is lack of participation and lack of interest from some staffs. This is a challenge that we need to work on seriously. That's why we do continue to do sensitization. There's a team that is given to that to see to it that people are sensitized, that people are asking for more for more cash. This is a collaboration project. It's not always easy. We are still working on it, and we believe it will move forth. Secondly, there is perceptions and cultural mites, and I know in other areas in the world and the projects that there is taking care of pain in children that is considered. Now here we have a serious problem because of the cultural mites. And especially in our project, there are those who believe the pain is a normal thing people should accept. Some people say no, even the Bible says children are born through pain, a baby in good health must have pain and cry, etc., etc. So it is making it a bit hard, the implementation of a project like this, but we believe in it. We're still working on. So the little image, unfortunately, it is not clean. You see how we have our tools. The project is still going on, and we're looking at how what to do, what to improve, and we are working on the possibility of starting to use proxy state of azote and intranasal, which is not there. And also we need to bring some kind of games, let's say a game room, and avail toys for children to play. It works on the mental health of the child and reduces pain, and also we need to have this in other services. I must say that the maternity, because there's a committee that was created, I did not say this earlier, I'm sorry, just in the assessment of the project, the maternity requested that these should take place even in internal medicine, and it is not systematic yet, but though there's no protocol or a project that is established like what we're doing in pediatrics, we want to have it in all other services. I don't know if we still have some time. There's a video of less than a minute that can show what we are doing, if I am allowed to. But thank you very much for your kind gesture of following. I'm still here. If there are questions or documents you want, I am ready to share. Please meet me or even write us on Moisala Project. Thank you very much.
One of the first of these sessions for the conference. You will see them scattered throughout the 2 days, a breaking news session. And these are just opportunities to update you on different things that are happening in the pediatric space in MSF. So I'm going to hand over to Nadia, who many of you will know. She's had a long history in MSF, and you'll see her running around these couple of days because she's not only the content coordinator, but she's speaking in her other role, which is the author coordinator of the guidelines. So I'll hand over to Nadia.
Hello, yeah. Okay, so I'm delighted to be here today. I'm going to try to keep this brief because I know everyone is desperate for coffee. So I'm delighted to announce the long-awaited Paediatric Guideline. So the Paediatric Guideline was written in strong collaboration with Paediatric Working Group, but also with many other working groups. So the Nutrition Working Group, the Nursing Working Group, Critical Care Working Group, many working groups in the MSF. And it just shows that it's so transversal and kind of touches every aspect of paediatric care. For those of you who are lucky enough to receive a copy, I encourage you to flick through it, to become familiar with it, to get back to your projects and use it at the bedside. It is supposed to be a clinical and practical guideline to be used at the bedside. It accompanies also the neonatal guidelines. So now we have a complete set of guidance from birth up until adolescence between the neonatal and the pediatric guideline. So what's new in this guideline? So this is the first international guideline. What that means is it's the first collaborative guideline between all of the MSF sections. So this will be used in every single hospital that does pediatrics in MSF. In the past, we've had some that have been used in certain parts, but not in others. So this is the first international guideline. It remains an internal guideline, which means it's only available for MSF staff. But that's available for every MSF staff. So even if you don't have an MSF email address, you can access this. And I encourage you to go and visit the Paediatric Working Group booth where they can show you how to use this and how to log in. It also has some new chapters compared to what you may have seen in the past. It includes children with malnutrition and children without malnutrition, so there's no separate guidance for medical conditions for children with malnutrition. And we also have online access via an app. So you can get this on your phone, you can download a PDF onto your phone, and you can also use your phone at the bedside. Let's take a little look inside. Let's take a little look inside. Okay, so this is what the Medical Guidelines app looks like, and I encourage you all to try and have a look at it. It's very easy to access, and although the book is amazing, sometimes it's nice to also use the online version. You can take it with you on your phone everywhere you go. So I'm just going to show you a little navigation through how this platform works. So you can see here that there's all the MSF guidelines are on this platform. It's not just the pediatric guideline. So all of the public guidelines and all of the internal guidelines you can access here. You can see all the chapters down the left-hand side. You can flick through every one. There are some new things I want to specifically make you aware of. So we have some new guidance on shock and circulatory impairment. There is a poisonings chapter, which can take you through a toxidromic approach. There is some new guidance on renal care, which we didn't have in the past, cardiology, and many, many other things. So I encourage you to look through it. I'm going to speed up a little bit because I know we're short of time. So what happens from here? This guideline is now being translated to French and Arabic. So by the end of the year, this will be available in both French and Arabic. It is going to be circulated in the field for 1 year, during which time we want to collect your feedback. So please, please send your feedback. You can do this in 2 ways. In the inside of the book, in the front cover, there's an email address that you can email with any suggestions, any feedbacks for improvement. We're really happy to hear them. You can also do this online on the feedback button. What we'll then do, we'll take all this into account, and we can actually, because it's online, we can make regular updates. So we don't have to wait for 3 years for the next version to come out. It will be updated regularly online, and you will have instant access to the latest recommendations and evidence. If you want to know anything else about the pediatric guideline, please come and visit the booth, the Paediatric Working Group station, where there is a laptop, and you'll be able to try to log in and have a look at the guideline for yourself. Thank you.
Thanks, Nadia. Now we just have one session between you and coffee, and that is speed posters. So I'll ask those of you that are
Good morning, everyone. My name is Selma Ali Swait, consultant pediatrician working with the Ministry of Health, Kano State. I have a poster presentation that I'm going to present on the rare manifestation of diphtheria, presenting with vulvovaginal manifestation of diphtheria. The case is worth noting because the manifestation of vulvovaginal diphtheria is quite rare, and also the integrity and improvisation that was put in place in the management of this particular case. So I welcome you to my poster presentation during the coffee break. Thank you.
Good morning, everyone. Diphtheria, which is a vaccine-preventable disease, has killed many lives, left countless others with lasting complications. However, amidst the challenges, there is a story of hope. A patient who not only survived diphtheria, but overcome not 1, not 2, but 5 life-threatening complications. Join me as we explore the journey of this remarkable survivor who spent 35 days on admission fighting against the odds. Let's discover the lessons learned and the strength found in the face of adversity. I'm Dr. Khadija, and I'm inviting you all.
Hello. If you have diarrhea and you go to seek treatment in a community-centered or based health site, most likely you will be given this, and chances are that you might have to drink it with water like this. This is what was happening in Maat in South Sudan until we set up a solar-powered filtration unit in order to start providing clean water to everybody that was sick in that community. Come see me, and you will not only understand the setup of the community, the filtration unit, but as well the drastic decrease that we had in diarrhea. Thanks.
Hi, everyone. And measles is a contagious disease in Somalia, and it is pardoned in Somalia as well. Therefore, we assessed the clinical outcome of measles patients is admitted in bi-regional hospital in Somalia. And we found that the main determinant of measles outcome was nutritional status, where malnourished children are less likely to be recovered and discharged from hospital compared to non-malnourished children. Therefore, our study is encouraging that nutrition intervention can contribute a lot to improve the outcome of the measles patients. So to get more about that, I'll invite you to my location. Thank you very much.
Thank you, and thank you for sticking to time. So it is now time for a coffee break. So we'll have 20 minutes. So if you can be back here ready to start at 11:10. And for speakers that are in the next session, including oral presentations, oral posters, please meet at 11 o'clock in the holding room just in the doorway. So there's skill stations, booths, coffee, chat, and we'll see you back at 11:10. If you can take your seats, please. Anna. We're starting, if everyone can please sit down. If you don't have seats, some more seats have been added at either of the sides, so there are some extra seats for people. All right, and apologies to those of you that might not have made it to the front of the coffee queue. All right, so we're going to kick off our next session, and we're going to start with another breaking news session. So I'll invite Amelia Zhao to the stage. She's the project manager of the Science Portal, and she's going to give us a quick update and show us this great tool.
Thank you. Good morning, everyone. I hope we had coffee and we're ready to dive back in. My name is Amelia. I will be presenting today on the MSF Science Portal. Could I have the next slide, please? So what is the portal? Why do we have a science portal? Before the portal, MSF research was spread out everywhere. The number one complaint that people had was that they didn't know where to look for MSF research. So the portal seeks to solve that issue. It brings all of MSF's research under one roof, regardless of the context, the medical topic, or the country, or even the OC that has conducted the research or led the research. The portal serves kind of two main goals. One is as a knowledge hub, so that in the projects that you or other MSF partners are working on, if you're having challenges in these projects, or if you want to see what other lessons that other MSF projects have learned, you can search the portal and you can see what literature they've published. And the second is Since this is a public website, it's for external stakeholders. So it's for MSF partners, for ministries of health, for policymakers, so that we can bring MSF's research and we can say, look, we've done the research, we have this empirical evidence on why this new approach works, or why this treatment should be done in a certain way. So I'll walk through a little bit on how to navigate the science portal. This is the homepage of the portal. At the very top, you can select the language, you can have your saved items and the search bar. What you see scrolling across is the newsreel. These are packages of content. These are very easy to share externally, so you can share a package on the climate crisis or the EU migration policies with external shareholders, and bring forward that empirical evidence that MSF has. This is a great place to start if you're just looking to browse the portal. We have the editor's picks, which are a selection of articles on current topics, and then we also have the newest content. Right now, all of the posters and abstracts from Paediatric Days today and tomorrow are up on the portal website. And this is updated on at least a weekly basis, so it's constantly being updated with the newest research. Going back up, if you just want to start and jump in, you can click View All, and you can see all of the articles that we have on the portal. We have almost 4,000 now, and this spans back until like the 90s up until today. This morning, some of the presentations that we heard from, one of them focused on measles vaccination and measles in Somalia. So if you wanted to learn more about that, you can type that into the search bar, and we have 150 results or so. You can apply any of those filters that you see on the left. You can also sort by publication date. So for example, if you wanted to see just the newest information, and if you wanted to see only research articles or only letters, you can apply those different filters. As I mentioned, we also have all of the MSF conferences as well. So if we wanted to look at some conference content, which sometimes can be a little bit more up to date since it doesn't face the same delays in publishing, then we can apply this, and you can see all of these conference abstracts and videos from MSF conferences. You can also click the hearts to save for later. You can also, if you wanted to share this, you can copy the URL and you can share it with anybody that you would like to, and this screen will come up exactly as you see it now. If we wanted to learn more about this lessons learned from the measles outbreak response project, then we can click the video and we can see it's a video in both French and English. So a spoiler, one of their findings was that they targeted low vaccine rate areas, and that was hugely effective in alleviating the measles outbreak. And so, for example, if you're working on that, then that's something that you could apply in your work as well. You can save them for later as well, and come back and view them at any time. So that's the portal in a super brief overview. We are constantly improving it and constantly updating the interface as well. So if there's anything that you think would be helpful to see on the portal but isn't there, please let me know. I am at a booth on the far end, and you can ask me any questions you have about it, and we can also help support your work in creating those packages of content as well. And if you have the water bottle, the QR code on the water bottle will also lead you to the science portal. Thank you.
Thanks, Amelia. So I'll now invite Joanna to the stage to give another breaking news to update you all on the paediatric and neonatal learning initiatives. Joanna has been with MSF for quite some time and in many and varied roles, but she's coming to present as her role as paediatric advisor now for the MSF Academy.
So there's an old saying that goes, if you give a man a fish, you feed him for a day. Teach a man a fish and you feed him for a lifetime. And in the humanitarian sector, this could be seen as a dichotomy between relief and development. But relief and development can coexist. After all, it's easier to learn when you're not hungry. MSF was born in a climate of acute humanitarian crisis, and while this remains our mandate, over the last 50 years we've grown considerably in terms of size, scope and vision. Over 90% of our staff are locally hired staff, and there's growing recognition in the need to invest in capacity building of our clinical staff to ensure they have the requisite knowledge, skills and attitudes to provide quality medical care. And with paediatric care comprising up to 70% of our activities, paediatric education should be our core business. The MSF Paediatric Learning Initiative is an intersectional venture that aims to mutualise training efforts across all OCs and initiatives to improve the efficacy, efficiency and alignment of training opportunities within MSF. It's not what the clinician knows, but what the clinician does that counts. By applying adult learning theory, we aim to use varied pedagogical techniques to build clinical competency in the workplace and ultimately improve quality of care. We use multimodal learning techniques adapted to the learner, including self-paced e-learning, virtual classes, micro-learning, face-to-face teaching, simulation, bedside teaching and mentoring and more. These activities are designed to be integrated at the project level as on-the-job training. And although we have a number of existing initiatives and opportunities, we lack a consistent and coherent intersectional approach. As such, our current materials are not standardised or systematically updated, and widespread upscale of learning opportunities remains limited. This initiative aims to bring together various learning offers and create packages of resources that are accessible and can be flexibly deployed according to project setting. Here we can see a range of learning opportunities currently available within MSF, and over this 2 weeks surrounding the Paediatric Days, we're fortunate to be able to offer a range of learning opportunities. Just this week, we've had a number of participants pass through the TB chest X-ray training of trainers, and then put their skills into action yesterday in a provider course as part of the Test, Avoid, Treat TB in Children, or TACTIC project. And next week there's a range of learning going to happen as well. There's a Helping Babies Breathe trainer courses, which aims to upscale effective newborn resuscitation at the field level. In addition, we'll have a paediatric training that puts to use the recently released intersectional guidelines. We'll also have a simulation training as part of the field simulation project to create experiential learning environments to improve preparedness and ultimately quality of care. And you'll also hear more about the Newborn Care Learning Hub, which is a hybrid learning program which has been implemented intersectionally. Meanwhile, our mobile training teams are delivering structured training courses in paediatric emergency hospital care and neonatal hospital care. And we're also fortunate to be joined by the team from the Berlin Knowledge Lab, who are supporting training initiatives through the development of podcasts and videos. And we plan to strengthen our links with the MSF Academy to build a paediatric curriculum to provide formalised training courses, including diploma-level training. So back to the fish analogy. Teaching a man to fish is only useful if you give him the resources he needs to go fishing, if he has a fishing rod, bait, if he has time to go fishing and a place to cook his fish. Similarly, training in isolation will not improve quality of care. We need to create enabling learning environments and conducive working environments to be able for learners to really put their skills to use. So perhaps we need to change the saying. Maybe we need to teach women to fish, give them the resources they need to go fishing, and provide a pond full of fish, and maybe we'll just feed the village. Thank you.
Awesome. Thanks, Joanna, and thanks to everyone that's contributing to the trainings that are happening around this event. So now we move to one of our main sessions, which is on vaccination. So I ask those oral speakers to come to the stage. So this session is about how to maximize catch-up vaccination opportunities in the post-COVID-19 era. So we have a range of speakers, and we also have 2 project testimonies. So I'll ask Gabrielle as well as, Faustin to come to the stage as well for your project testimonies. This session will be chaired by one of our vaccination experts. So Shamila Shetty is a vaccine medicines advisor for the MSF Access campaign, and so I'll hand over to her for the session. Oh, and just a quick reminder for the online participants to make sure you go to the Q&A section within the session and post your questions for this session. Thank you.
Thank you. Good morning, everybody. It's still morning, right? Okay. Yes, so my name is Sharmila Shetty, and I'm the Vaccines Medical Advisor for the MSF Access campaign, and I'm really delighted to be here to present this session to you. Just on a personal note, you know, I started my career many years ago as a pediatrician with MSF, and way before the Paediatric Days started. But when I heard about Paediatric Days, I thought, I definitely have to come here one of these days, and I finally made it. So I'm really delighted not just to be attending this, but to be chairing this session on vaccination, which is a subject very close to my heart. So I'm glad you're all here. So I think we'll start the session. We actually have polling questions for you to test your knowledge. So if you have your phones and the app available, if you can open up the app, and hopefully we can pull up the questions on the screen. Nadia is working feverishly to do so. Okay, you know what? We're just going to skip those questions for now. Maybe we'll do it at the end to test your knowledge. But okay, so as I'm sure most of you in this audience are aware, vaccination is probably one of the most safest, successful, and most cost-effective public health interventions around. Immunizations have enabled us to eradicate smallpox. We've nearly defeated polio, and it's enabled us to ensure children survive and thrive like never before. And with newer vaccines that have been recently licensed, like the malaria vaccine, the dengue vaccine, and others that are in development that can have a huge impact, like the tuberculosis vaccine, we can expect even more lives to be saved in the future. So today's session is actually incredibly timely because last week we celebrated World Immunization Week, where it was celebrating an incredible milestone, the 50th anniversary of the expanded program on immunization, or EPI for short. So about 50 years ago in 1974, fewer than 5% of infants globally were vaccinated. However, today, 84% of children globally have received 3 doses of the diphtheria, tetanus, and pertussis vaccine, DTP for short, which is a marker for global vaccine coverage. A recent Lancet publication very recently showed that since 1974, vaccination has averted 154 million deaths, which translates to about 6 lives per minute. Thanks to immunization, today a child is 40% more likely to reach their 5th birthday than a child born 50 years ago. So we've accomplished a lot in the last 50 years, but we can't take these gains for granted. So as the title of this session suggests, how to maximize catch-up vaccination opportunities in the post-COVID-19 era, that's a mouthful. Since the COVID-19 pandemic, there have been major setbacks in vaccination coverage. In 2021, there were 25 million children who are unvaccinated or under-vaccinated, the highest number since 2008. So it's set us back about 13 years. So while vaccination has slightly improved in 2022 compared to the previous year, there were still 20.5 million children who missed out on 1 or more of their vaccines, with over 14 million of these children not having received a single vaccine dose, also known as zero-dose children. So as a result, the world is seeing more and more outbreaks of vaccine-preventable diseases that our MSF field teams are responding to every day. We're starting to see outbreaks of polio, cholera, diphtheria. Another significant disease outbreak that we at MSF see quite often is measles. So just to put it in perspective, in 2023, measles cases increased globally by 70%. And because of the backsliding in coverage, there were 50 countries that had large and disruptive outbreaks of measles, which is actually double the number of countries than in the previous 2 years. So in this session, we'll get a firsthand account from one of our MSF OCA colleagues on the reality and impact of a measles outbreak on a community in South Sudan and the importance of timely vaccination. The African continent has been hit particularly hard by this backsliding in vaccination coverage, with many recurrent vaccine-preventable disease outbreaks. So one of our speakers from WHO will give an update on the status of outbreaks and immunization in Africa and the work that needs to be done to get back on track here. There's also increasing relevance of new vaccination strategies in humanitarian settings, such as reactive and preventive multi-antigen campaigns, which MSF is increasingly undertaking in our field projects. So we'll hear from one of our OCBA colleagues in DRC and what it actually takes to undertake multi-antigen campaigns. But beyond running vaccination campaigns, which we at MSF are quite familiar with, and is our usual modus operandi, is there more that we can be doing? So our colleague Catherine, our OCB vaccination advisor, would say, yes, definitely yes. We can and should be doing more, and she'll be providing many examples of how we can transform every encounter with a child, from the OPD, the IPD, to the emergency room, etc., into a vaccination opportunity. Also, we'll hear from Amy Latrielle of Gavi, the Vaccine Alliance, a pivotal organization making vaccines accessible to many children in lower income countries, many countries where MSF works in, on their support to countries in fragile and humanitarian settings and their approaches to reaching unvaccinated children there. So just to sum up, growing conflicts, economic downturns, and a rise in vaccine hesitancy are some of the threats to the efforts to reach these unvaccinated children. So we'll wrap up this session with a lively panel discussion where we hope to hear from our panelists on what they think we all can be advocating for at the global, the national, and at the project level to bolster our efforts and ensure that more children get caught up on their vaccinations, and how we should go about doing that. We all have a role to play in this, and our aim in this session is to inspire you and to motivate you to use your voice and leverage your influence in the promotion of vaccination. So if you're ready, let's begin. So our first speaker is Ms. Sarah Wanyoike, who is on WHO's Vaccine Preventable Diseases Inter-Country Support Team. She's currently leading the team overseeing vaccine preventable disease activities in across 20 countries in East and Southern Africa. She's a public health expert with over 20 years of experience working in public health, supporting various initiatives at the national, regional, and international organizations. And the title of her talk is Vaccine Preventable Diseases and Vaccination Coverage, the Global and Regional Situation and Response. Sarah, welcome.
Great, thank you, Sharmila. And good morning, everybody. Habari zenu? Glad to be back home. And thank you for having I'm actually really pleased to be here with you guys presenting for MSF. I think it's a step in the right direction in terms of what I'm going to speak to, about how we all need to make a concerted effort to consult with each other and see what we can do to improve this situation. So I think without further ado, I'm just going to dive into it and touch on some of the things that Dr. Sharmila has already mentioned in her presentation. So through this presentation, I'm basically going to be talking about the current situation, what we know about immunization in Africa today, the burden of zero-dose children in our country, in our continent, key takeaways from the status of immunization as of the data the best data that we have right now, and then lessons learned from COVID-19, and what is our role in putting us back on track. So I think to just start, maybe we can talk about some of the key achievements. I won't go into too much detail, but you've heard from Sharmila, we started with launching the EPI program in 1974. We had initially targeted 6 diseases, but now the EPI programs are targeting as many as 14 diseases that we see every day. And by mid-80s, all countries in the Africa region had established national immunization programs. The immunization efforts have resulted in about 51% deaths averted. So of the 140-something million children that deaths prevented through immunization globally, 51 million are in this region, deaths averted since the launch of the program in 1974. And this has resulted in the eradication of smallpox in 1979, while poliovirus was declared eradicated in our region in 2020. We also know that measles deaths have been averted up to about 19.5 million since the launch of the Measles Rubella Initiative in 2001. And we also know that for meningitis deaths, they've dropped by about 39% since 2000. And then maternal and neonatal tetanus elimination is very close. We have 43 out of 47 countries having been validated for elimination, which is very good for our region. So just a quick look at our milestones. Oh, thanks. All right, sorry about that. So I've briefly talked about where we are, and what we know is, as I mentioned, the EPI program was launched by WHO in 1974. And then in 1988, the Global Polio Program for Elimination, GPEI, was also launched for the eradication of polio. And then in the year 2000, the Gavi Vaccine Alliance, which is basically a partnership that is constituted of UNICEF, WHO, Gavi, and other partners, was also established. And we also know that Measles Rubella Initiative was established in 2001. We also launched the Global Vaccine Action Plan in 2012, which was later on revised and updated, which became the Immunization Agenda 2030. That was done in 2020. But before that, we also know in our region, our heads of states committed they made 10 commitments in 2017 to support immunization programming in our region for all of our countries. And we're in the process of preparing a status update for them to be shared with them next month. And we also know that after the Immunization Agenda 2030 was launched in 2020, in 2021, our ministers of health met and they actually they endorsed a framework for the implementation of these 2030 targets. So that is to say that all the targets I'm going to talk about, our heads of states and our ministers have already committed to supporting this work. So in terms of burden and where we are, so despite all this great work, unfortunately, every year, 30 million children in the region suffer from vaccine-preventable diseases. Out of those 30 million, about half of them actually die. That accounts for about 58% of deaths globally from vaccine-preventable diseases just in our region. And all these results in the recurrent outbreaks that we're seeing. We've talked a lot today about measles outbreaks, diphtheria outbreaks. We also know we've had some polio outbreaks. We also have yellow fever outbreaks. So there's a myriad of outbreaks that we're dealing with every day that can be prevented through vaccines. But as of 2022, based on a report that came out in last year, every July 15th, we usually get a report of how countries are doing, and this is reported by our national governments. So the report that came out last year in 2023 was looking at 2022 data. This is what our governments reported as the status of progress. So it's coming from them. So what we know is 13 out of 47 countries had achieved the 90% target for first dose DTP, the diphtheria, tetanus, pertussis containing vaccine. The first dose, only 13 out of the 47 countries. And we also know that coverage for first dose remained low, up to only 80%. The IA 2030 goal talks about 90% by the year 2030, so we still have work to do. The third dose was only at 72%. I hope most of you are familiar with all these doses and the schedules, and I'd be more than happy to talk about it after this presentation, because some of it might be a bit hazy. All right, and then in terms of MCV1, that's the measles-containing vaccine, the first dose, it dropped from 71% to 69% in 2022, and yet we are targeting 90% coverage by 2030. And then only 2 countries out of 41 have achieved the global target of second dose measles-containing vaccines. That is Seychelles and Mauritius. That's why we're seeing all these outbreaks. Then the number of children who received third dose oral polio vaccines was estimated at 71%. And for first dose IPV, that's the inactivated polio vaccine, was only 73%. So you can see our coverage rates still remain quite low, unfortunately, which is why we are leaving a lot of immunity gaps leading to the outbreaks that we are seeing. All right. So I'm not going to go so much into the numbers, but I just want you to take a look at the maps. Where you see the darker red, it means there's a lot of children who are yet to receive even a first dose of DTP, the pentavalent, which we usually call Penta 1 or diphtheria, tetanus, pertussis containing vaccine. So the darker the color, it means the more the children remaining unvaccinated. So you can see the progress between 2021, that's the first map, and 2022, which is the second map. Not much progress has happened. In fact, it's getting worse. And we're waiting to see what the data tells us in the coming July. I think the country is already reporting, so we'll see what the progress looks like. But on the very end, you see the graph, there's a red arrow that's going upwards. So in 2021, we had about 7.6 million children that were completely unvaccinated. And then in 2022, it got a little bit worse because now we were close to 7.8 million. Despite all the efforts on the ground, something is happening. So I won't go into all the numbers, but I can just mention briefly, we all talk about COVID pandemic. It did affect immunization programming. But before the pandemic, the program had already started to stagnate. All the progress we saw since 1974 was great, but over the last 10 years before the pandemic, the progress wasn't moving very well. So what COVID did is it just came and shattered an already fragile system that was going to actually just not do well with or without COVID. So I think COVID was part of it, but I think we need to talk about the health systems that we are working within. I think that really is where the problem is. So what are some of the key takeaways? What we know is immunization services in the Africa region have not yet fully recovered from disruption from the pandemic. In fact, we can actually say that we are completely off track to achieve the 2030 targets that have been set forth, the ones that our heads of states committed to. We also know that we need to accelerate the support and progress that we're trying to achieve to at least reach. So what has happened, that graph that I showed you about the 7.6, 7.8, we are estimating between 2019, since the onset of COVID, to about 2022, we ended up with about 28 million children unvaccinated. So right now, there's a lot of concerted efforts by partners globally, by donors, by immunization program managers, by governments to reach and vaccinate these children. And so also what we know is in February 2023, our heads of states met in Addis Ababa and committed to building momentum for routine immunization recovery in the region. So that means that they're going to prioritize universal access to immunization, as well as increasing and sustaining domestic investments for vaccine delivery. So the political will is there. The partners are there, the donors are there. We are also there, we're on the ground trying to get this to move. So we have to figure out what is it going to take to get to the targets we're trying to achieve. So this gives a fresh impetus to the implementation of measles and rubella elimination plans to achieve the set target of 95% and above of at least the first dose of measles-containing vaccine. And so we are calling on your support to actually get to these targets. So we can talk a little bit about COVID and what we know. So COVID-19 underscored a critical need for Africa to prioritize pandemic preparedness. We were not ready, and so we suffered serious setbacks because we were unprepared. So while the pandemic caused unprecedented immunization backsliding, the vaccine itself was rolled out very fast. It's the fastest vaccine to be rolled out globally. So what can we learn from that? The first thing is preparedness. There's a need to strengthen our public health systems and health security across the continent, not just in one country, but across all the countries. And this will require establishing a network of early warning and preparedness systems. Then there is also a need for Africa-led research. The recently concluded RITAG, which is a regional technical advisory group, which meets twice a year to advise our regional director for WHO on some of the key strategic priorities and policy recommendations that should be coming from WHO. They came out with a recommendation talking about the need to increase investments for Africa-led research and development, which includes basic and applied research, as well as clinical studies that support the development and introduction of vaccines for Africans. Then there's the need for independent manufacturing. I think there's a lot of discussions. If you've been watching the news, if you've been reading a lot on the internet, there's a lot of money being put forward to have manufacturing being done in the region. And so as part of the preparedness for future pandemics, we need to increase investments and innovations for local vaccine manufacturing, particularly focusing on the continually strengthening of regulatory and ethics capacity building, while supporting preparations for vaccines through some of our regulatory networks. So within WHO, we have a group called the AVAREF. They convene regulators for vaccine in the region. And what they do is they look at ethics and regulatory issues around vaccine production, particularly with the upcoming discussions around local manufacturing of vaccines. Then lastly is the need for health system strengthening. What we know is we now need better and more resilient health systems. So working within an immunization program is great, but if it's set up in a system that's not strong enough, we've seen what can happen. So I think COVID did do something to us, but it's mostly because our systems need strengthening. All right, so what is our role in getting us back on track to the 2030 targets? The first one is, I've already mentioned how our member states have committed through our heads of states to catch up, restore, and strengthen our programs. I won't go into the details of this, so I think you'll see there just to save time. I think the key one here is, so typically we have the routine immunization schedules, which are guided by national policies for immunization. But now what we are asking governments to do is to look at those policies and revise them. So if a child missed, for example, a measles vaccine at 9 months, can I still give that child measles vaccine when they come in at 18 months, 16 months? Those policies have to be revised to accommodate these children who missed the vaccines. So that's the work we're currently doing with our governments. And then there's also a need to leverage other primary healthcare platforms to move towards a life course approach, because now we have HPV vaccination, we have COVID vaccination, we also have maternal prenatal vaccines that are also coming up. Also, we've called upon donors to prioritize closing the funding gaps. Particularly, a lot of investments were made for COVID-19 to strengthen the COVID-19 service delivery, but now we are asking for that money to be used to other parts of the program that need strengthening. We're also working with agencies to mobilize public support and demand for the vaccines. Lastly, we are also asking agencies to support the global immunization advocacy and strengthening and collaboration across other sectors, which is why we're here today. We also hope that others will continue to showcase the progress that has been made this year. As Shamila said, this is a very important year because this is the 50th birthday of immunization globally. We just celebrated the Africa Vaccination Week. We have so much to celebrate, and we have to continue showcasing how much can be achieved through immunization. And I have to mention that I know in our region, our governments typically, it's very difficult to sell prevention. It's usually a curative approach that seems to be taken by most of our decision-making during the policy decision-making in our governments. But prevention is always a hard sell. Why should I invest in something that's not a problem yet? But yet we see the problem every day. So anyway, without further ado, thank you very much.
Thank you so much, Sarah. That was really enlightening. So I'd like to introduce our next speaker, Mr. Gabriel Quach. Is from Unity State in South Sudan, and he's currently the Nursing Activity Manager and Palliative Care Focal Point with MSF OCA in Bentiu IDP Hospital. After schooling in Uganda and receiving his nursing certificate and diploma in South Sudan, he's been working as a nurse and then as a nurse supervisor with MSF OCA for the past 13 years. And he's going to be giving a project testimony called The Reality and Impact of a Measles Outbreak in MSF in South Sudan. So, Gabriel, please. Thanks.
Good morning. I'm so grateful to be here to share our experience with measles outbreaks and the impact of measles in our projects. And I'm also thank the organizers of this event. It's a really very important event to come together and share our experience and look for the way forward. For you, I'm going to talk about measles outbreaks in South Sudan, Bentiu, IDP camp, as this happened in December, sorry, happened in 2023. Next slide. Next slide, please. There is, yeah. You see that is a Bentiu IDP camp. We was established after the conflict in South Sudan, 2013. MSF was existing in the main town, Bentiu, and then moved to the camp when the war destroyed the town, and then MSF went in the UNIMIS or UN base. This is the map of the camp. The camp faced a lot of challenges. One of it is population density. There's a population, and the area is very small, about around 2 kilometers square. And then we have also a problem of severe wash limitation. The water sanitation are limits. Toilet facilities are not available for the displaced population. And then with that challenges of wash, there is occurring outbreaks, hepatitis E, cholera, and then high rate of malnutrition. We also face the challenges of during rainy season, the logistic challenges. There's the supply to come to the camp is a challenge. Almost everything come by air. That is a map of South Sudan. You see in red is the MSF project in South Sudan. MSF is playing a big role in South Sudan, providing a quality health care to the population. Next slide. You see that is a graph of the small data from measles outbreaks. The measles outbreak, we see some cases, a few cases in April, and then June, in May, sorry, and then June, you know, there was a conflict in Sudan, and then people fled back to South Sudanese, and Sudanese refugees came to the border. So with that, you see the increase in June because of the influx of returnees from Sudan and Sudanese refugees. So we see the increase, the graph, go back to the graph. In blacks is a returnees, in red is a resident. Like in June, there is no cases recorded as a resident. When you go to July, and there was some cases of the resident, because when the returnees came, you know, most of them are with measles outbreaks. And then there was, this was a mortality and total cases. The trend of mortality and at the beginning, this was fine, and then there was a number of deaths. We will talk about in the next slide later because of the patient come in late presentation. Next slide. Our case management, and before the outbreaks, there was the isolated ward capacity was only 10 beds, but when we have outbreaks, we increase 4 times. We increase our bed capacity from 10 to 40 plus. Even we open OPD system within the measles isolation and during daytime, and then during night the triage and OPD system is done in the ER. All cases with complication of measles are admitted or were admitted and treated according to the MSF guideline. We did a routine nursing care, cleaning patient eyes. We give them vitamin A, and then we give nutrition support and encourage those who are still breastfeeding to breastfeed their loved one. Interdepartmental response or interdepartmental response to the measles outbreaks. We have HR. HR increased the number of manpower in the unit. They recruited some nurses, and they recruited COs and MDs to respond to the outbreaks. Medical team provide medical care, organizing, planning, and coordinate patient care. Logistics also created because of the measles outbreak. Our ward capacity of 10 beds, we increased, they contract another temporary ward, and then they renovated the isolation tukul. For those of you who maybe went to Binti, we have many isolation areas. And also Watson, get water supply, waste management, and cleaning. Health promotion team carry out community engagement and awareness plus early education in the hospital, also outside the hospital like Rukona and the camp. Our coordination in Juba and headquarters also did some advocacy and proposed for additional budget for 3 months. This is the impacts. Impact of measles outbreaks on the community and the population. This is a testimony from the survivor. The returnees, those who come from Sudan because of conflicts, they spent several days on the way before reaching our hospital. And then most of them use the River Nile. They stay on the boat. Many children with the measles diseases died in the boat. And then it's very difficult for the mothers because of the journey. It's difficult for the mother to bury their loved one. And they keep their loved one, the dead baby, inside the boat for days, even 2 days, before they reach the docking point where they can go down and bury their loved one. It is very shocking, and then it brings a lot of anxieties and psychological issues to the population, even the staff and the patient and their family. Next slide. There is factors affecting the severity of the outbreaks. When the conflict started, as I said earlier, conflict started in Sudan. There was a lot of roadblocks. It is not easy for people to move. Not easy for people to move. And then there was, in the border, they cannot reach our hospital. That lead to the delayment for them to present to the hospital. Also, they lack knowledge of where to go when they reach because they don't know where MSF is, or they don't know about health facility. Even before the conflict, the South Sudanese in Sudan, they have low, access or poor access to the health care, even before the conflicts. Malnutrition also contributed to the severity of the measles. You know, there is an interrelationship between measles and malnutrition. This increases the high mortality and the severity of the symptom. Challenges. We face a lot of challenges, high mortality rate, up to 25% at the peaks of the outbreaks. You know, as I mentioned before, the risk factors, you know, people, patient delayed because of the roadblocks, because they don't know where to go, and then lack of food and lack of things contribute to the high mortality. At the peak of the outbreaks, our mortality rate go up to 25%. We have challenges we face, ruptures because of, you know, we did not prepare for the outbreaks, a lot of medical supply ruptured. The last one. What we could have been done better. I think we need to respond, how we need to improve our awareness and preparedness to increase our capacity for the emergency response at the border point and at the port. Improve advocacy through the health cluster meeting and division of tasks and services between the health actors. Debriefing session after the outbreaks for the team who are involved in the outbreaks, this should be better. Provision of mobile clinics and ambulance services for the rural community and rural population. I will end here because of time. Thank you so much. I'm so glad.
Thank you, Gabrielle. So unfortunately, our next speaker from Gavi, who was supposed to join us virtually, is not able to join us today. So instead, I think we'll go back to our polling questions, if we can pull them up now. Can we pull up the questions? Yes? Yes, wonderful. Okay, so we have the first question up. Okay, yeah, this is actually question 2. Do we have question 1? If not, no big deal. Okay, so whose role is it to, and first, if you have your app, I think you can answer your question on the app, so we'll see if this works. Oh, okay. Whose role is it to ensure a child is fully vaccinated? The nurse, community health worker, nutritionist, or all of the above? I'll give you a few seconds. Okay, I guess everybody is providing the correct answer, which is great, 100%. It's all of the above. You answered correctly. Well done. Okay. Yes, okay, give yourselves a round of applause. So this is a really nice setup for our next presenter. Our next presenter is Catherine Bashi. She is she's a Belgian emergency room nurse, epidemiologist, and vaccinologist with extensive MSF field experience from 1993 to 2000. She's also worked as an epidemiologist and trainer for Epicentre. And since 2015, she's been the vaccination advisor in the medical department of MSF in Brussels. And Catherine is going to talk to us about missed opportunities for vaccination. No, she's not.
Thank you. I'm presenting here today, but on behalf of the vaccination working group. And I will actually try to give you ideas on how to maximize vaccination opportunities in MSF. So as a humanitarian medical organization, we have a duty to protect the most vulnerable. Children under 5 usually pay a heavy price when conflict, insecurity, displacement, disasters, or epidemic disrupt the system that is supposed to protect them. And all of us are very busy trying to deal with the many competing activities needed for them to survive to what is threatening their lives. And we are right to do so. Yet, we have a very powerful tool that would arm them to fight many diseases and protect their future. And it is the responsibility of each of us to give them this chance by offering systematic catch-up vaccination to all eligible children and pregnant women in all projects at every opportunity. Dr. Barry presented earlier the result of his evaluation of missed vaccination opportunities in Guinea. Another poster of a similar study done in Sierra Leone is available online. These evaluations are very often the first steps to recognize that there is a problem and to measure it. And we have developed standardized guidelines, training material, questionnaires, and database to facilitate these evaluations. These evaluations provide essential data that we need to advocate for change. But in our projects, where do we find the children that may be eligible for vaccines? Well, most of them are actually our patients. They are coming for consultation or hospitalization. They are enrolled in our nutrition programs or belong to a cohort of chronic patients. But they can also be just accompanying patients, other patients that we see in all these programs, and a few others. So whatever the reason leading to the encounter with a child, we should take advantage of it to protect the child. Ideally, we should offer a tetanus diphtheria containing vaccine to all pregnant women, and not only pregnant, but all women of childbearing age, to protect them and their newborn against tetanus, and give BCG, hepatitis B, and oral polio vaccine to every newborn as soon as possible after birth. Children up to 5 years of age should be offered catch-up vaccines, meaning the vaccines that they missed during their childhood, for all antigens included in their national program of immunization. This is part of the big catch-up campaigns that is financed by Gavi. Unfortunately, you didn't get this information, but Gavi is actually financing the big catch-up policy that for the next 18 months. And that will allow the countries to get vaccines for children up to 5 years of age. And this catch-up policy should remain beyond these 18 months in the country. And definitely it should also remain in our project. Older eligible children should be given at least a measles and a tetanus diphtheria containing vaccines, but other vaccines should also be added if indicated. And finally, some specific medical conditions such as asplenia or HIV require the use of vaccines in their treatment protocols, and these protocols should be respected. Each of us has a specific role to play. It starts with the health promoters and the community health workers, without which nothing would be possible. Because as it became obvious after COVID, it is actually not the vaccines that are saving lives, but vaccination. And disinformation is a real threat to this life-saving activity. Parents have the major role of bringing their child to the vaccination service and treasure the vaccination card that they're being given. The consulting agents, medical doctors, and other health professionals should systematically check the vaccination status of the children they see and refer them to the vaccination services when needed. The midwives should vaccinate all eligible women and newborn, and the vaccinators should vaccinate all eligible children getting to their services. Of course, all vaccination data should be reported to the health authorities. We have several tools to help defining the eligibility to catch a vaccine. The first one, is not coming. The first one is the old and too often missing vaccination card, but its analysis requires training and quite some experience. The second is a paper algorithm that we developed. It's a little bit easier to use. And last year, we developed a very powerful app in eCare called eCare Vaxi that integrates all vaccination algorithms. But the caveat is that the vaccination history of the child has to be entered at every encounter, which is quite time-consuming. And finally, we have the latest edition called the Vaccinometer, and I will get it. No. No. I'm getting back. Yep. All right. So the Vaccinometer here looks like this. It's a wheel. It's a plastic wheel, and with the algorithm based on WHO recommendation for catch-up vaccination. And the eligibility to vaccine is displayed according to the age of the child and the history of vaccination. It has been piloted in a few priority countries and will soon be available for purchase in 5 different languages through the supply centers of MSF. I have brought a few in English with me, and so if you're interested, feel free to come to see me at any break. I will try to find a table, and you can start playing with it. Yep. It's a pain in difficult. Can we go back, please? Back here. Okay. Beside the individual role of frontline workers, we also have to seize programmatic opportunities. In all programs with consultation or hospitalization, we have to create a circuit for the patient to avoid missed vaccination opportunities, hire and train enough staff, and of course, ensure supply of good quality vaccines. In programs where we do not see patients, such as environmental health programs or distribution of non-food items, we should still inform and promote vaccination. And in humanitarian emergencies, the core of our job, we should organize multi-antigen preventive mass vaccination campaigns. You know, that would have been very useful in the case described earlier in South Sudan. And we should also add opportunistic preventive vaccines to every mass vaccination campaign organized in response to epidemic. We should make all our campaigns becoming multi-antigen vaccination campaigns. We should also support as much as possible national initiatives, such as periodic intensification of routine immunization, supplementary immunization activities, or national campaigns, such as the ones organized for polio. And we should, of course, maximize The next slide, please. We should maximize synergies with other interventions and develop new strategies to get the zero-dose children that are often the hardest to reach. Next slide, please. Next, new initiatives, such as this passive active cold chain backpack called Indigo, that has enough autonomy to ensure stability of the temperature between 2 and 8 degrees for 5 days, will contribute to reach the 1 million of unvaccinated children. Next slide, please. Every change counts. Everyone has a role to play. It is humanly possible, and together we can do it.
Thank you, Catherine. So our next speaker, our final speaker before the panel discussion, is Dr. Faustin Bibiantio Ntalemwa. Dr. Faustin is a general practitioner with 10 years of experience, including 5 years with MSF OCBA and its emergency response and surveillance project in Congo. Through his work, he's acquired significant experience in the management of medical humanitarian emergencies in the context of epidemics, violence and population displacement, and nutritional and complex emergencies. So Dr. Faustin is going to be giving us an insight into opportunistic multi-antigen campaigns. Thank you, Dr. Faustin.
Merci de la parole. Bonjour à tous. Je suis Dr Faustin, comme on l'a dit, médecin en projet de réponse aux urgences pour la mission de MSF OCBA en République démocratique du Congo. Nous allons faire une présentation sur la campagne de vaccination réactive multi-antigène. Ici, il est question de vous présenter notre expérience. Et pour ce faire, nous aurons un plan à suivre.
We're going to start, first of all, a short presentation of Mr. Akuba in Congo. A presentation with the context of behavior in Congo and the impact that we've been able to observe with the vaccination of antigen. Another point would be we are going to project some activities that we realized, but also we're going to make an analysis comparison between the vaccination antigen and another vaccination before we will share our lessons learned and finish by recommendations from our panelists. For those who are in the mission of MSF in RDC since 2001, they work regularly.
Projet régulier. S'il faut prendre la moyenne, il y a des projets avec une moyenne de 2 ans, mais le plus long, on fait.
There are projects with 2 years so far. The regular programs or projects are in 2 regions. And still in the eastern part of DRC. We also work in the area of emergency since the year 2009, and this has moved for long. Considering our area of intervention, this project has been granted more space to serve in South Kivu and 2022 in the province of Maniema. It is a team that can survey 35 health centers in the eastern part of the country, South Kivu and Maniema. And the agents are the same. We are considering pandemics, violence, and people's displacement, which is the case right now with what is happening in the North Kivu. There is also many who are wounded. Some criteria of interventions, i.e. epidemiological and biologicals, that do consider operational criteria, and they are also contextualized. In terms of experience vis-a-vis the project, since its creation, the emergency has brought about 15 vaccinations and 2 mass vaccinations against measles. Here is the context of DRC. We said it, we are in the eastern part of the Democratic Republic of the Congo. Some 10 years ago, there have been this matter in the area, especially insecurity. The rights of children are threatened, and here there is matters to do protection and access to health, be it promotional, preventive, or curational. And as proof, our national coverage is low. We speak of 20% of children. 0 dose. We reach 56% of vaccination cover. It is almost like the presentation of what my colleague that preceded had mentioned. Sometimes there is a problem that has to do with the age of the parent, the provenance and the religion of the parents, the level of instruction or education, the lifestyle, but also the impact of COVID-19 most recently. Other problems are in some regions we have chains of cold, in some places it doesn't exist, and some others those chambers are non-existent, or if there are, they're not functional. There is also rupture. So there is no sufficient sensitization on key markers so far. There is also some weaknesses in terms of structure, i.e. birth rate is increasing, security and the geographical aspects. Now, what are the impacts that we want to see? The vaccination will help us reach children, which will improve vaccine, and also we will use the resources to reduce the number of vaccination sessions, but also we find that the efficacy of the vaccines have augmented or added. Logistically speaking, there is much to do with time, planning, stowage, and vaccine distributions. Multi-antigens, we think they are beneficial than the mono. It also reduces the risks and also grows equity. The third point, we will speak of pillars of interventions on strategy. The first point is advocacy in the area of strategy. Since the year 2015 that we have done advocacy to the government in order to bring this campaign in its national policy. And so there is this epidemiological knowledge that needs to add to increase, and in the government, and also coordination with BCZ and other actors. There is need for vaccine, guarantee for vaccine, so there is need to have massive vaccination. Of course, it will depend on the epidemiological analysis where we can do massive vaccination based on targeted areas or all health centers. And with this, we do associate professional testing and deparasitage in all other areas. We have also written some work to do. There is need for us to succeed in this vaccination. And finally, for the strategy, we need to consider CASAP and complex cases without forgetting others, i.e. respiratory cases of malaria and others. Here are some indicators that were done in various sections. And for those who do monoantigenic vaccination for the year 2022, but for Okuba, we were able to do multi-genic. So in the year 2022, the emergency team brought about 3 cases, 3 groups. You can see the data in various health centers that happen in many in counties or provinces in Eastern Congo.
Voilà notre petite analyse comparée.
And these are the studies done between the two, because most often we think that if we need to vaccinate all the children with the multi-antigenic, we might have more need of budgetary need and resources. Yes, for some needs, it may increase, but when you make arithmetics, you'll see the difference is not large. The comparison here, you will see that the number of vaccinated children is not the same. In Olingo, we were able to vaccinate all the children. You see, in all those cases, we were able to reach our vaccine cover. Considering the need, countering the days of vaccination, we need to agree on how to go about it. We need this number of days in order to cover. Yes, now with the teams, we need to have many teams, and the team should be made because we need to increase in number. And for a monoantigenic vaccine, maybe 157 people per team, but for the other, we need 12 to 14 people. And sometimes these are staffs who we need to look for because maybe they are not available in the area of intervention. And in the logistical matters, the need increases, be it the number of freezers, generators, motorbikes where necessary, because in Eastern DRC there are places that cars cannot move, even not the flights, and so we need to use motorbikes or motorcycles, and so you need to consider how to give contracts to those people. Sometimes people hire those motorcycles. Now, in terms of costs, for a monoantigen, for every child vaccinated, we will spend about 6.35 euro, but for multi-antigenic, we will only spend 7.7 euro. So there is a cumulative effect because of considering the number, when the number is high vis-a-vis vaccination. Learned lessons. Strengths. Multi-antigenic vaccines give a lengthy protection. There is strong logistics, which is assured. It allows us to cut costs, because if we want to do many vaccinations for multi-antigenics, that will be more costly. We also have a positive thing that is public simplicity. Now, the weakness is complexity in planning, risk of confusion. The people may not understand what the vaccine is about, and sometimes that will make and create resistance to the vaccine. Team supervision can also be a challenge. It is very hard in areas that are not easily accessible, or sometimes we do not have a sufficient network connection. But also there are challenges to do with how much people will accept when these injections, because parents are asking, why is my child going to receive 2-3 injections? These are challenges we face. However, we're going to finish with some recommendations. For us, we think that MSF, in its antigenic vaccination, there is need to have a strategic, there's need to have a strategic operation. If we need to activate the monogenic vaccine, teams should get sufficient information on how to run it. We do recommend for the planning, let there be sufficient financial resource available. There should also be catch-up vaccinations, especially in cases of pediatric cases, and we also suggest, in collaboration with the Ministry of Health, organizing vaccination catch-up, massive vaccination campaigns, and finally we need to consider coordination and the community in our activities. Thank you very much. Thank you, Doctor.
Now we're going to change gears a little bit, and we're going to have a panel discussion. It's being led by Dr. Neil Russell, so I will invite Neil to the stage and also the other panelists to the stage. I'll introduce Neil first. Neil Russell is a pediatrician with many years of MSF experience, and he's a member of the MSF Paediatric Working Group. Neil, please join.
Habari zenu. You should have learned that already from Sarah. Should we try again? Habari zenu. Okay, good. Shamil, is Amy joining us? No, okay, yeah, okay. So thank you very much. I think we've got until, I can't see the clock, but I think we've got until about 1:15, right? Because I know you're going to be hungry. I think we'll just carry on until we see someone doing this aggressively from the front row, and then we'll just stop there, yeah. In addition to Catherine Bashi from MSF that you've already heard from, has been introduced, and Sarah Wanyawike from WHO, who's already been introduced as well. We're also very lucky to have today also Mohammed Dialdin Omar, and he is a medical doctor and public health specialist with more than 20 years experience working with both NGOs, UN, and government organizations in both the development and humanitarian sector. And he now works with UNICEF in the East and Southern African Regional Office, particularly focusing on accelerated disease control, especially measles, rubella, yellow fever, and tetanus. We're also lucky to have here Victorine de Miliano, and she is a vaccine and policy advisor for the MSF Access campaign. And the Access campaign focuses on advocacy and campaigning for better prices for medicines and better access to medical products, including vaccination. And she's also on the civil society organization steering committee for Gavi as well. So she may have stuff to say about Gavi. And we also have Degamledet Tesfaye Woku, or Dagi, as many of us in MSF know him. He is a medical doctor also with huge experience with MSF over 20 years. He's worked in both medical and operational roles. And he's currently the emergency program manager for MSF Waka, or Western Central Africa. And he also was instrumental in our response to the diphtheria outbreak that you've heard about. And Amy was going to join us, but unfortunately can't make it today, Amy Latriel. So she's the program director for fragile and conflict-affected settings. And the reason that Gabby's an important actor is they are putting this focus on fragile and conflict-affected settings and zero-dose children. So that we want to focus in this panel on those kind of settings. That's where MSF really is focused, fragile and conflict-affected settings. And I just want to start this. Are you hearing me okay in the room? Okay, good. You should be also warming up your questions as well. We're going to start with a couple of questions to the panel, and then we want to hear from you in the room and also online as well. So I just want to start by doing a 1-minute story, okay? Which gives you an idea of my motivation for being involved in this. So I've got a piece of paper here, and I'm going to tell you the story about this piece of paper. Before I received this piece of paper, I'm not sure that I really understood the importance of vaccination, okay? This was given to me by a member of a community in a fragile and conflict-affected setting, not very far from here, not this country, but not far away. And they insisted that I do something with this piece of paper. So this piece of paper has got the names of 17 children on it. And this was given to me when I was doing a visit to a clinic in a remote area in this fragile and conflict-affected setting. And I was there in my MSF car, with my MSF jacket, feeling very proud of myself, as we often do in MSF. I don't know if anybody's noticed that. I got out of the car, I went to speak to the community leaders. I felt very important, getting to speak to the community leaders, making me feel even more overinflated self-importance, which we're also good at. And I was explaining to them that I'd come to visit the clinic just to see how it's running and see how the pediatric care was going, okay? And they said, well, that's very nice. We've got a better idea for you. We've got a better idea for you. We've just come out of a measles epidemic that's had a huge impact on our community. The measles epidemic started last year, and it wasn't until 5 months later that we had a vaccination response, despite begging for that during that time. And they said that we're not sure that you're going to really understand or believe us when we tell you the impact that this has had on us. So what they did, they insisted on taking me to see all of the graves of every child that they had lost during that measles epidemic. We spent maybe 2 hours going from one to another. And in that particular community, children who die are buried right outside the front door of their house, of the tukul, right? So as a parent, you'll walk past that child that you've lost every time you walk out of your house, okay? It just shows you how much value the children have in that society. And we met the parents and as well. They weren't able to show me all of the graves because, so instead they insisted on giving me this list. I'm not going to read out the names for obvious reasons. They had 7 children that died in that community. 8 children died on the road, on the way to the MSF supported hospital. And they are buried at the side of the road, okay? A bit like what you heard from Gabriel earlier. And 2 children died after arriving at the MSF hospital. We were very proud of ourselves for having a low mortality rate in our measles ward. We admitted hundreds of children with measles, and we had a very low mortality. Only 2 died. But we were not seeing the real impact in the community. And I think that that's the case for a lot of us that are there in front of the patients. We don't necessarily see that. And I'm going to stop there, and I'm going to now move to the panel. And to you guys, I want to hear your questions as well. So in light of the impact that we're hearing about, and this kind of impact on real people, Catherine, let's go to you first. What is holding us back in doing better on vaccination in MSF? Let's start with MSF. And people who are frontline healthcare workers, what can they take away from this conference and do differently, better, when they go back to their projects, treating patients usually? Usually we're focused on treatment. What can we do better? What's holding us back? What can we do better?
Well, I hope my talk was clear enough about, what's the role of everyone. I think what is holding us back is ourselves as an institution, because we built MSF on responding to emergencies, and responding to an outbreak is part of our DNA, and we have this momentum of responding, and we need a shift of mindset. Each of us needs this shift of mindset towards preventing diseases, and I think that's all that is needed. And you know, I'm really hoping. I mean, I've been in MSF for 30 years. I'm really hoping for seeing that change still being in MSF.
Okay, so I'm hearing about the shift in mindset. Okay, so most of us spend most of our time treating children, but preventing illness. So shifting that mindset to prevention, even if your role is not related to vaccination, perhaps. So you're treating children normally, maybe not realizing that a lot of the illnesses they have are actually vaccine preventable. So that's at the project level. If we move up to the sort of national level, coordination of outbreak response and prevention of outbreaks, what do you think, Dagi, do you have any thoughts about how we could be doing better at national level, coordinating response and prevention of outbreaks?
I think we just have to walk the talk, not only make it rhetorical, but be practically engaged in making sure national authorities understand the magnitude and scope of the problems they are facing and they are likely to face, and make sure that we work in partnership with them so that policy changes are put in place, and we also support them in implementing vaccination activities. So we need to talk, we need to walk the talk. Thank you.
And if I can come to you, Mohammed, so I know you've got a lot of experience with NGOs and UN organizations and government. We don't have any representation here from ministries of health, so we do want to hear from them, from any in the room later. Can you tell us about where you'd like to see MSF's role and what gaps do you think MSF should be filling, or things that you think MSF should be doing a bit better from your perspective, from UNICEF's perspective, but also from your experience?
Thank you and good afternoon. I think the effort and role that MSF is playing should be commended. And when we are talking about vaccination, we are talking about, like, it's not one time, event or task. It's a continuous, and the advocacy effort should also be continuous. MSF is doing a good job, and it has role and approach. I think I had the opportunity to work closely with MSF in Ethiopia, in Sudan. From my experience, I think this coordination and collaboration between other partners and MSF should be improved. We all know that all the challenges and constraints on the grounds, but always there are ways to find local solution to improve this coordination and collaboration for the sake of the children and to reach those who are unvaccinated or under-vaccinated in humanitarian and emergency settings. Thank you.
Maybe Sarah, I could come to you and say, with this, there's what you were saying earlier is that the political will is there, and these ambitious targets have been set for 2030. Can you tell us a bit more about what will it take from different partners to get to those targets? What do you think that what do you want to see from MSF as well, but also in general?
Yeah, thank you. I think that's a very important question. I think we're all asking ourselves the same question because there's a lot of effort that's been put in place, and thanks so much to MSF. I think a lot has been done, and it doesn't always come out for everybody to see, which points to the issue is working together transparently. To be honest with you, zero-dose children are always in the most obvious communities. It's not always in the hard-to-reach areas. Here in Kenya, the biggest number of zero-dose children will be here in Nairobi. They're not going to be in Kajiado, Marsabit, Garissa. The biggest number will be here in Nairobi. And yet we have so many partners in Kibera, we have so many NGOs. But what are they doing? It's not always transparent to the government. The will is there, the resources are there, but partners are getting the resources and going to their corner and doing the activity. Another one is doing the activity. Not the same for MSF. I'm just giving an example, but I've seen this. So I think it's the issue of being transparent with what we're doing and being coordinated, I think, as you brought up, coming to the table. And I think this is very good that you've invited WHO and UNICEF to this gathering, and I think now we need to do it the other way around. Where immunization is being discussed by WHO, UNICEF, and government, MSF should be at the table, and all the other partners, so that you bring what you're doing, so that one, there's no duplication of efforts, and that we're also optimizing the resources you're getting. And I was very impressed to see that study in DRC, really showing how multi-antigen campaigns actually save money. But we won't know this if you don't come to the table. If you have MSF convenings, it's great, and you've invited us. Now we'll make sure you're invited on the other side, so that you also tell us what you're doing. The other thing is advocate. You're the ones on the ground. You're seeing what's happening. So we're involved so much in policy, paperwork. But these perspectives you're bringing are so critical. They lack voices on the table. So we have to be intentional that MSF's voice, people on the ground, should be at the table when these discussions are being had. Yeah.
Thank you very much. That's really helpful. So we need to be at the table. So those of you who are at tables now, you can start raising your hands to start asking questions as well. So start warming up. I want to just turn to Victorine, because I want to hear from you at the Access campaign. What is MSF asking others to do? So the global community, what does MSF want Gavi to do more of? I know Gavi's not here to respond, but I think we can still go for it. What do you think? What are we calling on others to be doing more of? And you need a microphone.
Thank you. Yeah, so this is too bad that Gavi is not here today, because there is much more that Gavi be doing in terms of reaching children in humanitarian settings, fragile settings, hard to reach settings, because the way currently the model is operating is that everything goes to the Ministry of Health, and that means that many children that are not reached by the Ministry of Health for whatever reason are not reached. And so we need to advocate at the global level that it's not just children that can be reached that are being reached, but also the ones that really should be reached based on needs. And because, currently, as we've been talking about today, we keep responding to outbreaks because we fail to prevent. And we are globally behind on key indicators when it comes to immunization. So MCV, and I think Sarah mentioned that, MCV2, DTP3, equity, also equity in immunization, not just between countries, but also within countries. We're behind on all these key indicators, quite basic indicators, but key indicators when it comes to immunization. And when it comes to areas where, for example, the Ministry of Health can or will not vaccinate, it's not always possible for humanitarian actors to vaccinate there either. So what Gavi, for example, could be doing is setting up framework agreements that allow, instead of always ad hoc advocating, which takes months or weeks, or it's just often a very long an activity that takes a lot of time we often do not have, is that there are agreements in place that allow for the operational space also for humanitarian actors to intervene where we see a need, but then also have access to, I think that was quite clearly mentioned in the presentation before on DRC, have guaranteed access to multi-antigen stockpiles as well, because also that access to vaccines is not always a given. So we talk a lot about vaccination today, but we don't always have the vaccines. And then a final point, sorry, taking a lot of time, but is this point of being able to vaccinate up until at least the age of 5, because currently national policies often do not allow for that, but also the global sort of, the way we fund vaccines do not allow for that. So there's the big catch-up happening at the moment, which was mentioned, which is allowing for vaccination up until the age of 5, and these vaccines will be financed by Gavi. But what happens in 2026? You know, so we need to make sure that from 2026 onwards, we can continue to reach children up until at least the age of 5 with vaccination, and we need to really loudly advocate for that.
Okay, that's brilliant. So I'm hearing about the age ranges also, and about the supply as well. It's something that we often hear from teams in the field, that we can't get access to the vaccine supply as well. That's what I'm also hearing. I'm not seeing any hands yet. In anything online, or here we go, we've got some hands. Just while somebody takes a microphone to you, Dagi, you were very heavily involved in the diphtheria outbreak recently, which has really been a huge shock to many people about how big that was. Not specifically about the particular country that you worked in, but what did you take away from that you learned in terms of outbreak response and things that we need to do better in? And then if someone could take a microphone to these guys here. I'm going to, oh, they do, okay. I'm just going to add that because we don't have somebody from a Ministry of Health here, we'd like you to ask a question, but if you're giving a Ministry of Health perspective, you get a special ticket and you're allowed to do a comment, okay? Just because we don't have Ministry of Health on the panel, so you get special access to you can do a comment as well, if you like. Please go ahead.
So I'll put it in two phases.
La première phase, c'était pas une question.
Availability of vaccines became an issue. So when we start, I'll give examples and the role of WHO, UNICEF in giving policy guidance and the role of governments in making sure that all the targeted children are reached. The Nigerian diphtheria response was very difficult to have the 2 to 4 years of age children included because there was nobody to give a policy guidance to the NCDC, to the state ministries of health, to vaccinate these children with the existing penta vaccines that were already available in the country. It has happened for so many reasons: political, lack of commitment, slow response. So by the time, and not really even properly looking at epidemiological data. At that point, probably as outbreak response, we should have vaccinated 2 years and more, and we could have said under 2 routine immunization program, because the numbers were not that high. And then the next stage came when the outbreak started to spread. There was much more commitment on improving the reactive vaccination campaign, but at this time, there are no vaccines. To give you an example, in Zindir, MSF was requested to support the vaccination campaign. There was a backdrop of 60 million doses of vaccines. So it was not really possible to do it. So there's a policy aspect, there are resource availability aspect, and there should be also a mechanism of acceleration of response from the donors, that we shouldn't go to a very long, protracted, time-consuming, devastating process. One of our colleagues was saying there were 10 patients dying every day. Okay, that was our experience in Kano. 10, 15 patients dying every day, and you just can't help them.
Thank you very much. I think we can go to the room now. I saw you two over there first. If you could just say your name and where you've come from, and also if you could just, if you want to direct it at any particular person in the panel or just in general. Thank you. You may need to. Do you want to take it? Yeah.
Yeah, good afternoon all. My name is George Ibrahim Kamara from Sierra Leone. I want to say thanks to Madam Sarah for the nice presentation she talked about, from the origin of vaccination to where we are. I'm also happy about the inclusion of the members, including the head of state. But my question here is, how authentic are these data they are giving you guys? Because, like for Sierra Leone, where I'm coming from, and they brought in this MDG just to reduce the child mortality. They presented the data. Thereafter, we are asked to reduce the mortality to 2/3. Then after presenting the data, they went further and they actually received the SDG. Now, currently, we are 105 per 1,000 life birth. And for the SDG, we are to reduce to 25 per 1,000. So was that data accurate? That's my question. Thank you.
Thank you very much. I think that was a question on data accuracy and how confident we can be in the quality of the data. I think that was from a slightly different region to where you two both work, but maybe if I can put that to both you, Sarah and Mohammed, about data quality and how to improve that. Yep.
Sure, yeah, thank you. I think I'll touch on it, but actually Mohammed works a lot on this, so he loves data, so I'm sure he'll have a lot to say. But I just wanted to say, the data we present is the best estimates we have. There's a lot of challenges with getting really true data. Because one, the estimated number of live births is just an estimation. Sometimes in some countries, we overestimate the number of children we have, or we underestimate. So already that denominator that we're using to calculate coverage might not be correct, but it is the best estimate. Now, we also see areas where, for example, we have very good coverage. Like in Nigeria, we have very good coverage. So to get now outbreaks is a bit questionable. But then there are other factors at play, by the way. Coverage is one thing. And this I mentioned some time ago is sometimes even that vaccine you're giving to the child, when we do our comprehensive reviews, we move facility to facility because we do, like right now in Rwanda, we are doing a comprehensive review of the entire program. Sometimes when you pick up the vial, when you're observing the nurses, they don't even check the VVM, the vaccine vial monitor status. So sometimes that vaccine is not even viable. But as far as she's concerned, she's administered it and she's documented it. When the data comes, it will show fantastic coverage. But the viability of that vaccine is questionable because she didn't check. And sometimes, for example, you're coming from Nairobi to Nakuru, and you might stop somewhere for lunch in that truck. No one is checking that vaccine. So there's a lot of programmatic challenges that lead to us questioning these coverage rates versus why we're still having outbreaks in some of the places where we've demonstrated some of the best coverages. But these are just estimates, and I'll let maybe Mohammed get deeper into it because he does this every day.
Thank you, Sarah. Just before I joined here, I was reviewing the data set for the East and South African region, 21 countries, for the 2023 immunization coverage. It's a big topic, and it needs time to discuss about it. But I think, in general, the methodology we use to estimate the coverage, WHO and UNICEF, depends on the administrative data coverage from the national government and also the coverage survey from different sources, in addition to triangulation from other sources of data, like supply, utilization, and so on, and also with the expert opinion at the national level or subnational level sometimes. We are not saying that this is like a perfect estimation or data coverage that we provide, but the methodology, I think we thought it's the best one. And if you have time, maybe during the lunch, we can discuss more on that. On the life averted, I think that was a modeling used by WHO, and also we can talk about it. It has its negative as well as positive aspects of accuracy. Thank you.
Yeah, I think that's a really important issue. Obviously, in fragile settings, conflict-affected settings, it's even more challenging to get the data that we need to know how to respond and also to advocate on the situation that's happening as well. So I think that's a really good question. Can I go? Would you like me to take you online? I'm going to prioritize a Ministry of Health perspective here. If there's any Ministry of Health that would representative who would like to talk, I'd like to hear from them. Let's go to online. Yeah, Melissa.
This is a question from online. I had a question. Start again. I had a question about catch-up and multi-antigen campaigns in practice. In South Darfur, pre-current conflict, we could only use MOH vaccines and were not officially allowed to do catch-up outside of EPI schedule. Secondly, we had multiple pertussis outbreaks, but without confirmatory testing, we're restricted in utilizing mass vaccination opportunistically as part of our response, or do a multi-antigen campaign as part of measles response. How to best overcome these institutional and policy barriers?
Thank you very much. That was related to, how to get the vaccine supply for multi-antigen campaigns and how to get authorization to do those campaigns in places that need it. I think I'm going to go to Catherine for you on that one. Is that okay?
Yeah, I think it's a good question, and in many countries we are actually not allowed to import vaccines, even for outbreak response. So we are depending on the willingness of the Ministry of Health to get or help, or receive it, and it's only negotiations. So I think the best way for being in good terms with them is just to have good relationship in peacetime, so that when conflict starts, then you're good to go. So I think it is super important to have good relationship with the UNICEF, with the EPI program at all times. So I think if you're based in a capital or even in a region, having regular contacts with these responsibles, and build relationships so that they do understand what's the added value of MSF or the potential added value of MSF in some circumstances, and being involved also in their routine immunization, strengthening their routine immunization, because that's a very important issue that I didn't mention. So whatever we do in MSF, we cannot mess up the system, because we will be there for a short period of time, and their system is what needs to remain. So whatever we do, we should not mess up with their system. We should strengthen their system. But their system has flaws or gaps. And we have a very good, very strong added value as a humanitarian worker to fill these gaps. And doing catch-up vaccination means that we are filling the gap of the program over the last years, right? This is where we have this real added value. I see one hand over there.
5 minutes left, yeah. Should we go to you over there? Yeah.
Hello. My name's Pete and I'm a pediatrician. I haven't worked for MSF for about 15 years now, but I'm working nearby here. Where I work, we see a couple of children every month with a clinical diagnosis of measles. But the local authorities are not very keen to come and do the testing because they don't want to report cases of measles, or that's the implication. There's a marginalized population just nearby, and I think the problem is much bigger than what we are seeing. We're just seeing the complicated cases. This is not an isolated problem. When I was working with MSF in South Sudan, we had a patient with acute flaccid paralysis, but the sample it got lost. When I was working in another country, they were reporting 100% IPT for children under 5 with TB exposure, which we all know never happens. So my question is, what can we do to reframe it, to make it that people are keen to report, keen to talk about what's wrong, rather than having this sense of pride about saying, we don't have polio, we don't have measles, our TB program is working well.
Thank you. That's right. I mean, in the end, in general, we're all looking for the same thing. Nobody wants to see zero-dose children, and it's about having those constructive relationships, isn't it? I do still want to hear from someone in the room from a Ministry of Health perspective, but maybe I can put that question to you, Sarah. Is that okay?
Yeah, thank you. I think thank you for being very pragmatic and honest about it, because we do run into these situations. But what we found is you'll find that the people who actually don't want to report, it's very subjective. Sometimes it's also political. Like if I'm the senator of this area, I don't want to say I have polio because I already told people I finished polio. Or if I'm the senator, I don't want to talk about diseases that I'm trying to show I've controlled. It looks bad on my record. But that's why it goes back to the point of MSF being on the table during routine discussions. Because these are the things, even if the sample doesn't make it to the lab, being part and parcel of the program allows you to also bring that perspective, so that even if it doesn't make it to the lab, at least you get to present during they have a ton of meetings at the EPI office here. And I think just having a representative from MSF that's part of that conversation. And we run into these problems. Like right now in Kenya, we know there's a measles outbreak, and it's taking too long to respond the way it needs to be responded to. Part of the reason you mentioned, sometimes it's these donor requests that are so long and protracted, and the measles just spins out of control. And this is where we need your voice. You come out and you say, guys, this is now going out of control. This thing is quite serious. But you won't get to say it at the clinic. No one will hear you. You'll only be heard when you routinely attend these discussions with the broader stakeholders, where it actually helps us continue to advocate, even with the donors who are holding us back with when we want to move quickly.
Thank you very much. I think oh yes, please.
Thank you very much. I just want to say something based on the experience we had from Kanu and with this diphtheria outbreak. MSF did a fantastic job for us. I think without them, we would have been tipping a lot of cases in terms of death, case fatality rate. But what I noticed is that from the Ministry of Health perspective is that the partners, there is no coordination in terms of their work plan and framework. And most of the partners' frameworks are quite rigid, not flexible. I think when we went into the outbreak, we wanted for the reactive vaccination to be put in place as soon as possible, but it took about, I think, 8 months before that kind of thing was put in place, and that time the outbreak spiraled out of control. Some of the partners that were involved in vaccination programs went on to be vaccinating children against polio and rotavirus. And so there is no priority in terms of the disease that we're battling at that time. So I think there is need for synergy between the partners, and time frame should be more flexible. Thank you.
Thank you very much. I'm seeing that we need to start wrapping it up, right? Yeah. Definitely a hard stop there. One more. Okay. When we talk about vaccination, we often go into discussion about outbreak response. But one of the things I know that from Catherine and from others, MSF is trying to think differently about is preventing the outbreaks happening in the first place, right? So more of these multi-antigen campaigns and more prevention, not focusing only on responding to outbreaks, but actually preventing them. And that requires the prevention mindset. If anyone's got a question related to that, I'd love to hear it. If not, we can take one more question. You look very enthusiastic there, so I think we'll have to take your question.
Yeah. Okay, please pardon my curiosity. I think you've emphasized so much on the need for MSF to be on the table during discussions on this subject matter. The question is, why is MSF not yet on the table?
Who is it for?
The WHO.
Sorry?
WHO.
Okay, for Sarah.
Yes.
Why do you think MSF is not at the table? You defer to Mohammed.
Interesting one, and also the one of the vaccines and the supplies when you need to respond to outbreaks at the national or subnational level, I think. And most of the times that I have contact with MSF is about vaccines. We need the vaccines because we need to respond and so on. So I would like to mention that MSF is a founding member of the ICG, International Coordinating Group, for vaccination provision of cholera, yellow fever, meningitis, and also Ebola. They are doing a fantastic job with others, UNICEF, WHO, and IFRC. So the issue is that why we improve this coordination at the country level and sub-country level. So at that level, there is a good coordination and they manage well. The issue is at the national level. Maybe the contexts are different from country to country. There are governments, bodies, there are authorities, and so on. I think it's a call from now. We need to improve our coordinations at the country level and sub-country. It's not about only give us vaccines because we also don't have authority on the government. They manage the vaccine and the stock out. They are preventing the stock out for the routine immunization. But we can talk a lot about this.
Yeah, and maybe just to add, so the other thing we do have at the regional level, we have a regional working group. In the African region, we have 3 of them. There's East and Southern Africa, Central Africa, and West Africa. So for East and Southern Africa, we have all the partners involved. We have PATH, JSI, WHO, UNICEF, Africa CDC, IOM. And I think it's just a matter of making sure that MSF is at all these different levels engaged, and it's just being intentional. Like, as soon as you know there's something, just reach out to someone and say, hey, can I be part of that working group, or can I be part of that technical working group? And they exist. Within the ministry, there's different technical working groups. So as soon as you hear about it, I think we shouldn't be shy. I mean, all these people who joined our regional working groups all came knocking at the door and said, can I be part of that group? And we said, sure, let's see what you're doing. So I think it's a matter of just showing up.
Thank you very much. I think in MSF we love to criticize ourselves, and it's always nice when someone from outside says how great we are at the end of it. So I'm just going to leave it there now with Shamila, who's going to just round us off. Thank you. Maybe a clap for the panelists.
Okay, thank you so much. A big round of applause for all of our speakers and our panelists here today. Thank you very much. So my job is to just sum up this session. So I think we've all learned a lot. I think we've seen that because of the backsliding in vaccination coverage due to the pandemic and even issues that were happening before that, we're seeing, as a result, outbreaks of vaccine preventable diseases that we shouldn't be seeing. And I think there are a lot of initiatives happening at the global level. It was mentioned the Big Catch Up, which is this big initiative. Lots of attention, lots of resources that are going into it by a lot of global actors like WHO, UNICEF, Gavi, etc. So if there's all this attention, all these resources going into it, and everybody's making this concerted effort, we as MSF, on the ground folks, should be also doing more. And I think from Catherine's presentation, there are lots of missed opportunities, and how can we maximize all of the opportunities? It's all of our roles. All of the frontline healthcare workers have a role in making sure that all children get vaccinated. I think also at MSF, as a response organization, we're always in this mindset of responding to outbreaks. But I think another thing that was brought up here was we need to have a change in our mindset. You know, they say an ounce of prevention is worth a pound of cure. So if we can make that change in mindset and really focus some more activities on prevention activities, I think that would go a long way in preventing these outbreaks. So we don't need to respond to as many outbreaks as we have been historically. I think the panel discussion also brought up a lot of really interesting and really good recommendations. I've heard that, you know, there needs to be policies in place. Another thing that we can be doing is continuous activities and continuous advocacy. There also needs to be better coordination and collaboration and synergies, but also transparency in that. And all of this coordination has to happen at all of the different levels, especially at the national level and the subnational levels. And that at all of these different levels, we as MSF should be speaking out and sharing our experiences and our voice. This is our témoignage role. And we should be at all of these different levels, especially at, you know, EPI meetings, but at regional meetings, regional working groups, etc. And yeah, so I think I'll leave it at that. I think, you know, we've come a long way in the last 50 years, but there's more that we can be doing, more everybody can be doing. And I think together, yeah, we can make the world a better place. Thank you. Oh, sorry, and I'm also supposed to mention that on the chat for those online, as well as here in the audience, online chat, if you can just put in some of the key messages that you picked up from this session, that would be great. So appreciate that. Thank you. And thanks again to all of our presenters and panelists.
All right. Thank you for an amazing session, and sorry we didn't get to everyone's questions, but there will be an opportunity at lunch. All the panelists will be sitting in a specific area at lunch with a label Conversations Over Coffee, so take your questions and you can discuss more with them then. So now the last thing again between you and food is some more speed posters. So I would ask, who have we got? Ezebon, Philip, Joanna, Robert and Paula to come up to the stage. Again, they will have 1 minute each to give a little elevator pitch for their poster, and then during lunchtime they will be at their posters. Yeah.
Okay. So my name is Ezebon Philip. I'm the POCAS regional manager for South Sudan. Me, together with my colleagues from Homa Bay, I have Adede and Justin back there. So we wrote a poster, which is about a case of a child with acute abdomen that benefited from point-of-care ultrasound in Homa Bay Hospital. The ultrasound actually helped us a lot to look for evidence of acute abdomen, which is finding a free fluid in the abdomen, looking for also evidence of intestinal obstruction, and also it helps us a lot that because it's a case of ascaris infection in this child, so we're also able to visualize the worm actually live during ultrasound scan. That helped us a lot to convince the surgeon, and also help to accelerate bedside decision making, and also at last was also able to help the surgeon to predict the complexity of the surgery. So we welcome you to look at our poster. Thank you.
So Tony reminded us this morning that children are not little adults. Well, it turns out in medicine, newborns are not just little children. Neonates require a distinct approach to care, dedicated resources and dedicated training. So we've created a hybrid learning program in neonatal care, including an online e-learning platform with 13 modules available in French and English on Tembo, soon Arabic. And we've looked at the who, what, where and why of our online users and participant satisfaction. So come and chat to us to find out more, either myself or Murray over here during the break. Come and see our poster or find out more about how to enroll on Tembo. Thanks.
Hello everyone, my name is Robert Kosechka. I'm a pediatrician and I just finished my mission in South Sudan in Kaji, where actually I met Ezebon, so it's quite funny to be on stage with him here. My poster is about a small preterm with a giant omphalocele that we had there in our NICU. And we were struggling with the decision whether we should do surgery on that child, and actually decided not to do that. And in that course, we actually managed to, let's say, cure that child, and the poster's about that. If you want to find out more, please have a look.
Hello, I'm Paula Cuenca, HIV TV referent for OCBA. I want to ask you a question. If I tell you HIV, epilepsy, psychosis, asthma, what do you think they have in common? So they are chronic diseases, and as we have pointed out this morning, chronic disease represent a significant burden in humanitarian settings, and of course in many of our projects. So how do you think MSF should approach people living with chronic conditions? MSF OCBA has successfully implemented a chronic care unit in Malakal in South Sudan, and this unit seeks to integrate the management of chronic conditions, chronic disease, with an holistic and people-centered approach in order to improve quality of care and the quality of life the populations we assist. So as a result, the first 6 months of the implementation, 1,200 people were included in the unit, around 150 children among them. So if you want to know how to implement, how to set up a chronic care unit in your project, so welcome to join me.
Thank you all, and yes, they will be at their posters during the break. So now it is lunchtime. Lunch will be across in the restaurant building, so if you walk straight across the courtyard past the empty water feature, the next building across there is the restaurant, and that's where lunch will be. We will reconvene back at 2:30. Please try and come on time so we don't lose time again. And a reminder, the speakers from the vaccination session will be in a special area for conversations over coffee. And then we ask the vaccination panelists to just go to the holding room quickly before they head to lunch. Enjoy your lunch.
Hello. So, I hope everybody had lunch. Welcome back. So we'll just start straight to the next speaker. Our next speaker is Dr. Helen Nabuero. She's a pediatrician and a physician scientist with a special interest in nutrition. Very accomplished author. She has authored more than 40 scientific articles on peer-reviewed journals and contributed to 6 chapters in different books. And then I just welcome her to the stage.
So, good afternoon, everyone. The post-lunch slot isn't always the best, but I'll try and keep you awake. So, as I've been introduced, I'm a pediatrician, but I predominantly do research now, but contribute to clinical care and the public health services in Kilifi County here in Kenya. And just really wanted to say thank you. I'm greatly privileged to have been invited to give this keynote speech, and just really want to acknowledge, I'm honored to be in the presence of, many people who work in really challenging situations, often unpredictable. A lot of what I'm going to present will be more in a stable situation, but I hope there'll be lessons that you could learn and maybe carry on in your own contexts. I also want to acknowledge the presence of my mentees in the audience, and also Ms. Joycelyn Kathembe, who's my research officer, who keeps me on track in terms of the various things I have to juggle. So, in discussion with Nadia, we settled on this topic, and I hope it will be of some relevance to you. It speaks a little bit to my journey as a pediatrician, trying to address the nutritional needs of the children who come under my care. So, keeping mother and child together for great gains in child nutrition. So I'll just walk you through this presentation, and hopefully there'll be something useful that you'll get from it. So the outline of my talk will be just really focusing in on the global state of child nutrition and child health. I'll then talk a little bit about the journey of transitioning from predominantly focusing in on the child in order to address their nutritional needs, to actually encompassing the wider aspect of that child, i.e. the mother, but often in more of our cases now, the wider family. And then touch a little bit on the evidence. Okay, so when we talk about child health, often the key indicator is child mortality. So if you have high rates of child mortality, then either your clinical services are not right or there's something happening in the community that's not right. So it gives you an indication of the challenge you have right there. So this is a graph from the UN IGME Child Report in 2022. And what I wanted to highlight here was the fact that, indeed, overall, we still have very high rates of child mortality. But when you look at the rates of mortality, the group we are still really struggling to address are the under fives. And so my work and the talk that I'm going to give will really focus in on addressing the child health and nutrition needs of children under 5. And at the moment, in terms of the global statistics, we still have about 5 million children dying every year. A lot of these are from preventable conditions. Certainly those of us who, obviously for you working in the humanitarian context, but for me having transitioned from working in a high-income country to a low and middle-income country, the frustration of seeing children die unnecessarily is never ending. Sorry. Okay, so this graph just shows, it's really to highlight where the burden of under 5 mortality is. And what I wanted to highlight from this chart here is that when you look at all the countries where you have rates of under 5 mortality of greater than 100 per 1,000 live births, these are often in the humanitarian context. And so for me, it's been a privilege to sit here and learn more from you, because often when I'm giving this talk and speaking to my students, certainly I always highlight this and say, look, we really need to try and generate evidence on how to address the needs in those humanitarian contexts. So certainly I think, seeing all the interventions you've put in place, including having standardized guidelines, will absolutely help us address that. But we still don't have enough evidence in those from those contexts. Also wanted to emphasize the fact that even though in Kenya we would say we are in a stable political state, when you look at how we are doing within the region, we're actually one of the poorest performing in terms of addressing our under 5 mortality. So at the moment we sit at 41 per 1,000 live births. But if you look at the trends in terms of what's happened over the past 30 years, countries such as Rwanda have made significant progress in this, whereas we haven't. And so when you look at what the causes are of under 5 mortality, this is a familiar graph, and I know for many of the pediatricians in the audience, we have become quite familiar with this, where we know that because of obviously the great success, as your colleagues here spoke about, the vaccination programs in addressing infectious diseases, now almost half of under 5 mortality is from neonatal conditions. And what isn't highlighted in this graph is the fact that actually about 50% of mortality in children is due to undernutrition. And so all these conditions that you see there, what underlies most of those conditions will be undernutrition. And so this was a conceptual framework that was developed by Professor Per Ashen and colleagues, where they really wanted to, as I've noted before, neonatal mortality is now contributes to about 50% of under 5 mortality. And so they wanted to really tease out what the vulnerabilities are around newborns. And what they found was that actually from this new conceptual framework, which really tries to highlight the vulnerabilities that come through because of maternal undernutrition, i.e. fetal growth restriction and everything that comes after that, they came up with this conceptual framework of how we can measure vulnerability or describe vulnerability. So if a mother is undernourished and this infant is exposed to fetal growth restriction, then they could be born too soon, they could be born too small, small for gestational age, or they may be born low birth weight, i.e. less than 2,500 grams. And so this conceptual framework really helped us to understand the greater burden of what we thought was a small condition, which we focused in on as low birth weight, that actually the burden of maternal undernutrition on newborn health outcomes is even bigger than we thought. So overall, in summary, what they found from this analysis was that an estimated 35 million newborns will have one of these vulnerabilities. Those numbers are huge, especially for those of us who are working on addressing child health outcomes. And that about 50% of those infants, 50% of these infants, neonatal, in terms, when you look at neonatal mortality, approximately half of these will be caused by infants who are in that vulnerability group. And even if they survive, they'll survive with multiple problems: growth, nutritional problems, neurodevelopmental problems, and as they go into adulthood, their socioeconomic status is likely to be lower, i.e. because of poor educational attainment. So it is a big problem, not just for child health, but for social capital altogether. So where are we in terms of addressing meeting the Sustainable Development Goals for under 5s? So this graph I like because it just reminds me of the amount of work that we still need to do. Sub-Saharan Africa and Asia are often the burden areas for most child health conditions. But what's happening here is that whilst there's greater progress happening in Asia, Sub-Saharan Africa, in some situations, actually, we are lagging behind, and certainly in terms of maternal and child nutrition. So this is just a reminder that for those of you who are working, obviously this is, as Professor Ndwati said, a Pan-African conference. There is a lot of work to be done in terms of addressing this. And we can, as we said in the Kenya Pediatric Association meeting, where we're looking at how to address newborn deaths, we can shift the needle a little bit to try and bring those numbers down. We have only up to 2030, just 5 years to bring it down to, we said, at least 25 per thousand live births. So we are still way above that. And for me, this quote just helps remind, please move on. Yeah, from the United Nations Secretary General. It's when we look at the Sustainable Development Goals, as we do for all targets, it's not just about the lines where we are sitting in terms of everyone else, but also in terms of that line. But it's very much about trying to, it's about healthy mothers and babies. It's about children learning the skills to fulfill their potential, and parents who feed their families. And you can go on looking at the other aspects that he discussed. So it's very much a holistic approach. But for me, the key things are really making sure that we are keeping mothers and babies healthy. And so, unfortunately, the rates of undernutrition continue to be very high. And this, again, is another slide from one of the UN reports, just telling us where we are in terms of undernutrition. So wasting is where a child is, has lost a lot of weight in a very short period of time. So they've got a low weight for height Z-score or low weight for length Z-score. And there are regional differences even within Africa where we have burdened countries, but you also have high rates of wasting in countries like Asia. So that's still an ongoing problem. And as I mentioned, as I alluded to before, we know that if these infants start off, as in if the exposure is suboptimal in terms of maternal nutrition, then they're likely to be the ones who end up in our malnutrition units. And certainly that was part of what stimulated me to really go back and start working with newborns, having looked after children with severe acute malnutrition and been frustrated at the rates of relapse that occur and also the high rates of mortality. So still a lot of work to be done here. And then when you look at the rates of stunting as well, the rates are still extremely high. We still have 148 million children under 5 who have stunting. There are regional differences. So obviously, again, the humanitarian context tends to have really high rates of stunting. Within a country, so for example, within Kenya, overall our rates of stunting maybe are not too high, but when you look at specific hotspots, so for example, Kilifi is one of those hotspots where 37% of children are stunted. And when you look a little bit deeper into that, you find that there is a significant burden of maternal undernutrition in Kilifi County. And so therefore the need to actually, if we continue working towards just focusing in on the child, we're not going to get very far with that. So this is just a little bit of work that I did when I worked in the Gambia. The Gambia has a rural field station It's a nutrition field station where they've been providing nutritional support and doing nutritional research for well over 4 decades. And so they've got really nice records of, anthropometric records, but also over time, as it shows here on the graph on the right, they've been providing primary healthcare services to a number of villages, particularly 3 villages in rural Gambia. And over time, there's been an increasing number of interventions that they've been providing. So it's been mainly, obviously, around vaccinations, but also around providing supplementation, some public health interventions in terms of providing clean water, as well as sanitation. But so what this analysis showed was that despite all these interventions, when you look at rates of undernutrition, so in red you have stunting, and over those 40 years, we were only able to halve the rates of stunting in that community. So that tells you that actually, if you focus, a lot of these were really predominantly focused on the child. If you focus predominantly on the child, then we are unlikely to get very far in terms of addressing undernutrition in children. And so the UNICEF conceptual framework from 2020 really nicely revised how they looked at child undernutrition and really brought the mother and child together. And prior to that, Professor Black and Professor Zulfikar Bhutta, who are really leading public health, but also pediatricians in this space, from 2008, they really highlighted the fact that beyond looking at child undernutrition on its own, we really need to look at this burden as both maternal and child nutrition. And they did some really nice analysis looking at, okay, so then what interventions do we know that if we put in place would really comprehensively address both maternal and child nutrition and lead to greater gains in child nutrition. So they've published 2 Lancet series, so in fact 3 now, and the first one was in 2008, and then the next one was 2013. And then following that, UNICEF also really revised their conceptual framework to really include interventions looking at both maternal and child nutrition together. I like this conceptual framework, and my students know that I use this all the time, because it just reminds me that even as a pediatrician, I shouldn't just be focusing in on lack of food and disease, but actually thinking about all those other underlying factors that would have led to a child, but also now the mother being undernourished. Okay, so just coming up to some evidence as we wind up. So this is a really nicely written Lancet paper by Keats et al. So this is again Professor Zulfikar Bhutta as well as Professor Robert Black. And what they've done is they've summarized all the evidence that we have on maternal and child interventions that can really make a significant impact on child undernutrition. So multiple micronutrient supplementation is big. And you can see that there's really strong evidence around that. If you remember the conceptual framework on the small and vulnerable newborn, it has an impact on all those in reducing low birth weight by about 10%, in reducing small for gestational age by about 10%, and reducing preterm by about 15%. So it's a simple intervention, but why is it that we're not able to deliver it to scale? And certainly, multiple micronutrient supplementation in pregnancy can be done, both in a stable state, but also in the humanitarian context. But the reason why we are not able to implement a lot of these interventions where there's absolutely strong evidence is partly what we've discussed already, that our health systems are just weak, and we are unable to deliver all these interventions at scale. So I guess as I come to the conclusion of this talk, it's really a call for, I call it a call for action. For those of us working in child health, absolutely as a child health expert, my focus has been and my training has been on looking at the child. But now more and more it's the realization that if you don't look at the mother, look at her health, look at her nutritional status, look at her mental health status, then I think, certainly colleagues in the audience who worked with the MAMI project, then we're unable to get very far with what we're doing in terms of addressing child health. So this framework, again, which comes from that same paper where they've summarized the evidence really well, it looks at all the different aspects. So you've got your direct nutrition interventions that are delivered at the health service level, but also looking at aspects of policy. And then on the right there, you've got the indirect factors, so such as, for example, maternal vaccinations, that also have an impact on child nutrition, interestingly. So looking at all those aspects, really, we really need to somehow have a stronger collaborative approach to what we are doing. But for me, most importantly, ensuring that I'm speaking to my maternal health experts, but beyond that, speaking to my public health experts and everyone else. So this is just, some of the work that we've been developing here in Kenya and with ongoing work in Kilifi. So this was a small feasibility study that we did in Homa Bay. And we really wanted to address the needs of the small and vulnerable newborn, i.e. in this case, because it's difficult to assess gestational age in our health system, we used low birth weight because often these babies will have a low birth weight. And what the literature was showing us was that post-discharge, we're absolutely focusing in on saving newborn lives in the hospital, but they are discharged to, there's no support once they get back home. The idea is to discharge them to community health workers, but often that doesn't happen. And their experiences, certainly from work that's been done by colleagues in the Camry Wellcome Trust, shows that their experiences during that hospital admission traumatized them absolutely. And in one of the kind of like qualitative interviews that were done by, again, colleagues from the Camry Wellcome Trust, one of the moms said she wouldn't wish that experience on her worst enemy. So these women are traumatized by that experience. And then when we discharge them into the community with a small baby, when, there are a lot of community misconceptions, and that's a talk on its own. I'm not going to dwell on that. But what I wanted to emphasize was that the approach of using mother-to-mother peer support somehow brings that mother and baby together. When we initially developed these interventions, me with my pediatric hat on, I focused in on child interventions. And actually, it was colleagues, even in the ethics, who are reviewing this protocol before we send it to ethics, who said, what happens to the mother? Why aren't you focusing on the mother? And indeed, we incorporated psychological support as the main aspect of supporting the mother. And what we found was that this was just a small feasibility study with just 60 mother low birth weight infant pairs. And what we found was that the psychological support actually really enabled mothers to cope a lot better with what they experienced in the community, enhanced their practices in terms of breastfeeding, but also infant care. And overall, these infants who had a median birth weight of 2,050 grams gained about nearly 3 kilograms in weight over that 3-month period of follow-up. And that was really just the peer mothers providing that support. So I guess what I want to conclude on is the fact that, indeed, we still have a high burden of undernutrition in under fives, particularly in sub-Saharan Africa, but also in Asia. The progress we are making in sub-Saharan Africa is still very suboptimal. And so therefore, we need somehow this shift in terms of our approach, even as child health experts, to really be thinking we need to integrate somehow, incorporate services, just as we are thinking, okay, we've seen a child, we need to vaccinate them. We need to be thinking as well, how about the mother? Is she vaccinated? Has she received all the services that she's supposed to receive in order to optimize both her health and nutrition? So I'll finish there, just to say thank you for inviting me, and I welcome any questions at the appropriate time. Thank you.
Thank you so much, Dr. Helen. Somebody probably has left his phone. It's somewhere in the booth. You can come to the front and get it. Yeah? Okay, good. So next will be oral presentations. Will be moderated by Samuel Copy. Samuel is a nutritionist and a dietitian. He's also working on his MSF page. He has been working for 12 years in humanitarian settings in Liberia, South Sudan, and he's currently a nutrition advisor based in Nairobi for MSF. The presenters, maybe you can come to the front. Samuel will be moderating your sessions here. Thanks.
Good afternoon, everyone. I believe we are going on well. Eh? Thank you so much. So I don't want to take much time. I just want to introduce our first presenter, Dr. Khan, who is a PhD in psychology. He has 25 years of currently working with the Action Against Hunger. Kindly take it up.
This doesn't work? No, and this one?
It's working.
Okay, great. Okay. Good afternoon, everyone. So my name is Karine Leroc, and I work for Action Against Hunger as a mental health and psychosocial support research advisor. So on behalf of Epicentre and MSF research and operational teams and partners in Mali and in France, that's not mine. That's, no, the other way? How?
The next presentation, not this one, because this one is the guy did not turn up.
Okay, so the guy who did not, okay, cool. Sorry. Ah, here you go. Thank you. So I'm very glad to present you our study on behalf of Epicentre and MSF research operational teams and partners in Mali and in France. Our study, STIMNUT, is an innovative community action research on psychosocial stimulation. It aims at improving care for severely malnourished children, and it was conducted in Koutiala, Mali. So a bit of context. Sorry. One doesn't work. Sorry. Techniques. So what are the fundamentals of psychosocial stimulation? So on the left side, you can see the diagram that shows that for any children, psychosocial stimulation participates to the child's physical and psychological development. It brings positive emotions for the mother and the child through positive parenting, and it reinforces the experience of attachment and inner security that they need in this, the context of malnutrition. For those reasons, we have decided to conduct a study on psychosocial stimulation in some treatment in the context of Koutiala in Mali, as you can see on the right side of the slide. For undernourished children, studies show that psychosocial stimulation provides short and long-term benefits for the cognitive and social development. Psychosocial stimulation has been recommended in the SAM treatment protocol in Mali since 2017, but strategies and interventions are not yet standardized, and few resources have been allocated so far. Besides, the prevalence is quite high in this context. Oh, sure. Oh, sorry. So, in order to assess the effect of the psychosocial stimulation intervention, we have designed a mixed method study conducted with mothers and their children aged 6 to 23 months affected with severe acute malnutrition in 2 community health centers, the CESCOM, and in the pediatric ward at the hospital supported by MSF. We use pre-post intervention questionnaires. We evaluated 2 determinants of child undernutrition, one of them being maternal mental health, as it was mentioned in the presentation before, and we administered a questionnaire which was developed for the Malian context. We also observed the changes in mother-child interaction using the Piccolo tool, which is an observation grid. In addition, we conducted semi-structured interviews with parents and primary caregivers, psychosocial workers, and healthcare staff to assess the acceptability of the psychosocial intervention. So this is how it looks like. On the right side, you see the psychosocial intervention consists in 5 sessions with different topics which were tailor-made for families and children with severe acute malnutrition. The curricula was based on another curricula, the FUSAM protocol, that was developed for children with SAM in Nepal. We explored solutions to improve the care to children and to support parenting skills. Moreover, we propose a continuous oversight of the implementation of the sessions by the psychologists who originally trained the team. So now some results. Among 48 families, we followed up and completed the evaluation for 36 families. As a result, 149 sessions were offered to families by 3 psychosocial workers. 18 were conducted in the hospital, and most of them, the majority, in the centers, community health centers, 131. 36 children and 34 mothers with 8 other accompanying adults received those interventions. There were also husband, nephews, brother-in-law, father-in-law, uncle. Males were really supported to be engaged in this intervention as well. 122 individual sessions and 27 group sessions with about 2 to 3 families were conducted, and the median time per session was 54 minutes. Okay. So some results here. So regarding the pre-post measures, we found improvement and significant changes in both outcomes, in maternal mental health and in the mother-child interactions, even in subtotal scores. For maternal mental health, the changes showed a higher reduction in feeling lonely and crying easily. Usually when the mother comes, they are very much depressed and tired, and there are many signs of psychological distress. For mother-child interactions, the most important changes were reported for increased encouragement and responsiveness, but also for teaching and affection. Regarding the qualitative study on acceptability of the mothers, this diagram shows the effect of the sessions called the talks by the mothers. So where you see the 3 dark orange circles, they represent the major changes perceived by the mothers. They were able to transmit the knowledge that they learned during the interventions. They also reported having a better relationship with their children and more interaction through play. Besides, they also reported, as you can see on the right side, for mothers, family, and close contact, and also for children, they observed that their children seem more alert and they show more autonomy and they sleep better. The family and close contacts are more involved. They express positive attitudes, interest, and encouragement for the mother and for the child. And finally, the mother's capacity for autonomy and sense of efficacy. Mothers have acquired some knowledge, they feel more autonomous, and they regain a degree of self-confidence that they usually have lost when their child became sick. So here are some quotes from mothers reporting positive feedbacks. One of them reported sharing knowledge with other members in the family, like her husband or other co-wives. Another one explained how she benefited from the exercises during the session, how she felt more relaxed, she had less negative thoughts. And the third one said, I had a child whose father tended to ignore. He plays with the child. Even this morning when we called him, he was playing with the child. So to conclude, these study shows that it's feasible to implement psychosocial intervention in the care pathways for children with severe acute malnutrition. It has shown good acceptability among mothers, and in addition to this, the acceptability was found to be good also in health staff and psychosocial workers who are still working today, even after we stopped the study. We've seen a great synergy between various stakeholders, beneficiaries, health personnel, local actors, community members. They all participated to the design of the curriculum. They all participated in the mode of integration of the psychosocial services within the healthcare pathway. Those results are encouraging regarding maternal and child health and well-being. The transformative effect of this study has led to the continuation of those services within the care pathways of children in Kutyala. Last but not least, there are needs that have been identified in other contexts where MSF intervened. There are ongoing discussions for scaling up this intervention. The proposal of a framework for the replication of the psychosocial stimulation intervention in other MSF projects and contexts is being discussed. So thank you to all the families, their valuable time, contribution to the study, all members of the different advisory boards that participated to the conduct of this study. There were also some partners in Mali, AMED Association, the Ministry of Public Health and Social Development, and traditional authorities. If you want to know more, you can go on Epicentre website. There are lots of other presentations and videos, and you will see other results presented there. Thank you.
Thank you, Doctor. Let's keep our questions we shall ask at the end of the session. So our next presenter, please, is Karan. He's a epidemiologist with over 5 years experience in health and research. He's currently working as an epidemiologist with MSF Northwest, Syria. So let's put our hands together for him.
Thank you very much. Good afternoon, everybody. Okay, some of you responded to good afternoon, so I can already tell we're awake and well. All right, so I'm going to talk a little bit about Tom Brown. It's a product to treat moderate acute malnutrition. Acute malnutrition, also known as wasting. So some of my colleagues have already spoken about wasting, and it's about acute malnutrition. We divide it into two different parts, moderate and severe. I'm going to talk about the management for moderate acute malnutrition. And this was done as a part of my work with Taimaka. It's a NGO based in northeast Nigeria. Okay, great. So if you can see, we work out of Gombe, which is a small state in northeast Nigeria. There's plenty of experts here who've worked in Nigeria before me. They know that the location is a little bit special because it's close to Borno, Adamawa, and Yobe in northeast, which are humanitarian contexts. But Gombe necessarily isn't. But a lot of the health indicators that we see in Gombe are definitely higher than the national averages. So this is also a study to sort of get our understanding better about neighboring areas of humanitarian context and see if there's any other approaches that we can see here to prevent them from falling into the same poor health indicators as some of the humanitarian areas do. So about 50,000 people are at risk, are moderately acute malnourished in Gombe. And it's been proven already that targeted supplementary feeding programs, or TFSP, is a good way to prevent deterioration to severe acute malnutrition, to make sure that their health status doesn't deteriorate and they're protected from morbidities and mortalities. Locally produced treatments have the benefits of being acceptable, accessible. Supply chains are already established, more or less. They're usually cheaper than established products, but that also has a caveat. So Tom Brown, if any of you have heard about this product before, it's essentially a blend of 3 different things. Dry roasted, milled, and then blended together. Peanuts, soybeans, and sorghum. Sorghum is 60%, peanuts 10%, and soybean 30%. So all of this together goes into making about 1.5 kg of Tom Brown, which is the general management for 1 week. This is usually cooked into a porridge. So of course, the cost of making it, the fuel and the cooking is transferred to the community. So when we say it's cheaper, we're sort of also kind of being mindful that it's cheaper because we're transferring a little bit of the cost. It's not ready to use. The more important thing here, I won't go into the details of the macronutrients, but they do meet the WHO nutrient recommendations. Micronutrient recommendations, it does not. We did not choose to include MNP, which would micronutrient powder, which would be a good way to solve this problem, because some previous organizations that have used this product did not use it either. Right, so the objectives, primary, to assess treatment outcomes, to understand children who are moderately acute malnourished on this product, what is their outcome at the end of the observation period. Look at the average length of stay and average weight gain, both very standard indicators to understand what the product is. And secondary is to assess deterioration to SAM. Locations were 3 sites in Gombe across 3 different LGAs. And the time period was between October and December 23. The study design is retrospective data analysis of existing programmatic data. So we did not have the capacity to do any RCTs or any experimental studies. And the inclusion criteria is children aged 6 to 59 months, the standard again, who are diagnosed with moderate acute malnutrition, which happens to be either through MOAC or through weight for height Z scores between -2 and -3. Or both. This is not an either or, it's an either or. Of course, children who have any existing severe infections or any existing nutritional edema are excluded from this, and they're usually referred to as SAM patients or referred to inpatient facilities. They were enrolled at least for 14 days for our program. The treatment or the intervention rather was Tom Brown, 1.5 kg per week per child, and with 150 grams of sugar. Follow-up was weekly until they exit from the program. So these are the results. As we can see, 90% have recovered at the end of this day, and we define recovery as a little more specific to say that it was 2 consecutive visits with weight for height Z scores between greater than -2, as well as MOACs or mid-upper arm circumferences more than 12.5. Of course, again, no severe clinical complications. And only about 2 children died and 2 were transferred out. And then a major chunk defaulted. So about 7.58% of the children defaulted. So just about 100 children did not make it to the end of the program and were sort of not followed up. And there were a small percentage, about 2, who did not respond to the treatment. They stayed MAM throughout the observation period. I'll go to the next slide. I'll skip this one. We'll come back to this. Let's look at this one now. So it's the same slide that I showed you earlier, but we did also see a little bit of deterioration to SAM in all of these kids. So if you break it down, the lighter parts are the ones that deteriorated to SAM first and then recovered. So out of the 90% that did recover, so that's about 1,000 kids, 165 first deteriorated to SAM, lost a lot of weight, lost a lot of upper arm thickness, and then finally were recovered. So there is definitely some severe risk factors that we are probably not able to describe a lot on with such a descriptive study, but this is just to bring up that a significant chunk of all of these chunks did end up deteriorating to SAM first and then became recovered. So there was, even with the treatment that we're saying worked, it definitely did not work for a significant amount of time. And so we can go back to this one, which is the secondary outcome indicators. If you can see, these are decent enough for recovery from MAM. We're seeing about 5 weeks of recovery time, 36 days, with, of course, the standard errors are a little wide because this is just secondary data analysis. An average weight gain is about 4.2 grams per kg body weight, and these are using standard indicator calculation definitions. The ones who deteriorated to SAM, and I would like to compare these with the ones that were SAM at admission, in fact show worse outcomes than the other ones. So if a child was SAM at admission, the child was in treatment for shorter, the child gained more weight per day as compared to a child who was first moderately malnourished, acute malnourished, and then went to SAM. So again, here, this sort of data point does bring up a little bit of questions about what kind of risk factors might be also involved in this kind of treatment. And I guess that's all for the results. And just a comparison, why we say it's cheaper, we've compared it with RUTF treatment. So RUTF is standard in the COMPASS study, if any of you is aware, because we do not have capacity to order RUSF products in our facilities. So compare it with RUTF treatment, it's a little bit cheaper, but the standard errors do not say so. So anyway, that is all for today. Thank you very much. Sorry for going over a little bit. These are some of the limitations. I'll leave you with these. And finally, thank you so much for everybody who's collaborated on this project with us, especially the team in Gombe. Thank you.
Yeah, thank you so much, Karan. Now we have our third presenter who is going to join us virtually. That is Marlene Taure, who has public health, nutrition. He's a public health nutritionist with over 10 years of experience implementing nutrition-specific, nutrition-sensitive, and social behavior change programs. She has worked in over 12 countries. Welcome, Marlene.
Good afternoon, everyone. Can you hear me?
Marlene, can you just try to speak again, please?
Yes, can you hear me okay?
Yes, we can. You can put your video on if you would like.
Yes, my video is here. I just need to share. Sorry. I can't see the sharing button for my presentation.
If you would prefer, we can display it from here, and you can just tell it to move slides. Yeah? Okay.
All right, that's fine. Thank you. Sorry about it. Okay, I got it. Sorry. I don't know, I was anxious. So can you see my screen?
Yes.
All right, thank you. So good afternoon in Nairobi. So today I'm going to share some of our learning on implementing the integrated care pathway for vulnerable infants under 6 months and their mother in South Sudan, so known as the MAMI care pathway. And this work is the result of a collaboration with 3 other colleagues that I'm representing today, Angelina Boy, Kirk Durden, and Edwig de Conmo. Sorry. So globally, we know that 3 risk factors of vulnerabilities that include being born too small, too early, or with a low birth weight is contributing to more than half of neonatal mortality. In South Sudan, these vulnerabilities are also prevalent in newborn and infants under 6 months of age. As an example, we have found that 1 in 5 newborn and infants are born with low birth weight. However, due to lack of data, we know that the burden of this vulnerability is underestimated on this age group. Therefore, in South Sudan, we have used 2 opportunities to try to minimize and tackle those vulnerabilities. The first one is the USAID-funded Momentum Integrated Health Resilience, led globally by IMA World Health, that work to strengthen health resilience in fragile settings with a focus on maternal, newborn, and child health, and also family planning and reproductive health. So the second opportunity we have leveraged was the existence of the Mommy Care Pathway package developed by Mommy Global, the Mommy Global Network in collaboration with ENN and LSHTM. And this package is a set of materials that can be adapted to the local context to help practitioners identify and manage small and nutritionally at-risk infants under 6 months and their mothers. So basically, this package is supporting the implementation of the Mommy Care Pathway. So today I'm going to focus on the qualitative studies, that sub-study that was conducted as part of a larger Mommy implementation research conducted in South Sudan. This qualitative piece was conducted between January and March of this year. The objective of the qualitative study was to explore the acceptability and adherence to the Mommy Care Pathway among service providers and service users. This was a retrospective study involving semi-structured key informant interviews and using a framework-based questionnaire. So in terms of study population, on the provider, we interviewed clinical and community health workers that were trained to support the implementation of Mommy Care Pathway, as well as the Mommy assistant that were MIHR staff trained to mentor the clinical and the community health workers for the delivery of the Mommy Care Pathway. In terms of users, we interviewed 3 categories of mothers. The first categories were mothers retained into the care pathway until their infant reached the age of 6 months. The second categories were mothers that returned only few times for follow-up visit and then became absent. And then the last categories were mothers that never returned for follow-up visits after they were enrolled in the Mommy Care Pathway. So this slide just gives you an overview of the 2 theoretical frameworks that were used. The one is the theoretical framework of acceptability by Second and Al, looking at the acceptability, and then the second one, looking at the adherence, is the capability, opportunity, and motivation behavior framework. So we conducted a thematic analysis from the key informant interviews, and then we use the teams that emerge to map. We map the team that emerged from these interviews into each of the 2 frameworks. So for acceptability, we mapped those teams into the 7 component of the framework of acceptability. And in terms of adherence, we did the same exercise and mapped the team emerging from the interviews into the COM-B 3 components. So in summary, we have then analyzed these team in terms of enablers and barriers to acceptability and to adherence. And then we look at the care provider side and then the care user side. So the care users are the mothers. And then the care providers were both the clinical and the community health workers. So looking at the care providers, we have found that enablers of adherence to the mommy care pathway included the fact that they were providing care for a neglected age group and the fact that they were receiving respect from both the caregivers and their communities. Then the barriers included having more and longer consultation and then more workload. And this was partly linked to the fact that they were using lengthy assessment form that included the assessment of both IMNCI and mommy risk factors. Then another barrier that was identified was the fact that they were requiring new skills for assessing and providing care to the couple, the pair of infants and mothers at once. So from the care users, enablers of adherence and acceptability included the fact that they were gaining new knowledge and skills to improve the health of the infant, but also themselves. And then the fact that it was easy for them to practice the new knowledge and skills at home. A barrier included the difficulty in understanding some of these vulnerabilities and their causes, and also access to health facilities, meaning then traveling long distance to come for regular follow-up visits, and also managing some conflict between messages provided by the care providers with messaging coming from the family within the household. So in conclusion, we can say that by supporting measurement of MWAC for infants under 6 months, by supporting maternal mental health, and by supporting the continuity of care for both the infant and the mother, so having a person or a peer-centered care, the mommy care pathway was able to fill a gap of a community and facility-based maternal and child health and nutrition services. This study also gave us the opportunities to identify ways to improve the acceptability and adherence of the mommy care pathway for both the health workers and also the service users, so the mothers of these vulnerable group. And finally, collective adaptive learning has allowed us to engage with health workers to improve the quality of care and to address barriers to the delivery of quality services for both infant under 6 months and their mothers. So as a next step for us, we'll triangulate the finding from this qualitative study, but also the quantitative analysis of the larger money implementation research, and we will consolidate and disseminate the learning. We will use those results to inform discussion on how to adapt the mommy care pathway in the South Sudan context, and will keep advocating to increase buying and funding for both care implementation and research on the mommy care pathway. Thank you, and over to you.
Hello, sorry. This question is for Karen on the Tom Brown product. I know that this was a retrospective data analysis, but I'm just wondering if you know, based on the available literature on standard RUTF, can you say anything about how Tom Brown compares to RUTF? And my second question, sorry, I might have missed this in the beginning, but why is it called Tom Brown? Thanks.
Great, I'll tackle the second one first. It's called Tom Brown because it turns brown on boiling, and I think that as languages do, over a period of time, it just started being called Tom Brown. Generally, Tom Brown is seen as this quasi-traditional product which is good for babies, and its composition isn't very, it varies a lot in northern Nigeria, but the product that we are using and the composition that we're using, and this also relates to the first question, is based on a couple of studies, mainly the one done by CRS, and they've piloted Tom Brown already in Maiduguri and parts of Bay State areas. And the issue with Tom Brown is that so far there's only a little bit of literature as to how it is being used as a standardized product. So it's really, the literature isn't out there. Any literature that we did come across for more locally produced foods were about 3 or 4 studies that looked at standard RUTF products, and then maybe lipid-based nutrient supplements or fortified blended foods, and maybe a few other local ingredients, but they were in very varied in geography and time. So this locally produced food product is definitely a little bit preliminary in terms of its research, very nascent, and generally less preferred as compared to fortified blended foods or more standard targeted foods that are that have a little more body of evidence. Yeah.
Thank you. I made an observation that 16.3% of the children went to RUTF. Could you, and that's a huge percentage considering that Tom Brown, actually I've had Tom Brown for a while now, and Daniel from Save the Children, I had it when I was working for World Vision through CRS. So the question now is it that it's not very effective such that you have more than 15% of the children deteriorating? So what is the issue? Do you have an understanding? And especially also considering the context, like the recent WHO guideline is really encouraging, readily available local foods to manage malnutrition. Thank you.
Thank you. Thank you for your question. Yeah, it's definitely something that we don't know more about, and I think the logical step is to do a more observational experimental study that can look at it in isolation and perhaps with other products to see how, to also see it in comparison to other products, but also eliminate a lot of these products that we may not directly be able to observe through a little more standard research approach. As far as we know, we have not looked into it in further detail, so it is definitely a more understanding of implementation, how people view Tom Brown as, not medicine versus RUTF as medicine, so they definitely, and then we've always worried about how people don't view RUTF as medicine. So, it's definitely different steps to this. But yes, at this point, this is the most information that we have based on this preliminary sort of data, secondary data analysis. And for your second question, sorry, can you please repeat the question? I'm sorry.
I think as I was saying, possibly you need to understand a bit more because, Tom Brown is made from locally available materials. If I would understand what I learned from the CRS team. And so that means it is easy to adopt. It is easy for it even to be replicated in many other areas. So you need to understand why are some children deteriorating.
Absolutely, and I think the value that I would say here is more about places where you need something to just blow over an emergency, especially for children that are not directly at risk. So this is definitely not a product for blanket supplementary feeding programs or in places where global acute malnutrition rates are over emergency thresholds. But Gombe falls, coincidentally in a place which is close to a lot of violence, but not directly involved in a lot of that response. And so there seems to be like a middle ground that can be seen where we're making sure that we're managing children who are most at risk to become SAM, which is MAM children, and also preventing them from worsening into it and protecting them from worsening into SAM. So, yeah.
Are you thinking of conducting clinical trials comparing RUSF with Tom Brown? Are you thinking of conducting clinical trials comparing RUSF and Tom Brown? I think it will be interesting.
I think a good product to compare it with would be RUSF, of course, but RUTF with especially I spoke a little bit about the Optima protocol where IRC used low dose RUTF, particularly in contexts where multiple products may not always be available, would be an interesting approach, especially given our program capacity. We do have supply chains already established for RUTF, so we think if we can use the same product, product with plenty of evidence, then that would be a good sort of thing to do. I know 3-arm RCTs are extremely expensive, but if I had to pick one, I would probably do it against RUSF first.
Sorry, I have a comment. Thank you very much for the presentation. Mine is just from the experience in my hospital. Most of the patients that we place on RUTF, some of them, because of the secondary lactose deficiency from chronic diarrhea with malnutrition, they tend to have worsened diarrhea. So we had to also go for the Tom Brown in form of, we call it Kwashi-Pap. But then the issue is that there was a recent, I think, study that was conducted in those that refused to respond to the use of the Kwashi-Pap, aka Tom Brown. It was seen that they have also associated celiac disease because of gluten sensitivity. And so you have to think of whether you're going to substitute like the use of sorghum on wheat or wheat with other things that are more gluten-free to see that those kind of things will not affect it. Thank you.
No, I appreciate that comment. I think the value of Tom Brown also is how flexible it can be, as long as it's meeting the macronutrient and perhaps with additional resources, micronutrient requirements, it can really be something similar depending on the local context, local acceptability. So I think in our case, I'm not sure because we haven't looked into it, but I do think that it is possible to work on it together with the community and be more flexible as regards to the contents. Sometimes we do replace the sorghum with millet because that's what children like more. So that definitely does change.
Okay, so yeah, that's great. Thank you so much for all those really great presentations. Mine is to Karim, just in terms of the psychological support intervention that you had put in place. You looked at short-term outcomes, I think. And I think, we've been thinking through this as well. And just in the context of, for example, adverse social circumstances, how long would the impact of your psychological intervention last? I think I would just like you to comment on that, because obviously for these mothers of children with severe acute malnutrition, the journey has been long for them. And so therefore, obviously, those short-term outcomes, yes, they will happen, but maybe if you could comment on what your thinking is around the longer-term solutions for them. Thanks.
Yeah, thank you very much. That's really great question, and I wish I could answer. Unfortunately, even though it has been advertised for more than 20 years, there are still very few initiatives. It sounds like it's too complicated. We will do when we will have time. I mean, you know, what's the problem in the field. We've done, 10 years ago in Nepal, we've done this RCT where we compared two groups of children, some children. One group received the psychosocial intervention, the other group did not. So what we could see is after 3 months, those children who benefited from the psychosocial intervention, they had a better child development than the other children. But still, they didn't reach the level of other children in the community that were never malnourished. So this is after 3 months. And then we repeated the same measurement after 5 months from admission. And we see the same results. And again at 11 months. And we see the same results. Those children who do not benefit from such psychosocial intervention, it's not like they deteriorate, like child development deteriorate, just they don't grow normally like others. So those ones, they won't do good at school. You know, they will have lifetime problems. This happened in Nepal. In the middle of the data collection, there was the earthquake, then they had 6 months of insecurity, they closed all the OTPs, there were many adverse events on the way during those 11 months. And I don't know if there are any other research projects who were conducted in those contexts in such a long time. Of course, 11 months is not long term, but what we can see is in 11 months, it remained the same. So I would say, you know, I will give half of an answer. I would say it's always better to provide psychosocial intervention because it prevents deterioration. It doesn't boost the child development, but it helps deterioration. But also the mothers, they learn that they can help their children. And this is for a lifetime, even though they learn for like, you know, those sessions, they lasted even less, like 30 minutes or whatever. They've learned something. They've learned that they can be competent. They've learned that they can help their children grow as they should. So in a way or another, it's always better to provide psychosocial intervention than not to provide psychosocial intervention.
Thank you so much. I know there is a lot of interest. People have so many questions, but kindly allow me not to take any other question because we don't have much time. We will have to discuss during the break so that at least if you have questions, they'll be here to answer your questions. Lastly, I just want to take this opportunity to appreciate Dr. Karan, and Marlene for their good presentation. I'm sure we have really gained a lot, and we hope that we can interact even more. Can we put our hands together for them, please? Yeah, I should not forget myself. Please, can you appreciate me? Thank you. Thank you so much.
Thank you, Samuel. Thank you, everyone, for your interesting presentations. And I hope this presentation will be very useful when we go back to our respective projects and clinical practices. Our next presenter is Roberta Petrucci. Yeah, welcome. Roberta is the leader of the MSF Paediatric Working Group, pediatrician. Yeah.
Thank you. What is the pointer? Have you ever been at the bedside of a malnourished child who is having diarrhea, is having dehydration, and wondering, what am I going to do? Am I going to give him Resomal, maybe ORS? Or maybe it's time to put an IV line and give him some fluids. If it's so, how much? In how much time? I see several heads nodding, eh? Yes, it's very common. And despite being so common, there are still so many uncertainties on how to treat these kind of patients That's why I'm so glad today to bring you this breaking news that the GastroSam study is currently ongoing to try to answer some of these questions. What is the GastroSam, to start with? This is a phase 2 randomized clinical trial that is trying to generate evidence to improve the management of dehydrated children with severe acute malnutrition. Why? I think it's quite obvious, but let's try to go a little bit further. We know that children with severe acute malnutrition have diarrhea very often, and for those that come to the hospital with severe dehydration, case fatality rate is very high. So again, super common, and it's a major cause of mortality in many settings, including our setting. As we said, rehydration management is controversial. We know that we need to restrict IV fluid, wait longer than for normal children, give less, give slower. But actually, these recommendations are basically expert opinion. There is very little evidence to back this up. We are using Resomal rather than ORS, and it's a bit the same. Based on expert opinion, very little evidence. There have been 2 systematic reviews in 2017 confirmed that these recommendations don't really come from evidence. So should we actually keep going that way? About the study, who is involved? We had the great opportunity to join a multi-center study run with other institutions. First of all, the Imperial College of London, the Wellcome Trust, KEMI here in Kenya. So we are joining 2 other countries that are already also including patients, Kenya and Uganda. MSF is joining with 2 projects, one in Nigeria, Medjugorje, some of the participants of the study might be here, and Magaria in Niger. How does it work? I don't expect you to read the study algorithm, but if you are interested, it is published, so it can be found online. But very quickly, patients coming from 6 months to 12 years to our centers with severe acute malnutrition and diarrhea and dehydration will be randomized in 3 different groups. Those with severe dehydration, first group will receive, first of all, if they have a shock, they will receive a bolus of 20 milliliter of Ringer lactate, and then they will go with Plan C, as is defined for normal nourished children. So the 100 milliliter in either 3 or 6 hours according to age. This is the first group. The second group will receive 100 milliliter in 8 hours, regardless if they have shock or not. The third group will receive the standard WHO protocol as it is defined today. So if they have shock, 50 milliliter of Ringer, repeated twice if needed. And then basically oral rehydration with Resomal. For those that are either improving from severe dehydration or coming with or moderate dehydration, they will be again randomized in receiving Resomal or receiving ORS to also try to address this question. So what are the expected outcomes? Well, first of all, mortality. In those receiving IV line with the 3 protocols as described, what is the difference in mortality? Which one is the approach that reduces mortality the most at 96 hours? For those receiving oral rehydration, we will assess the change in sodium levels at from 0 to 24 hours. Secondary outcomes will be electrolyte abnormalities, severe adverse events that might happen, and survival at day 7 and then day 28. Your next question will be when the results will be available. The study is currently ongoing. We do expect to finish recruitment by the end of this year. So most probably 2025, we will have some results. Thank you. I'd like to thank Mark Lee, that was supposed to give the presentation, could not be with us today, but I know that he's following from home. So thank you very much. And thanks to you all.
Thank you, Roberta. Now we go to the speed posters. Hussein, Lucille, you can come forward. Michael, and Michael? Yeah.
Hello everyone, my name is Hussein from Yemen. We do a research with our college, Sulan Yanj and Marina Gonzalez. She is not here, Sulan Yanj. Other authors which I cannot mention them. Nearly half of the deaths of these children under 5 are linked to undernutrition. I can have, do you also have an ITFC inpatient therapeutic centers in your mission? Are you also trying to bring the mortality rate to low? We have been in the ITFC for 8 years. This is the first conducted study analysis in systematic way in our inpatient mortality risk and how the compliance are we toward the nutritional protocol. We will share the analysis finding and our recent implementation and the improvement that comes after. If you find this relatable, comes to our poster and you are so welcome.
Good afternoon, I'm Lucille and I'm physiotherapist. Our poster is talking about a mission in Yemen. It's a pilot project who aim to assess needs and to implement pediatric physiotherapy activity. It shows some of the risk factors for children to develop developmental delay, mainly among malnourished children. You will also see the result of the screening showing that almost 40% of the patients between 0 and 3 years old are already presenting neuromotor delays before hospitalization. You will see the strategy for implementation and the results. This topic will need further investigation, but it's a very interesting start. Thank you.
Hi everyone. Have you heard of a disease that can kill in 2 weeks? That's Noma disease. Noma disease is a devastating disease. It's a rapidly spreading disease of the oral cavity. And if you do not seek treatment in 2 days, in 2 weeks, you see that there's a 90% mortality rate. And it's predominantly among children that are 2 to 6 years old. There is limited understanding of the epidemiology of Noma, so we sought out to estimate the prevalence of any stage of Noma in a pediatric population. We found out that malnutrition is highly linked with gingivitis. 1 out of 40 of these hospitalized patients had signs of gingivitis, which is the warning stage of Noma. And these patients had not had oral health care in the past 1 year. So we thought about it, that if there is, if the lack of access can underscore the reason why we do community oral screening and health and oral screening in our health and nutritional services, we'll be able to prevent Noma. I'm Michael Olale, the Noma epidemiologist. If you want to learn more, please see me at the posters.
Merci. Bonsoir à tous. Je suis Dr Farouk. Je suis investigateur clinique. Je suis avec MSF et je travaille avec l'équipe tactique. Je serais très heureux de partager avec vous notre expérience en matière de diagnostic de la tuberculose pédiatrique dans un contexte de ressources limitées. Tout le monde va se dire comment sûrement. Et il s'agit de la mise en œuvre de 2 algorithmes d'aide au diagnostic de l'OMS, donc pour le diagnostic de la tuberculose pédiatrique, que nous avons implémenté au Niger, dans un projet médico-nutritionnel de MSF, basé à Maradi. Il s'agit des outils qui accordent une importance particulière à des symptômes cliniques avec ou sans confirmation bactériologique. La radiographie peut être nécessaire, mais pas aussi une obligation. Alors, cette stratégie tendant à une certaine déconcentration, donc, sinon décentralisation en matière de diagnostic de la tuberculose, nous serons très heureux de vous accueillir au niveau de notre coin afin de vous donner l'essentiel des détails en matière de cette stratégie qui a eu un impact considérable au niveau de ce projet. Alors, je vous remercie.
Merci. Thank you so much. So now we'll take a 10 minutes break, unfortunately. With apologies, when you have tea, you can bring it back to the room with yourself. And yeah, thank you so much. We'll be back quarter past. We'll continue. We have a live demo on nutrition tools in MSF. Yeah. Anna Valori, one of our pediatric advisors, and Samuel again. Welcome.
Shall we? Hello. Yeah. I'm Anna Valori. I'm one of the pediatric advisors for MSF Spain, or OCPA, and I am based in Barcelona. Good afternoon.
Welcome back again. If we can settle very quickly, it will be very good for us. This is Samuel Kopi, nutrition advisor for MSF Spain, based in Nairobi. Thank you. Anne, so what are we having today for presentation?
Yes. So today we are presenting a package of 6 standard of procedures, or SOPs, and a toolkit to integrate nutrition into emergency response intervention or preventive interventions. What are those? Those are mass vaccination campaigns, what we call one-shot interventions, measles or cholera outbreaks, malaria emergencies, also interventions for newly displaced populations. You can see there all the documents. But Samuel, why have we worked on this?
Yeah, basically what we are saying, in most of our area of operation, there is a lot of emergencies, and there was a need that we need to develop tools that will help us. The main objective is just to integrate nutrition, preparedness, and response into the activities that we are doing under emergency. So, Anne, how do you plan to do this?
Yes, so we plan to help or facilitate the field team's work when they are preparing this kind of intervention, very specific interventions, with these SOPs that are or were intended to be practical and ready to use. And they were developed in collaboration with vaccination advisors, nutrition, obviously, also NTDs, NCDs, and also including members of medical operations in different regional emergency response teams. But then, for who? Like, who is the target for this?
As indicated earlier, we are looking at the emergency team that implement activities within a very short time, and they want something that are very ready. So we are looking at emergency response team where in West Africa there are several emergency teams. In African countries there are so many emergencies. Oh, sorry. Yeah, we are saying that. Okay. Sorry for that. We are saying, whom are we targeting for these kind of tools? So the main people that we are targeting for these SOPs is people delivering emergency response. So we are looking at the emergency, mobile emergency response team in various places within the field. We are also looking at emergency units that do a lot of emergency work whenever it's happening. Like right now, we have Sudan, they're doing a lot of emergency response. We have so many countries, Gaza, that they are doing emergency response. So those are people that we are looking at. And also during our regular activities, you find that some of the OCOPs, they are maybe when we are doing mass vaccination. So during our regular activities, we integrate these OCOPs that are ready to use. So Anne, can you tell us a little bit more about them?
Yes, so I will just really fast navigate you through one of them. This is the mass vaccination campaign SOP. And I will only show you that there are different sections. So the first on the purpose, the second one on different definitions for this specific intervention that are important. Then you go for the third section into the actual procedures that are recommended to carry in this particular intervention, with more details for this. Sorry, there you can see that you have a table, so it's really practical, ready to use, easy to use. Then we have also health promotion recommendations. And then the tools and equipment, everything that is recommended has an annex with a toolkit that will give you everything you need to carry on these activities. And then the references, that's the last. Voila. Then how can we access these SOPs, Samuel?
Okay, fine. These SOPs, they are readily available in our SharePoint, where we are looking at the nutrition working group, SharePoint. They are available in 3 languages. We are talking about English, French, and Spain. All the tools were developed internally within MSF Spain, and the team are planning to implement very soon. We have just completed on the tools, and they are ready. So we are planning to implement very soon. We believe that it's a good example of transversal and the integration, where we are integrating nutrition and health in all our programs, and we have a ready-to-use tool that we can pick and be used readily. We are saying that if you want to use it, just talk to your nutrition advisor who have been in any OC. We have this nutrition advisor that we have been working together onto this, developing these tools. Talk to them, and also talk to the medical operation coordination team, and they will help you on how to implement them. Do you think you have something to add?
Yes. I would just like to mention that this was all coordinated by Montse Escruela. She is our nutrition advisor. She wasn't, unfortunately, able to make it this time, but she has been part of all the recent Pediatric Days, so we would like to acknowledge her, recognize her. And lastly, if you want to check them out, they are printed in the booth of the Pediatric Nutrition and Nursing Care groups outside, and you can take also one home. We have quite a few. And if you have any questions, don't hesitate to reach out to us. We'll be around, Samuel or myself. Thank you.
Thank you so much.
Thank you, Samuel and Anna. So we'll continue our sessions. The next will be fly on the wall. We have a bit of changes on the speakers. So we'll have 2 online virtual speakers, Grace Kichuchi from the Ministry of Health, and Mercy Rocaspana, MSF Emergency Health Advisor, will be joining us online. And we have people from UNICEF and WHO to discuss the next topic with us. Carly DePoli will moderate the session. Betty Laniero will also do the discussions. She will be the one replacing also the missing one, and also part of the discussions. Yeah, sorry, Betty. Sorry. Jacinta Achen. So it will, we start with Betty.
Yeah, presentation. Okay.
Okay, good afternoon, or good evening, whichever, wherever you are. So, my name is Dr. Betty Lanyero. I am privileged to be amongst very distinguished guests and all of you. So thank you very much for the invite to make this presentation. I work with WHO, based here in Kenya with the regional office of Africa. I'm going to make this presentation basically looking at the WHO guideline on the management of acute malnutrition that was released towards the end of last year. This presentation, actually, I'm making it on behalf of my colleague, Alison, who unfortunately fell sick this morning. We wish her a quick recovery. All right, so very quickly on this. Let me see how this works. All right, so the new WHO guideline, if you would like to scan that QR code, you'll be able to access it online with all the details. Today's presentation will basically focus on just giving an overview of or highlight of how, or the process that WHO goes through as far as making the recommendations or the guidelines is concerned. So just before we move on, I want to acknowledge the key people who were at the forefront during the preparation of this guideline. We had the WHO steering group members, and then we also have the guideline methodologists who were from the University of Stellenbosch University. So, how does this work? Okay, I think I get it now. Just before I go into the details of the guideline, if you look at the trends as far as acute malnutrition or wasting is concerned, we see a general a stagnation as far as the decline as far as the children who are affected by wasting, compared to other parameters such as the stunting or the underweight. So one of the key interventions or steps that was taken globally was to have the global action plan on wasting. So here in the global action plan of wasting, we have a number of actions that are outlined that are supposed to support the acceleration of all the different agencies and all the different governments in terms of addressing wasting. And to coordinate this, we have the 5 UN agencies taking lead in different aspects. So this includes WHO, UNICEF, FAO, World Food Programme, and UNHCR. Now, specifically for WHO was to look at WHO committed to ensuring that we review the available evidence or science, examine the programmatic experience and approaches that are ongoing, so that we come up with a comprehensive guideline that would support the acceleration towards reduction of wasting. So this is the background to having this guideline. All right, so late last year, we had the 2023 guideline on management of prevention and management of acute malnutrition, or what we can say wasting, and those with nutritional edema. Now, what is interesting about this is we see a widening in terms of the scope of the guideline coverage. When we see that 2013 guideline, that was the last one that was released by WHO, majorly focused on severe wasting amongst children from 0 to 59 months. Now here in the new recommendation, we are extending to see that we also include infants, not only those who already have malnutrition, but those who are at risk of poor growth and development, so that we are able to capture them a little bit earlier and prevent the malnutrition. And then secondly, for the first time, we are including the management of moderate acute malnutrition. And as we know, among those who are wasting, those with moderate wasting are usually a very huge population. So if we are able to improve our management for this age group, we will reduce the number of those who will have the severe forms. Now, the guideline not only focused on the management, but also looked at available evidence as far as prevention is concerned. So this time round, the guideline is called Prevention and Management of Wasting and those with nutritional edema. So we will not go into the specifics of the overall guideline, but just to highlight that it has 4 sections. One is on the infants who are less than 6 months at risk of poor growth and development. 2 is on the infants, management of infants and children 6 to 59 months with wasting or nutritional edema. Then we also now particularly look at the post-exit interventions after recovery from wasting. And then the 4th section is looking at the prevention of wasting and nutritional edema. Now, the process, it is really a long process when it comes to eventually getting these recommendations. And there is a whole team of people who are involved in this process. Now, particularly for this guideline, we had about 27 external experts with a broad range of technical skills, expertise, not forgetting to ensure that there is gender balance as we looked at this. Now, the guideline development group had very specific functions. One was to determine the scope in terms and prioritization of the questions to be addressed. I believe if we open the floor right now, everyone would have a question as far as management of malnutrition is concerned. But the question is the guideline development group needs to be able to prioritize which is the most critical question that should be addressed. They also have the role of reviewing the available evidence. And then secondly, is to formulate this evidence into recommendations that then the population or all of us can be able to use. Very important always is that it's important for them to always declare any interest or conflict of interest as far as the contributions are concerned, such that we limit the bias and when it comes to the decision-making process. How specifically how do we get to these recommendations? There is a process. What we've learned over time is that the development of the guideline needs to be a collaborative process. It needs to be transparent as far as the decision-making is concerned, and we need to use established or standardized methods as far as making the final recommendations are concerned. We all agree that evidence is very essential, and evidence is always growing and changing. I was very happy to listen to the different research and documentation that the colleagues presented just previous to this session, and congratulations, first of all, to the wonderful work that you're doing. So we do have what we call the grade process or the grade approach. This is basically grading of the recommendations, assessment, development, and evaluation of this. The very important thing here that we need to know is that this grade is a very common and sensible way in which we try to determine the certainty of the evidence, and then look at how strong this evidence is in order to be included in the guideline. There is a decision-making framework which has close to 9 different areas that need to be considered for every question that is put on table. We look at how desirable are the effects that the evidence is presenting. What are the undesirable effects? What is the certainty of this evidence? Does it actually represent the population? Can we extrapolate this? What are the values? What are the resources that are required to implement, let's say, new recommendation from a different research? Many times if we recommend something and it is not cost effective, believe me, no one will implement it. So these are some of the things. Look at equity, look at acceptability, look at feasibility of these recommendations or evidence as far as making the recommendations actionable. So I want to take you, so during this guideline development process, we had about 16 questions that were reviewed, that were prioritized with different sub-questions. And out of this, we were able to come up with 21 recommendations. Out of the 21 recommendations, 14 of them were actually new, based on available guidance or evidence. 7 were updated from the 2013 guideline. And then we also now had the good practice statements that should improve the care at facility level. Now, specifically in this guideline, we try to be as pragmatic as possible, sensible, and see that whatever it is that is being recommended is practical in various contexts. Now, the guideline questions were quite broad and quite many. When you go to when you scan the QR code, you'll actually be able to see what were the different questions in detail. I will not go through that right now. I want to just take you through an example of one question. This was on the dietary management. Okay. Dietary management of moderate acute malnutrition, of moderate wasting. So we had 2 questions. So the question here was in infants and children 6 to 59 months with moderate wasting across different settings and contexts. The question is now, which children require the specially formulated foods? What is the effectiveness of the different specially formulated foods versus the non-specially formulated interventions versus other approaches? So I think you can just see the extent to which you must research all the different options. The second question was, in infants who are 6 to 59 months with moderate wasting, what is the appropriate dietary treatment in terms of the optimal type, the quality, and the duration? This was the second question as far as moderate acute malnutrition was concerned. Now, we know that there are quite a number of children, as I mentioned in the beginning, who are affected by wasting. And evidence was then identified as far as the SFPs were concerned. But we also saw that some of the specially formulated foods were quite expensive, and not all children necessarily recover on them. There was very limited data on subgroups to look at its effects in different children. So during the synthesis of all this, we can see that one, the guideline group was able to ensure that there is an equity lens, giving great attention and resources to the most vulnerable. We are not able to address the 31 million children. So what can we be able to use the available resources for? So targeting was very important. So using this, we're able to identify some child characteristics, some social areas, contextual factors that were then used to make the recommendation. So this is what the recommendation looks like. So at the end of the day, this is what the recommendation looks like. It's a strong recommendation with moderate certainty of evidence. So we recommend that we can prioritize the specially formulated foods together with counseling for the most vulnerable children. And these are some of the factors that you can look at. There are child factors here. You also have the social factors that are included. So I think what I'm trying to say is that there are several areas, and the framework that the grade criteria uses is very important as far as making the recommendations is concerned. When you get to that link, you will see that there are recommendations, there is evidence and different references that you can access that were used in development of the recommendations. So there is always a process of updating the recommendations, given that science is a changing area, okay? So new evidence comes in and recommendations can always be updated. And this comes with, we can come up with new guideline questions that need to be reviewed. We also look at some of those that where there was very low evidence. And this is where the team that was previously there, we see that we can now need this new evidence and research. And then we also have the WHO UNICEF technical working group that is always looking at these areas. I think this is my last slide. Yeah, thank you very much.
Is this on? Yeah. Come on, MSF, come back over. Look, it's typical, huh? She's standing away from everyone. Thank you so much, Betty, especially standing in for Alison. And I can tell you, Alison is one of those people who can work through the plague. So if she's not here, it's for a reason. I was just laughing with Sophie about how I was with MSF for 10 years and still never managed to get a nutrition session in the Paediatric Days. But now we have one. We're very excited about it. And I'm so happy to have my colleagues here from UNICEF and WHO. And hopefully we have Mercy online and also our colleague Grace from the Kenyan MOH, who I think is having some technical difficulties. Actually, I'm going to go over here so I'm not blocking Mercy. Am I over here? You can all see her. Actually, I'll come back here. Okay, so we're just going to we'll have a little session now where we're not opening up necessarily to the audience, but you get to sort of get an insight into the discussions that we're having at the moment about the implementation of this guideline. So I'm going to ask a few questions to my colleagues and our colleagues online. And I'm going to start with Betty, who hasn't done enough work already. But Betty, so from the WHO point of view, and you talked about it already, there's been so much focus on integration of nutrition and health. And so in your opinion, your regional perspective, your country perspective, how can we actually make that happen at sort of implementation level? What do we need to make that happen?
Well, thank you, Kirili, and I think this is great. Excellent question. What we really need to see here is that recognize is the fact that the guideline is looking at a child health approach. And I'm very happy now that we have the nutrition section included in the overall Paediatric Days. Congratulations to the team. So this is really our first step, I think, as MSF, that is looking into the integration and looking at the entire child in totality. So how can we make this happen? One is that as the countries now develop their guidelines, we need to help bring all our colleagues on board, particularly the health colleagues, such that we do this together. We integrate. The previous speaker showed us all the tools that they have, so they are already integrating. So right from the guideline, the Ministry of Health level, at implementation level, let's work together with our health colleagues. Secondly is on the health information component. Our data, we don't need nutrition data to stand on its own and rotate in silos. So moving forward, I think it would be very important that we have this integrated. Similarly, for capacity building, mentorship, supportive supervision, let's do this in an integrated fashion and know that we are addressing one child. Thank you.
Thank you, Betty, so much. Such important messages, and I think it's something that we did try in MSF to work towards with Roberta and I, and now Kirsten and Roberta working together. So Jacinta, tell everybody a bit about how the UN agencies are collaborating together in terms of implementation and also with governments.
Thank you, Kirli, and it's such a great honor to sit and discuss with the team from MSF. And I just to acknowledge that I've worked in so many countries and I've collaborated on many occasions with you. And I think sitting here, it gives me that honor to share what the UN are doing. So me, I'm working at the regional office with UNICEF. And basically when it comes to the rollout of the guideline, we see the government in the driving seat. It has to be government-led. But of course, the UN agencies are there to support the work of the government. And I believe also the CSOs, which include MSF, will also join in that effort in supporting the national guideline to be adopted. So in terms of the collaboration among the UN agencies, Betty mentioned that we have at the global level, so we are supporting government at various levels, at global level, at regional level, and also at the country level. At the global level, we have the UNICEF WHO Technical Advisory Committee that really support in coming up with the guideline, the whole process that took place. But at the same time now, they have two priorities. And one is, of course, to come up with operational guidelines that would help countries to adapt this guideline. But at the same time, also, we have seen that we need evidence to be able to accept any of these recommendations. So there are research gaps that the global team also help, and they actually have to work with the regional team as well as with the country team. So this is at global level. But when we come to the regional level, we also do have a strong team, and these include also UN agencies, and when I said UN agency, I mean mainly UNICEF, WHO, WFP, but you also have FAO, you have UNHCR, and we have the partners that we work with. MSF is one of the partners. So in terms of what has happened, after the launch of the guideline last year, there was a collaboration we had 5 webinars across to present the new recommendations, have discussion, familiarize people with it. And then after that, we have had face-to-face discussions with many countries, I think over 12 countries. After this now, at the regional level, we have created the Regional Wasting Technical Working Group. And I hope Samuel will join from Nairobi in the team and bring that experience. And also other colleagues, I had Save the Children is in the house. We really want it to be a very consultative and participatory group that would support country offices. So the role of the regional office where I sit is really to support all the countries in the region and make sure that they are able to understand those recommendations and be able to implement it and support the government to adapt the national guideline. So we really have to support from that level. But all the work happens at the country level. So you know that is where the nitty-gritty happen. So really, we need to support government. And I know MSF is observer, but it's good to be in that technical working group, to be able to support, to provide evidence, so that when they are taking any recommendation, because it's a national guideline, so we have to have a say in what goes in that guideline. And really support the government, make sure that we come together. And I know that the UN agencies are supporting. It's a very complex process because you have to engage at national and subnational level and make sure that you bring everybody around the table. So also my plea is that when you go back to your respective countries, please support the process of making your national guideline to be aligned to the WHO 2023.
Thank you, Jacinta. That's already our call to action, first call to action from this session. Now to the slightly juicier parts. Kirsten, what does the new guideline mean for MSF? And Merce, you're not safe. I'll be coming for you afterwards. But still, tell me, Kirsten, what does it mean for MSF?
Kirli likes to stir things up. It's no secret that MSF has a history of being fiercely independent. We like to do things our way. We like to have a little bit of control. But as we can see here, we're not the only actors in global health, in pediatrics, in nutrition. There are a lot of actors, there are a lot of stakeholders. And so we really do need to be part of that. A lot of work has been going on. MSF level, the nutrition working group is pretty small compared to what's going on at the global level. And so we really do need to be part of and support this process. This is, of course, the intersectional viewpoint. Every OC is also fiercely independent and has their different ways of doing things. But this is an evidence-based process. This is a global process. Of course, as Jacinta has very, very importantly acknowledged, this is also a government-led process. And there's two parts of the question. They're supporting WHO and supporting the implementation of the guidance, but I think that just as importantly is supporting the country and the MOHs in the countries where we work, because malnutrition is not a new issue in many of the places where we work, unfortunately. National protocols for management of acute malnutrition have been around for quite a while in many of the countries where we work, and so I do really think that it's important for us to be part of that process. So not only to use those protocols, but to be part of the process of integrating the WHO recommendations into the process. Now, having said that, we know that the WHO guidance is not perfect. Nothing is perfect. It has many strengths, including the number of experts that were included in the guideline development process, including the fact that it is a very rigorous process, that it's evidence-based, it's not based on political willpower or lobbying. It really is a serious process, and so we can trust that what is in the guidance is based on the best evidence we have. Now that's, I guess, another part that's a weakness also, is that it is based on available evidence. And we know that a lot of questions around nutrition don't have a lot of evidence behind them, that the evidence is weak. It's weak because a lot of the areas where these issues come up with are hard to do research in, and because contexts are very different, and so it's sometimes hard to generalize what works in one context might not work in another context. There are also gaps. As Betty explained, the guidance can't answer all of the questions, and so there are gaps. And I think that we need to remember this. There are gaps that we can help to fill. I think that a gap that we have already really, really helped to fill is the health meets nutrition gap. A lot of the previous guidance was very, very nutrition vertical. We believe in peds and nutrition coming together, and health and nutrition coming together. We have pushed for that, we have advocated for that, and now we see that it's integrated into the guidance. We also believe in management of infants under 6 months, because we see these infants coming into our programs. We see that we can't just manage all of them inpatient, and so we've pushed for more guidance in that, and so here we are. It's there, so we can be part of the process, and there are also many parts of the guidance that we've been working on. The management of MAM, we know that that's something that is becoming more important to MSF. We don't always have all that guidance in our protocols, so it can be really a give, it should be a give-give experience.
Thank you, Kirsten. And Mesut, from your side, I know you've memorized the whole of the 201 pages of the WHO guideline. So from the operational perspective, what are your thoughts on the guideline in terms of what you think is going to be important for MSF to operationalize and also difficult?
Yeah, I think Kirsten summarized quite well the position of MSF. But I mean, from operational perspective, no, and mainly thinking on emergency situations, I think it's good that in the guideline, I mean, as Kirsten said, no, I mean, there is a highlight on the moderate acute malnutrition, which we are very interested in this group, because for us has been always a challenge, especially in emergencies, because we really think that I mean, the prevention of the severe malnutrition is very key in emergency situations. So the support to the mom is important. So here in this guideline, they make very detailed recommendations with which specific products to be used. I think this is very interesting, but somehow we saw also that it could be a bit more complex, the implementation of some of recommendations, because it's making different categories among the moderates, different diagnosis criteria. So, I mean, we need to see how this would be really feasible, and how the teams could understand new rules, new criteria, new protocols, no? So we are, I mean, reading very detailed all the guidelines to see how we can adapt to this, because we really think that the as simplest as possible is the best, no? Especially in emergencies. Then another concern is about the supply. I mean, who is going to supply this? I mean, is there any change? Is WFP who is going to supply the support to the moderate? Is UNICEF? Is going to be MOH? I mean, who's going to do the adaptations on the national protocols, and who is going to provide with the products for the moderates, you know? And then I mean, something interesting also is about the reduction of this proposal of reduction of the doses for the SAM, for the severe cases, according to the improving conditions. And then the last thing I wanted to say is that when reading the guideline, all the chapter about the babies and the sick, we think it's very difficult to read this chapter without the nutritional support to the mothers. So I think that is another guideline, let's say in the oven, no, being cooking, but we are waiting for this guideline to read both together, because we think the supplementation or the support to the babies and the sick, without knowing if there will be new recommendations for mothers, is a bit difficult, not to have the global picture and to see how we can better support to this population, because we see more in emergencies, and depending in of course in which emergency we are, in which situation, this group is very vulnerable, the under 6 and together with the mother. So let's see if this guideline comes soon, and then we have wider picture of the nutritional support to this population.
Thank you, Mercy. You have read it. I'm impressed. Thank you so much. Jacinta, do you just want to say a quick word about the strategic approach with WFP and UNICEF in terms of Mercy's question?
Yeah, so yes, the UNICEF and WFP, they have come together, and basically is with the support from USAID to with a few countries. I think there are 4 countries, 3 in this region, but in the other regions, to see how they can pilot, especially looking at the high-risk mom, how we can be able to provide some services to them, but also focusing on the prevention. Really, we have to come up with a package of prevention services that can be provided. So this is it's a pilot that is starting, and we hope that with this pilot we can be able to share learning with countries, and we'll be inviting all of you, whether it's in Wakaro or it is in West Africa, or in Eastern Africa, to share lessons so that you can also be able to implement it in your program. But at the same time also, it helps you with whatever you're doing, that maybe we could also bring you to share your lesson, because I know there are so many pilots being done by MSF. So we'll create this platform where there is opportunity for sharing. So WFP and WHO and UNICEF have started this strategic approach, and we hope we'll be sharing some lesson in 1 year's time. I wanted to add something on the simplified approach. I know when we look at the WHO guideline, most partners do ask what happened to the simplified approach. There is a full briefing note that has been developed between UNICEF and WHO, and it's there on the online site that has been shared. You can read that. But I think the push now is to have a collective effort with all the partners, UNICEF, WFP, WHO, to align to the WHO guideline 2023. This does not mean that you don't have exceptional circumstances, like in emergencies, and that has to be agreed so that you can apply those simplified approaches. But most of it within the guideline is captured. So I think when you want to apply the simplified approach, please have discussion within the countries, agree on it, have it time-bound. We don't want it perpetually. We want to stick to the guideline, but at the same time, when the circumstances call for it, you can always apply. I can give you an example. In Tigray, right now we had to use the simplified approach and use the expanded criteria to treat mom with RUTF. So you will find yourself in humanitarian situation that you have to apply this. We are not saying don't use it, but if you can even annex it to your guideline, it is good, because then there will come a situation where you have to actually bring it on board.
Maybe just also give a teaser that there is guidance coming for pregnant and breastfeeding women and girls, hopefully soon. I think maybe that you can speak to that, just to respond to Mercedes.
Yeah. So there is UNICEF guidance coming out on for nutrition for pregnant and breastfeeding girls in emergencies. And there is also part of the UNICEF, the WHO guideline, the antenatal care guideline from 2016. But it's actually only now they're starting to do some work on the implementation guidance of that, and that will be on the balanced energy protein in populations where there's a high rate of underweight. I should really stop speaking on behalf of WHO, shouldn't I, Betty? You're going to slap my wrist. but we do appreciate how needed it is, and that is such an important aspect of the guideline, was the mother-infant approach. Betty, with your long experience in WHO, just sort of for you personally, what are the areas in the guideline that you were really excited to see, that you were really happy, that you think are quite new and are really going to be game changers? I know you sort of touched upon them, but what are your game changers for implementation?
Wow. So I think the one thing about the guideline maybe that I would like to re-emphasize is that was very exciting for me, was to see that we're focusing on a child health approach. And I think this is, for me, is a very big message, not only to this population, but everyone else, that we need to look at the child in totality. Now, also in the guideline, we see the aspects of the management of severe acute malnutrition or wasting by the community health workers. in our different settings, we see that many times some children or caregivers are not able to reach the facilities. So if we are able to actually see that we build the capacity of our community health workers to support management at community level, I think this may be a game changer, and we look forward to looking at that. The other aspect is on the management of infants less than 6 months at risk of poor growth and development. This has really broadened the scope for infants who are less than 6 months, given that we are now, the aspect of prevention is critical, and early identification. So we are looking at those with preterm, those with difficulties in feeding, all those are now going to be included and identified, and we also identify how to manage them. I think maybe just to add on what my colleague said earlier, there is WHO, UNICEF is working on an operational guidance for this specific guideline management of wasting. And I think this will also help in highlighting or breaking down some of the recommendations that will support the implementation and make it easier. Yeah, thank you.
Thank you, Betty. Okay, so now I come to the bit where you're allowed to be honest. MSF likes a bit of tough love, don't they? Jacinta, what would be, in terms of some of your key messages, what would be your ask of MSF as we go forward, trying to implement these guidelines and overall trying to improve care for malnourished children?
Thank you, Kirli. Now this is Jacinta talking. But I think, thank you so much for, first of all, giving us this platform. And I would, of course, call upon you that let's work together. In different countries, I've signed an agreement with MSF where we had to give supplies and things like that. I think we really need to continue this collaboration in different countries. But also, I think MSF plays a really critical role. I've seen it in Ethiopia, in Dila, when 1 million people were displaced. It was MSF that stood to make sure that we couldn't even manage as UNICEF. So I just want to acknowledge that. You go in very difficult locations, and we have complementarity that we really have to acknowledge. I wanted just to pass one message which I struggle with, and that is the exit time. And this, I've seen it in Somalia, in South Sudan, in Darfur, and it's difficult. I know MSF come at the peak of the emergency, and you do great job, you bring a lot of stuff, but at some point, it's like, okay, time to go. And you have 3 months, and you know, it's exit plan. This is what we have, this is the inventory, and it's so difficult for UNICEF, I'll be honest with you, to pick it up. And I would really recommend maybe a longer time in terms of, you know, the exit plan. We can work together, but let's have a longer time for planning. And most time you leave the equipment and nobody knows how to use it. So this is being honest, and I've seen it in many countries. So I thought I have the platform, so why not share with you?
Thank you, Shinza. Reminds me of when I was a junior doctor, and they always said as soon as the patient is admitted, you start thinking about their discharge plan. So I think it's a really important message. And so Betty, my same question to you. What would be your sort of request of MSF in this process going forward?
Okay, I don't know whether I should be as honest as Jacinta, but I definitely will be. My request, or what I look forward to with MSF, is to, one, continue a collaboration with WHO. And the aspect of evidence generation remains very critical, given that you have boots on the ground, and what you bring to the table in terms of sharing what is happening is very critical, and this is the evidence that we need to make stronger recommendations and try to make sure that the evidence generation goes through the right processes such that it is considered. So stronger and continued collaboration with WHO, the evidence generation, and in the aspect of collaboration also alignment. Alignment, because this really helps the country to know that they are following. So if we have totally different protocols, picking up will be very difficult for the government, and yet they remain in the leading seat. So, yeah.
Thank you so much. Now, because our colleague Grace from the MOH wasn't able to join, there was some connection issues, I'm going to give two completely off-the-cuff, look at her face, two little off-the-cuff questions. And also because I was thinking about what Catherine was saying in the vaccination session as well. And I think it's something that we thought about a long time when I was in MSF. So for Kirsten and for Merce, we heard this little word prevention. Now and obviously it was such a big emphasis in the WHO guideline, and we know that there is, these 45 million kids out there that need management, but the ideal and why the emphasis on the infants was there, and why the emphasis on managing MAM for secondary prevention. So there is such importance being put on in every way you hear about prevention. And so what do you think within MSF could be a role within MSF towards prevention?
Thank you. So prevention often goes with the other naughty word, public health, right? It's hard. Prevention is hard. I mean, not that what we do isn't hard, but prevention, it's so big. Where do you start? Who do you start with? What happens when you leave? What do you start with? I mean, it's really big, so I think it's really scary. It's uncharted territory. I think that we are starting to do more and more of it. You hear us talk more and more about it, about this need to prevent. I mean, I think that even MSF's desire to start addressing moderate acute malnutrition is, in our minds, also prevention of SAM, a different way of thinking about prevention. I'm going to put my little plug in for under 6 months here, because I think that this is a population that maybe it's not so daunting, and yet we've heard all throughout today about the risk factor of being premature, of being low birth weight. We know that these infants are at risk. We know that their mothers are at risk. We know that this is a pair that is very, very vulnerable. We have them in our hands. They're born in our centers. We see them in the OPDs. We see them coming. I think that this is a key area where we can really intervene more and prevent them from falling off that cliff, because we've also seen them once they have fallen off the cliff. And we know that they're so hard to bring back. And so that's, I guess, where I would say we can start on prevention.
And Mercy, what are your thoughts? I know, Okba, you're usually a bit better than the others, aren't you, on that? But what about prevention? Where do you think MSF could have a role?
No, I think besides what Kirsty just mentioned, about is mother and child and the prevention for the under 6, I think this is very important. I think, I mean, we did prevention, and we are doing prevention in some context, especially in big crises. In Tigray, we did the blanket distribution. So in other places, I mean, we did the targeted or blanket distributions. And I mean, it's not something that we are doing everywhere, in every context, not systematically. But we think in some contexts, depending on the conditions and the characteristics of the crisis and the population, is very important to do this prevention. No? I mean, through a target distribution or a blanket or whoever. So we know now, I mean, in the guideline, they give different options, no, with the different products to use. And it could be, again, no, I mean, who is going to supply this? When you do prevention, of course, the number of children to assist is much bigger than the number of malnourished. So we are not talking about 100 cases. We're talking about 5,000 children, no, in a place. So the magnitude of prevention is quite big. So we need to balance always, no, the capacity, the operational capacities, and the benefits for the population. And and also thinking that we are part of a group of partners present in a place, no, including WFP, UNICEF. So I think that prevention is very important, specifically in some emergencies where providing treatment is very complex and is very difficult. So in these places, prevention is even more important. So yeah, we try our best. Let's see what we can do, but yeah, definitely. I mean, we are, of course, in favor of the prevention. Yes. Thank you, Mercy. Kirsten, you wanted to add something?
Thank you. I'm also going to once again use this opportunity that we have the pediatricians and the pediatric working group. I think we've talked about the intersection between health and nutrition and how excited we are that this is part of the WHO guidance, and we really need to not underestimate it as one of the preventive factors also. And this is an area, this is our battleground, right? This is where we're good. So I think that sometimes we try to seek way outside of what our comfort areas, and we start to think about, doing food aid and doing things that are not within our area of specialty, but providing healthcare is our area of specialty, and going out into the communities and making sure that we find these kids on the first day of diarrhea, not the 10th day of diarrhea when they're malnourished and dehydrated and they're in the hospital. Doing all of those steps to make sure that every children has access to adequate health care, and that we even think of following them up as outpatients. We follow up our children with acute malnutrition if they are ill. We have this tendency to say, okay, we've treated your pneumonia, you're cured, but it turns out that a lot of these children still die. And so maybe we also need to have better follow-up programs afterwards to make sure that they really are okay, to address some of these other factors that are going on in the household. But here again, these are children that these aren't hard things. I mean, implementing things are always harder than it seems, but we need to look within the scope of things that we can do and not be so afraid of prevention, I think.
Thank you. And Betty, you were saying you wanted to add something?
Well, I think we've mentioned it. We are already doing the prevention. When you look at the guideline, the prevention is the last section on this. And one of the key evidence-based prevention interventions is supporting breastfeeding. As pediatricians, as doctors, we have been supporting and protecting breastfeeding since time memorial. So I think we should continue on this. Do not be afraid on the preventive arm. And the collaborative effort between nutritionists and the clinicians, I mean, I can't say more than that, yes. So we are doing prevention. It remains very critical, and one of the targets, actually, of the Global Action Plan. We need to prevent wasting. Yeah.
Any final thoughts from you, Jacinta? No.
No, I just request you that when you go back to your countries, please look out for the various technical working group. I know MSF is maybe not a cluster partner, but you're observers and you bring your technical experts. So we call upon you. Please be in that seat and please provide your honest opinion in those discussions. So thank you.
Thank you. So I'm so grateful to Betty, Jacinta, and Kirsten and Mercy for coming today. I think the message that we keep hearing, and I think it is one that we've been saying for so long, is looking at the whole child. It's that prevention is actually good child health care, and that this is something that it's complicated, but it's not complicated. And to use existing protocols, to use IMCI, it's a good thing. Keep going with the things which have worked, and again, and looking at our mother and infant together. And indeed, like MSF, there's so much to bring, so please come to the table. And it's like they were saying in the vaccinations session, not just at the emergency moment, but before then, so that you can already be building those relationships at country level. So again, I'd like to say a big thank you again to all the panelists, and thank you, and we will pass back to Nicola. No, thank you. Thank you, everybody.
Thank you very much for the panelists. We are now very far from the end of the day here. Lucille, voices from MSF projects.
Thank you. Can you hear me? Yep. So the sound is working. Can you hear me? Okay, so hi again. I'm still Lucille, and I'm still a physiotherapist. And I'm very glad to welcome you all to my PED talk. To know a bit more about me, I've been working for 10 years with infants and toddlers. And right now we are super lucky because my favorite topic to talk about is neurodevelopment from birth to 18 months old. At the end of last year, I was in Haidan in North Yemen, working in an hospital supported by MSF and by the NIH. The mission was to assess needs and to implement pediatric physiotherapy activity. Let me introduce my dear colleague in the field and our pilot project.
I am a physiotherapist here at Haidan Hospital. I'm so excited to be talking about our amazing new neuromotor activity program for children with developmental delay. Our team, along with MSF, felt strongly about creating a program that went beyond traditional therapy and focused on stimulation through play. As physiotherapist, this was a new approach for me, but it's been incredibly rewarding. Honestly, at first, I wasn't sure how it would work, but seeing the positive change in children has been truly inspiring. We have treated over 100 children and conducted around 400 sessions.
Thank you, Zaid. So maybe the main question now is, why do physio cares about the first 1,000 days of life? Maybe it's because it's where it all starts. Being able to feel and then to move will allow the young child to explore the world and then to build up social, cognitive, and emotional skills. For example, a 3-month-old baby is able to grab toys in the midlines. Then his brain will understand that he has a left side and a right side that can be coordinated together. Soon, our baby will be 6 months old. Then he will be able to grab his big toe. Then his brain will understand that there is an upper body and a lower body. He will start to coordinate all the limbs together through next gross motor skill, rolling, crawling, sitting, standing, and every parent's biggest pride, walking. These first 1,000 days of life are the golden window for the brain to integrate all these gross motor skills. Then, if a delay is noticed, it's not necessarily linked to a neurological condition. It can be transitory due to environment, such as the condition of life in humanitarian settings, or due to lack of energy to produce movement, as we see in malnutrition. So what is this? You are looking at an extract of the Alberta Infant Motor Scale. This is our assessment to assess gross motor skill from birth to 18 months. Then, if a delay is noticed, providing early stimulation will have a better impact than waiting a few days to see, a few months to see how it goes. We would like to avoid accumulating delays since the very beginning of life. That's why we propose to our patient to do early neuromotor rehabilitation. For example, here is Ahmed. He's 6 months old. He's very small for his age. He's also very cute, but is not yet able to grab toys on the midlines, nor to grab his feet. Let's see a part of a session. As you can see on the video, this child is really, really cute. Now, as you can see in the video, I'm explaining how to provide support to this baby during tummy time. We want him to be able to push on his elbows and to hold the head. This is a necessary step before being able to crawl and even to stand. So we help him to feel this sensation of pushing on the elbows. He was supposed to be able to do it at 3 months old. Yep. He's cute. I think that's why the computer wants you to see him again and again. Okay, another example. Here is Amlak. She's 11 months old. She's also very small for her age, and she's not yet able to sit by herself nor to grab. Maybe we can wonder why. Let's see. As you can see on the video, this is also about pushing on her arms. She can't do it. She doesn't know how to do this movement. So Zaid will help her to push, and then he will move the toys on the side to stimulate pivots. This is the step just before being able to crawl. It will allow belt dissociation, but it's very useful to walk. In fact, the physio is organizing the environment around the child to help the brain to produce the right movement. I let the word to Zaid to talk about another aspect of the neuromotor rehabilitation. Sorry. Oh no, I don't let the word to Zaid. First, another video of Amlak. So you can see in this video, you will help her to stabilize sitting position, then to feel weight transfer on the right side, and to push on her arms. Now I let the word to Zaid, if I can. I don't know why the video is not working.
But the real star are the families. A big part of the program is teaching the mothers how to use the play technique at home. This empowers them to continue their child recovery journey long after they leave the hospital.
And that's true. A major part of the neuromotor sessions are about parental coaching. Here are just a few numbers to figure out how important it could be to do a proper neuromotor screening in our hospitals. In Haidan IPD Pediatric and Inpatient Therapeutic Feeding Centers, neuromotor screening showed that almost 40% of the screened patients were presenting delays before hospitalization. You can also see how screening modified the activity orientation. We switched from 3% of the activity dedicated to neurostimulation sessions, mainly for neurological cases, to almost 43%. So this is now the major part of the physio activity in that hospital. If you want to know more about data, don't forget to come and see our poster about this pilot project. A few words from Zaid to conclude.
The children are healthier and happier, families are more involved, and the staff feels more motivated. I'm so proud to be a part of it.
And I'm very proud too. At the end, the goal was to set up the activity and to help the team to be autonomous using local resources. They did a great job and they are following it very carefully. I will be glad to go back there again this year and to see how it goes. Talking about local resources, here is a 2-week-old picture showing a play session in Adré, in Chad. There were no physio yet in this program, but we started to implement gross motor skills stimulation and play therapy with the health promotion team, something that may give ideas to a lot of projects. Thank you for your attention.
Thanks so much, Lucille. I know it's really hard to be the last speaker of the day, but she handled it well, giving us cute baby pictures and videos to keep us entertained. But really lovely program and really nice to hear some success stories. So just a few things to draw your attention to as we finish. You may have already seen a couple of features on the app. The first one being a quiz. So there's some questions with points throughout the 2 days if you want to complete the quiz. I can't guarantee there'll be any prizes, but just the accomplishment of scoring high. But more importantly, there's poster voting now available on the app. And there's 3 different categories you can vote for. Let me just pull them up. Which poster is the most colourful and visual? Which poster is the most innovative? And which poster is most likely to change your practice? So please do look at the posters through the app so you're getting all the online ones, not just the printed ones for those of you here face-to-face. And please put in the poster number for each of those categories, and the winners will be announced in the afternoon tomorrow. So reminder, tomorrow we start at 9, just so we don't have the dramas of today. Please come a little bit early so we can start on time. And then now we will have our networking drinks. They will be located in the restaurant, which is where we had lunch. Each person will be given 2 drinks vouchers on your way out. So where you registered, actually no, it might even be right at this door, you'll be given 2 drinks vouchers, and there'll also be some snacks and canapes across there. So I know it's been a long day, but I hope you've all found it as enjoyable as I have, and we look forward to seeing you all bright and early tomorrow.